Good morning, everyone. Hopefully, all of you are fine. So, today we'll be talking about urology first, and then we will begin with hernia. So, our today's target would be to complete urology and hernia. Okay. It would be possible, just we have to be on toes for our urology. Urology is part which is there. It is important for your upcoming examinations, as it has been seen in the recent pattern of examinations. But it is easier also on the other hand. ठीक है, not very very complex. हाँ, थोड़े कुछ टॉपिक्स इधर उधर कॉम्प्लेक्स लग सकते हैं. So that's the reason, beta. I would definitely pace up in urology so that I get enough time for hernia. Clear about? If you have went out at any point of time anywhere, you can immediately ask me. No issues with that. Okay? Or even in the break, you can message me. Okay? Very good morning, everyone. Chalo. Hopefully, all the audio visuals are clear. And let's begin with the class. So today we will start with urology, beta. If I talk about urology, we know urology means actually, beta, the urinary system and the male genital system we are going to study about. Okay? Let's start with the urinary system first. In the urinary system, beta, we know the main function is definitely excretion or the urine production. For that, we have a pair of kidneys. This pair of kidneys, which is there, but as you are able to see, will have a capsule outside it, and then there will be this outer part called as the cortex. Then there will be this inner part, beta, in triangular formats. These are known as the medullary pyramids, beta. Okay, so the outer part is cortex, the inner part is medulla, and medulla is in the form of pyramids. Now, in the cortex and medulla, beta, we have the basic functional unit of a kidney known as the nephron, beta. Nephron definitely has a tuft of capillaries known as the glomerulus from which the blood passes, and there is filtration which leads to formation of urine in the Bowman's capsule, which further passes via the PCT, loop of Henle, DCT, and ultimately the collecting ducts, beta, right? That is important. From the collecting ducts, this urine collects into the ducts of Bellini, beta. Yes, multiple collecting ducts come together to form the ducts of Bellini. From the ducts of Bellini, beta, now these ducts of Bellini will come together to form these minor calyces. Each kidney is going to have, beta, around 6 to 7 minor calyces. Okay, and then these minor calyces come and combine to form the major calyces. Okay, so all these minor calyces which are there now, they come together to form the major calyces, beta. There are around 3 to 4 major calyces in each kidney, beta. There are 3 to 4 major calyces in every kidney. Now important is here you are able to see all these 3 to 4 major calyces have joined together to form this part called as the renal pelvis, beta, right? This part which I've highlighted right now is the renal pelvis. Once that renal pelvis is formed, from there the urine will be drained into this muscular tube over here known as the ureter. That ureter basically connects, beta, the kidneys to the urinary bladder. Then the bladder which is there, beta, it is made up of detrusor muscle, especially, yaad rakhna. And then below the bladder we have the urethra, which is the passage of urine, beta. Clear it? In the urethra, beta, we are going to have two urethral sphincters. One is the external urethral sphincter, and the other one is the internal urethral sphincter, beta, which controls the passage of urine, which is clear. So that is the basically the outline of the urinary system. Now, if I talk about the kidney, beta, I hope all of you are quite aware that all your urinary system, especially the kidney, this was the question, it develops from which embryological structure? So we have three germ layers: ectoderm, endoderm, mesoderm. So yaad rakhna, the urinary system, especially the kidney, develops from the mesoderm, beta. Now what is that part of a mesoderm called as which develops into the kidneys? That part of the mesoderm, beta, which develops into the kidneys is either called as a metanephric blood. Okay, either it is known as the metanephric bud or the metanephric blastema, beta. Okay, either you can call it as a metanephric bud or metanephric blastema. That has to be remembered, and it is actually a derivative of the mesoderm. It is actually a derivative of the mesoderm, beta. Now important is, where do these kidneys develop? So yaad rakhna, beta, that these kidneys which are there, they develop from the metanephric blastema or the mesoderm, but they do not develop at their normal adult position, beta. Yes. So where do they develop? They usually develop in the iliac fossa, beta. Yes. So please remember, ये जो kidneys होती है, beta, they mainly develop in the iliac fossa. That has to be remembered. They develop in the iliac fossa. That has to be remembered, beta. Now important is, once the kidneys development is complete, beta, then definitely these kidneys are going to ascend up. Ascend up मतलब ऊपर चढ़ जाएंगे, beta. So these kidneys from the iliac fossa will ascend up definitely to its adult position. And what is the adult position of a kidney, Viche? Okay, the adult position of kidney is going to be from T12 to L3 beta. The adult position of kidney is going to be between T12 to L3. No issues with this, anybody? That is important. Now another thing that you have to remember beta is nothing else but the hilum of the kidney. So yaad rakhna, at the hilum of the kidney beta, what we'll be able to see? Sorry, at the hilum of the kidney beta, we will be able to see vape basically. What is vape? So hilum is this entry point of the kidney beta, and from that entry point of the kidney beta, there are certain structures which will enter the kidney. There will be certain structures which will exit out the kidney beta. So the mnemonic to remember the arrangement of the structures at the level of hilum is going to be wave. What does that mean? So anteriorly beta, if I go from anterior to posterior, okay, if I go from anterior to posterior, the first one is going to be renal vein beta, okay, V for vein. Next, followed by that beta, the second structure which is going to pass behind renal vein beta, we have the renal artery beta, okay, and followed by that beta, behind that we have the renal pelvis bache. Okay, so do remember that the arrangement which is there at the level of renal hilum, okay, from anterior to posterior, okay, from anterior to posterior, you have to remember it is first the renal vein, then it is the renal artery, and then it is the renal pelvis beta. Okay, so that is important to be remembered. Now if they ask you beta, if you have to do a renal transplantation in a patient or a kidney transplantation in a patient, then which kidney do we prefer? We know beta, in a patient of renal transplantation, obviously we have to prefer the left kidney beta. Why we have to prefer the left kidney? The reason we prefer the left kidney bache, because definitely the left renal vein which is there, that left renal vein is shorter or longer? The left renal vein is longer beta, and as the left renal vein is longer, that's the reason definitely you prefer taking the left kidney beta. First thing. Now when you have taken the left kidney, where do you place it? Anybody? What is the site of positioning the donated kidney? Anybody? The transplanted kidney which is there in the recipient, it will be placed at which site? Anybody? Let me know that. Okay, we'll discuss about that further also, don't worry. Now important is the next part which is there beta is going to be the ureter. Okay, ureter is what? As I've told you, it is nothing else but a pair of the muscular tubes beta. Sorry. Sorry. It is a pair of the muscular tubes which connects the kidneys to the urinary bladder. Okay, so that is what is called as a ureter. Approximate length, as I've told you beta, it is approximately equal to that of the esophagus. Yes, esophagus, duodenum and the ureters have the same length, approximately 25 centimeters beta. That has to be remembered. Okay, now if they ask you beta, the next one, that is nothing else but the urinary bladder. Now if I talk about the urinary bladder beta, urinary bladder is what? It is basically a sac which is made up of, okay, sac which stores the urine beta, and it is made up of which muscles? As I've told you, it is made up of the muscles known as the detrusor muscles. A lot of people tend to get confused beta between the dartos muscles. याद रखना बच्चे, dartos muscles are usually seen in the scrotum. ठीक है, detrusor muscles are usually seen in the urinary bladder beta. ठीक है, so that is important. Now here you have to remember, on the posterior surface of the urinary bladder beta, we have certain structures present. And these structures on the posterior surface of the bladder will be the vas deferens, the seminal vesicles beta, and the ureters. Yes, the ureters usually open on the sides, you might have seen, right? The ureters usually open on the sides of the bladder. So they open on the sides, okay, but on the posterior wall basically. So they actually open on the posterolateral wall of the bladder. Okay, so that is important. So on the posterior surface of bladder, what are the structures which are present beta? So do remember, the structures which are present on the posterior surface are going to be the vas deferens, the seminal vesicles, and the ureters beta. These all structures are going to be present on the posterior surface of the urinary bladder, and hence all the bladder operations which are there beta, these bladder operations are usually done via which approach? Anterior approach or posterior approach? Obviously, if posteriorly there are so many structures, always we have to go beta for the bladder operation via an anterior approach. And when we do a bladder operation beta via an anterior approach, what is that incision that we take on the skin known as? So bladder is the lower abdominal organ, right? So for this lower abdominal operation basically, what is the incision that we take is known as? So the incision that we take beta is classically known as the pan and steel incision beta, which is also known as the bikini incision, right? Because it is cosmetically better. The fan and steel incision or bikini incision which is there. You might have heard this incision for a lower segment cesarean section beta. The same incision is also used beta in a bladder operation, right? The same incision is also used in bladder operation. I told you now, for LSTS, when you do a phalansteal incision, then after cutting all the layers beta, you are able to see the bladder in front of you, and then you have to retract the bladder down. Now a question from previous year, please tell me, we have discussed this, which is the retractor to retract the bladder down? Which is the retractor with the help of which you are going to retract the bladder down? Okay, the next part which is there beta, it is the urethra. Basically we know urethra which is there, it is actually different in males and females. Yes, the male urethra is pretty much longer beta, around 20 centimeters in length. On the other hand beta, the female urethra is somewhat shorter, around 4 centimeters in length only. Okay, the male urethra which is there, it is 20 centimeters and it has multiple parts to it beta. Okay, so let's talk about that. If they ask you, first of all, write down that which is the narrowest part of the urethra. So yaad rakhna beta, as we know that definitely this is the urethra, definitely, right? You are able to see this is the urethra. So the narrowest part of this urethra is this one beta. Yes, the external opening of the urethra which is there beta, that is actually considered as the narrowest part. So you can write down the narrowest part of the urethra. If they ask you, the answer has to be the external urethral meatus, or external urethral opening, whatever you call it as. So external urethral meatus beta is going to be the most narrowest part of the urethra. Followed by that, if they want the part only, then you can mark it as membranous urethra. Yes, the second most narrowest part which is there beta, it is going to be the membranous urethra. So these are considered as the narrow parts beta in the urethra. If they ask you bache that in male urethra, definitely what is the length? As I've told you, the male urethra is of almost 20 centimeters in length and around 6 to 8 millimeters in diameter. Okay, and we know that the male urethra which is there, do remember the male urethra which is there beta, it has basically two parts. Broadly it is divided into two parts beta. What are these two parts? So see, the part which is lying inside the pelvic cavity beta, jo part which is there in the pelvic cavity near to the urinary bladder beta, which has just started from the urinary bladder, that is called as the posterior urethra. And then the part which is actually outside the body beta, the part which is almost outside the body bache, that could be called as the anterior urethra. Okay, now the posterior urethra which is there beta, it has basically two parts. We know, as the urethra starts from the bladder, the first part of the urethra is surrounded by a gland in males beta. And what is that gland called as? The prostate gland. So that first part of the male urethra beta will be known as the prostatic urethra, whereas the next one is the narrow part beta called as the membranous urethra. So posterior urethra is further subdivided into two types beta. The first one is the prostatic urethra. The second one which is there at beta, it is the membranous urethra. Anterior urethra has two parts further bache. The anterior urethra, first of all, it is either divided into the perineal or the bulbar urethra. That means the urethra which passes in the perineum beta is known as the perineal or the bulbar urethra, and the penile urethra. Penile urethra is the urethra which is present inside the penis beta, okay, which is protected by the penis basically, okay, which is present in the corpora spongiosum of the penis. That is what is known as the penile urethra. Okay. Now I'll show you the image, don't worry about that. So female urethra will likh lo ek bar. Female urethra is only 4 centimeters in length, we discussed, and the diameter is only 4 to 6 millimeters beta. The diameter is around only 4 to 6 mm. Okay. Now let's see beta the male urethra first. Okay, shall I? So see over here, you are able to see beta, this is the urinary bladder, the yellow one beta. Okay, and this yellow urinary bladder is made up of which muscles? It is made up of the detrusor muscles beta. Next, definitely we have the urethra. The first part of this urethra beta, you can see it is surrounded by that blue color prostate gland. So therefore this part of the urethra will be called as the prostatic urethra. Okay, next part which is there beta, you can see this is the narrow part, and this narrow part of the urethra which is there beta, it is the membranous urethra. We know that the prostatic and membranous urethra together will be called as the posterior urethra. Next important, here you are able to see beta, this part of the urethra is actually passing via the perineum beta, and as this part passes via the perineum, either you can call it as the perineal urethra or you can call it as the bulbar urethra. You can even call it as the bulbar urethra, whereas the last part of the urethra which is traveling via the penis, it is known as the penile urethra. So these are the parts beta, and we know that the bulbar and the penile urethra together are going to be the parts of anterior urethra. Clear above? That is important. Now in the urethra, I've told you beta, there are going to be two sphincters. Can you see those? The first one beta is located at the level of bladder neck. The first sphincter is located at the level of bladder neck, known as the internal urethral sphincter, which is known as the internal urethral sphincter. Whereas the second sphincter you are able to see beta, it is located at the level of the membranous urethra beta. Okay, so that is important. It is located at the level of membranous urethra. Okay, females में जो sphincters होते हैं बेटा, for example, this is the female urethra, short होता है. So in females beta, the two sphincters which are there. The first sphincter is again located at the level of bladder neck. Yes. So the location of internal urethral sphincter is exactly the same beta, whether it is a male or a female. It is going to be at the level of bladder neck. But the external urethral sphincter in females beta, obviously females do not have so many parts of the urethra. So the external urethral sphincter in females beta, it also lies in the proximal part of the urethra itself. Yes. So yaad rakhna hai that the external urethral sphincter usually lies in the proximal two-third of the urethra. It usually lies in the proximal two-third of the urethra itself. Okay? So let's talk about that. If I talk about the two urethral sphincters, beta, yaad rakhna, these two urethral sphincters, the one is internal, the second one is external. The internal urethral sphincter ka location was common in both the sexes, beta, and it was at the level of the bladder neck, beta. It was at the level of bladder neck. But the external urethral sphincter which is there, the external urethral sphincter which is there, it is definitely at different locations. In males beta, the external urethral sphincter was at the level of the membranous urethra. Okay, in the males beta, the external urethral sphincter was at the level of the membranous urethra, whereas in females beta, it is usually at the level of, in females bache, if I talk about, it will be at the level of proximal two-third of the urethra. No issues with this, anybody? Got it? That's important. Okay. So in males, definitely it is at the level of the membranous urethra. In females, it is at the level of the proximal two-third of the urethra. No issues. So that is important. Now, last part which is there from anatomy beta, and it is nothing else but the contrast studies. So please remember beta that the last part which is there beta, it is nothing else but the prostate gland from the anatomy. Prostate gland, if I talk about beta, so yaad rakhna, the prostate gland ka weight is approximately around 18 to 20 grams beta. Prostate gland ka weight is around 18 to 20 grams basically. Okay. Now prostate gland which is there beta, I hope all of you are quite aware, it is responsible for secretion of the it is responsible for the prostatic secretions beta, actually, which gives the volume to the semen basically, right? That is important. They contain some important enzymes like acid, phosphatase and all. Okay. Apart from that beta, you have to remember that prostate also secretes an antigen, and that is called as PSA beta, that is prostate specific antigen. That prostate specific antigen could be considered as an important marker in the prostate gland pathologies beta. Yes, so we are going to discuss two prostate gland pathologies mainly beta. The first one is going to be called as the BPH. What is BPH? Benign prostatic hyperplasia, where the number of cells inside the prostate gland is going to increase, and therefore ultimately the size of the prostate gland is going to enlarge beta, and that causes compression of the prostatic urethra. That condition is known as BPH beta. And second condition we will discuss about is going to be the prostate cancer, which is the most common cancer in elderly males beta. Clear about that? We'll talk about. But for that you have to have an idea beta that the prostate gland which is there, it is usually divided into 5 lobes by anatomists beta. Yes, anatomically prostate is usually divided into how many lobes? It is divided into 5 lobes beta. The anterior lobe, posterior lobe, the medial lobe, and there are 2 lateral lobes beta. Okay, easy. So it is the anterior, posterior, medial and 2 lateral lobes beta. Okay, which is the anatomical classification of the prostate gland. But the surgical classification of the prostate gland is slightly different beta. The innermost part of the prostate gland is called as the central zone. Then the middle part which is there beta is what is called as the transitional zone, and the outermost part which is there beta is what is called as the peripheral zone bache. Okay? Sorry. The outermost part is the peripheral zone, the middle part is the transitional zone, the inner part is the central zone beta. So surgically beta, according to McNeil's classification, we usually divide or classify the prostate into 3 zones. That has to be remembered. So yaad rakho yahan pe there are 3 McNeil surgical zones beta that you need to remember. That one is the central zone, another is the transitional zone, third is the peripheral zone. important is beta याद रखना, we actually have to remember that in which condition, which zone is more commonly involved. So we will discuss that further also, but have an idea about this. That if I say beta BPH, okay, so please remember in patients of BPH beta, mainly the transitional zone is involved. Yes, okay, so the transitional zone or the lateral lobes which are there usually beta, those are going to be more commonly involved in a case of BPH. Okay, if I say prostate cancer beta, so prostate cancer के patients में definitely it is the peripheral zone which is involved, and in the peripheral zone it is which lobe? It is the posterior lobe beta. ठीक है, so for prostate cancer you can remember PPP, that is prostate cancer peripheral zone posterior lobe. ठीक है, so these are the things to be remembered over here. If I talk about contrast studies, like we discussed about the barium studies for your GIT, right, बच्चे, जैसे वैसे ही we have to discuss about the contrast studies for your urinary system. Easy to remember, understand. First beta, we have to give a contrast basically via the blood vessels. Yes, by IV access beta, by IV route, we have to definitely give contrast to the patient. Now this contrast will travel all the way to the blood vessels, and we know all the blood goes for filtration into the kidneys. So kidneys mein beta, this contrast which is there from the blood, it gets filtered out, and once that contrast starts getting filtered out via the kidneys beta, now we will take a X-ray. As the contrast is filtering out via the kidneys beta, we'll be able to see the kidneys or the renal pelvis properly, okay, and we will also be able to see beta the ureters properly. So to highlight the renal pelvis, okay, or to highlight the ureters beta, we have done this investigation. So if there is any kind of problem inside them, we will be able to assess that beta, and this contrast study is classically called as IVP or IVU, that is the intravenous pylography or intravenous urography beta. So if they ask you that what is the contrast study, okay, what is going to be the contrast study done done for the kidneys, pelvis and ureter beta. So kidney, pelvis and ureter के लिए if they ask you what is the contrast study, the answer has to be an intravenous. The answer has to be an intravenous pylography or urography beta. It is nothing else but a X-ray when the contrast is going to travel via the renal pelvis or the ureters. I'll show you the image. Okay, you can call this investigations as IVP or IVU. Clear to all of you now? See the images once beta. Intravenous pylography or intravenous urography beta. See, I'm going to show you images. This is the IVP beta. Okay, this is what is the IVP or the IVU. So here what are you able to see? The contrast is basically traveling via the renal pelvis. So you can see the renal pelvis appears highlighted. It is traveling by the ureter, so the ureter appears highlighted, right? So this is what is called as the IVP or the IVU beta. Next important if I talk about is the urinary bladder beta. So urinary bladder ke liye what we do understand? We insert a catheter beta, just like a Foley's catheter for urine. We insert a catheter beta up to the patient's urinary bladder via the urethra beta. And then we have to inject or we have to fill up the bladder beta with a lot of contrast. Yes, we have to inject or we have to fill up the bladder with a lot of contrast beta, and then we will take a X-ray. Okay, now definitely here the contrast is only inside the urinary bladder, and now the bladder appears highlighted. So we are able to pick up any problems inside the bladder beta. This investigation which is there will be called as a cystography or a cystogram, right? So this investigation which is there beta, you can call this investigation either you can call it as cystography or you can call it as a cystogram, whatever you want to call it. Okay. Next important investigation is for the urethra beta. Now याद रखना urethra के लिए what we do, we actually inject beta. Okay, we actually inject the contrast inside the urethra. Now as we are injecting the contrast into the urethra beta, it is going in a backward flow, right? So therefore it is called as retrograde, and as we are taking the X-ray or the picture of a urethra, it should be called as a urethrogram. So therefore this investigation for the urethra beta is going to be called as the RGU. And what is RGU? Retrograde urethrogram. The investigation for the urethra which is there beta, it's called as the retrograde urethrogram. Once you understand this beta, रट्टा मारना ही नहीं अपने को, ठीक है? We know कि what problem के लिए what investigation has to be done, ठीक है? Next important beta is nothing else but urinary bladder and the urethra together. If I want to see any problems in the bladder and the urethra together beta, then there is an investigation beta. It actually tells me about the flow of urine also. Yes, it will definitely tell us about the problems in the flow of urine also beta, and that investigation that you need to remember bache is going to be called as the MCU. Now what we do in this investigation, understand, Again beta, via the urethra we have to push the contrast in a backward manner. Okay, once the bladder is completely full with the contrast beta, okay, once the bladder is completely full, we have to fill up the bladder beta till the patient gets an urge to micturate or urinate. Okay, तब तक भरते रहना bladder को. Once my patient gets the urge to micturate beta, my patient will start urinating in front of the X-ray machine itself, right? We will give him a container and he will start urinating in front of the X-ray machine. And when my patient is urinating beta, then we are taking repetitive X-rays beta. Either you can call it as a fluoroscopy or we are taking X-rays beta. Okay, and this investigation is what is called as a MCU, matlab micturating cystourethrogram. While the patient was micturating or urinating beta, you have taken a picture of the bladder and the urethra together, right? So that investigation should be called as a MCU beta. So it is known as micturating cystourethrogram. Do you remember micturating cystourethrogram, which is there beta? It can actually tell me about two problems related with the urethra or the bladder beta. The first problem is easy. What is that first problem? For example, this is the bladder and this is the urethra of the patient beta. Okay. Now, in some children beta, usually in male children, obviously, okay, in male children beta, there is actually a blockage or there is a valve beta in the posterior urethra, right? In a male child beta, in the posterior urethra, there is a valve. And this valve which is there beta, it will not allow the flow of urine properly. Okay, it is actually causing blockage. So this condition is known as the posterior urethral valve. So for that condition known as posterior urethral valve beta, micturating cystourethrogram or MCU has to be the investigation of choice beta. Yes, this investigation has to be the investigation of choice beta, your MCU or the micturating cystourethrogram. The reason is over here, due to the valve, the contrast will not be able to come outside, and therefore we'll be able to diagnose that okay, there is some kind of blockage in the posterior urethra of this male child, and that is more likely to be a case of a posterior urethral valve. No issues with this, anybody? That is one condition. Second condition where it is investigation of choice beta, it is nothing else but VUR. Now what do I mean by VUR beta? It is vesico-ureteric reflux. Matlab, when the urine which is there, see, normally beta, when the bladder should contract, normally whenever the bladder should contract beta, okay, the urine which is there beta, it should come outside via the urethra. Normal hai, the bladder contracts and the urine comes out via the urethra. But beta, in some patients what happens, as the bladder contracts beta, some urine definitely comes out via the urethra, but a lot of urine also goes backward into the ureters beta. Upar jati, upwards it goes into the ureters. Now as the urine is going from bladder into the ureters beta, that condition is known as a VUR, that is vesico-ureteric reflux. And this is basically beta because please remember the ureteric openings which are there in the bladder are going to be very, very broad. Reason, if these ureteric openings are small beta, then what happens? Whenever the bladder contracts, these openings are going to close and therefore the backflow is not going to happen. But if these openings are too broad in size, if the opening is too broad in size beta, what is going to happen? Even if the bladder contracts beta, can you see? Even if the bladder is completely contracting, still the ureters are open beta, and as the ureters will remain open, that's the reason why there will be a backflow of the urine beta leading to a VUR or a vesico-ureteric reflux. Hopefully that's clear to all of you. Now therefore beta, we have to ask the patient to urinate now to see whether that contrast is going in an upward manner or not. That's the reason beta, for a vesico-ureteric reflux you cannot just take another investigation like a cystogram beta. You have to take a micturating cystourethrogram because you will be able to see the reflux only when the bladder contracts, right? So that is important to remember. Chalo. So hopefully contrast studies are clear to all of you. Now next, let's talk about the congenital anomalies beta. Now as I talk about congenital anomalies of the urinary system, the first congenital anomaly is nothing else but renal agenesis beta. What is agenesis? Agenesis means no development. Yes. So renal agenesis beta matlab there is no development of the kidneys, there is absence of the kidneys beta. Okay. So renal agenesis mein, in this condition there is going to be absence of kidneys, but beta, kidney is not going to be absent alone. We know if the kidney is absent beta, on that side the renal pelvis, the ureter and even the hemitrigon of bladder, that is half of the bladder on that side will also be absent. Okay. So agar kidney absent hogi beta, the ureters on that side and the hemitrigon on that hemitrigon of bladder on that side beta, that is half of the bladder on that side will also be absent. Okay. So yaad rakhna hai bachche, whenever there is absence of kidneys, okay, there is also absence of the ipsilateral, that is the same sided. Okay. There is also absence of ipsilateral ureter as well as the hemitrigon, that is half of the bladder. Hopefully that's clear to all of you now. That is important. If they ask you beta that It is associated with which condition? So do remember, if there is renal agenesis in a patient, beta, the male child which is there is more likely to have another problem, beta, known as UDT, that is undescended testis. Yes, we know, beta, that the testis of a male child, beta, develop inside the abdominal cavity. But at birth, beta, before birth, just that means between the 7th to 9th month of intrauterine life, beta, these testes which are there, they are going to descend down, they are going to come down inside the scrotal sac outside the body. Reason? The testis which is there, beta, they need a temperature which is 2 degrees less than your core body temperature. Otherwise, the process of spermatogenesis cannot happen. But in some children, beta, what happens during the development, that these testes are not able to descend down into the scrotum, beta. They get arrested itself. ठीक है, वो अटक जाते कहीं. That is what is classically called as undescended testis, beta. So please remember, this condition, renal agenesis, is commonly associated with undescended testis in males, beta. And in females, beta, it is associated with absence of the fallopian tubes. Okay. In females, beta, it is usually associated with the absence of the fallopian tubes, that you have to remember. No issues with this? Sure. That is important. Next important, beta, याद रखना, renal agenesis can be unilateral, can be bilateral. More commonly, obviously, it is unilateral, beta. So usually the renal agenesis which is there, it is usually unilateral. Incidence, if they ask you how much is the incidence, so याद रखना, beta, the incidence is around 1 in 1000 live births, beta. Okay, 1 in 1000 live births basically is the incidence of renal agenesis. Okay, one child in every 1000 live births, beta, may have the risk of renal agenesis, beta. That is important. Now, if there is a bilateral renal agenesis, beta, if there is a bilateral renal agenesis, then definitely we are able to see a very classical condition, beta. And that classical condition is known as something called as Potter syndrome. This you might have discussed in pediatrics. If I talk about Potter syndrome, beta, please remember what is seen in Potter syndrome patients. The first one, the patients are going to have bilateral renal agenesis, beta. First thing. Second important, beta, as there are bilateral renal agenesis, we know that the major contributor in the amniotic fluid, beta, is going to be the fetal urine itself. Obviously, if the baby is not having both the kidneys, there is no urine production. That's the reason, beta, the patient who is there is going to have severe oligohydramnios. I hope all of you are quite aware the most common cause of severe oligohydramnios is going to be bilateral renal agenesis itself. Sorry. Okay, so that is important. Along with that, beta, as the amniotic fluid is less, please remember the lung development of the baby will also not happen properly, and therefore there will be underdevelopment of the lung. Underdevelopment of the lung is known as pulmonary hypoplasia, beta. Along with that, obviously, beta, the baby is going to have a wrinkled skin. Okay, as you are able to see, beta, there will be wrinkling of skin which will be present in this patient basically. Apart from that, the baby is also having abnormal faces, beta. Can you see the face of the baby is not properly developed? There is abnormal faces like nasal hypoplasia is there, beta. Small palpebral fissures are going to be there. So all these problems which are there, beta, they will be seen in this patient of renal agenesis, and there can be limb defects. I hope all of you are quite aware that whenever a female has oligohydramnios, beta, the chances of limb defects are very, very high. Something like CTEV you might have studied in orthopedics, right? So congenital talipes equinus virus. So these conditions are commonly associated with Potter syndrome. Yaad rakhna, Potter syndrome is an important condition. Yes, here the baby does not survive. Obviously, bilateral renal agenesis है beta. Obviously, the baby who is there, beta, is not going to survive over here. But this is the important condition has been asked, so do remember this. Okay? Clear है? Next important, beta, is a condition that is known as an ectopic kidney. Now, if I talk about an ectopic kidney, beta, okay, if I talk about an ectopic kidney over here, do remember that kidney which is there, bache, okay, kidney which is there, it is present at unusual location over here, right? The kidney which is there, it is present at unusual location. What is ectopic? I've told you earlier also. Ectopic means which is not present in the original location. What is the original location of the kidney? T12 to L3. So here the kidney is not present in the original location, but it is present somewhere else. So that is what is known as an ectopic kidney. Now, please remember, if they ask you, it is associated with what? See, if the kidney is located at unusual levels, beta, there may not be proper drainage of the urine, and if there is not proper drainage of urine, beta, the patient will have a very high risk of UTIs, that is urinary tract infections, beta, or the patient may also have a very high risk of backflow, that is vesico-ureteric reflux, beta. ये ठीक कर लेना. It is not vesico-urethral, it is vesico-ureteric. Okay, it is vesico-ureteric reflux will be there. Urethra में reflux कैसे होगा? Clear? That is important. Apart from that, if they ask you which is the most common site for ectopic kidney, so we know beta that kidney develops in the iliac fossa. If the kidney remains in the iliac fossa itself, that means it does not get ascend up. Okay, then obviously that will be an ectopic kidney. So yaad rakhna beta, the most common site of the ectopic kidney is iliac fossa because kidneys develop over here. So what happens is the kidney develops in the iliac fossa and they remain in the iliac fossa beta. Okay, they do not come to their original position. That is what is called as an ectopic kidney. See, if the patient is not having any problems as such, then obviously no treatment is required. Even if the patient is having some minor problems, beta, something like usually your UTIs, vagara, you are going to treat the patient conservatively only. Okay? You go for a conservative management in this patient itself. No issues with this. That is important. Next important, beta, let's talk about another condition called as the horseshoe kidney, beta. Now, if I talk about horseshoe, I hope all of you are quite aware, beta. Horseshoe is basically this kind of a shape, bache. So what is seen over here? Understand, beta. Here we have a pair of ectopic kidneys, beta. Yes, we have a pair of ectopic kidney. Matlab both the kidneys which are there, beta, they are not present in the original location. Both the kidneys which are there, bache, they are usually present at some abnormal location. Both the kidneys which are there, beta, they are not present in the original lumbar location, beta. They are present in the anterior part of the abdomen, right? We know kidneys are in the retroperitoneum, but here, beta, the kidneys which are there, they are present in the anterior part of the abdomen mostly. Okay, sometimes, and then as both the kidneys are not in the original location, beta, these are called as a bilaterally ectopic kidney. And then this ectopic kidneys which are there is one more feature that the lower poles which is there, beta, it is going to fuse with each other. Okay, lower poles of both the kidneys is going to fuse with each other. So as there is a bilateral ectopic kidney where the lower poles fuse with each other, beta, this is going to form a horseshoe shape. That's the reason, beta, this is what is called as the classical horseshoe kidney, beta. This is classically known as the horseshoe kidney. As I've told you, it is nothing else but a pair of ectopic kidneys, beta. It is going to be a pair of ectopic kidneys where the lower pole of both the kidneys which is there, beta, it is going to fuse in the midline. Okay, and as the lower pole of the kidneys have fused in the midline, beta, will they be able to go up? No. Okay, they will not be able to go up, beta. Reason is it is restricted by the inferior mesenteric vessels. Alag alag hote to they might have gone, but now they are fused together, beta. That's the reason they are not able to ascend up because they are restricted by the vessels over here, beta, known as the IMA, inferior mesenteric vessels, beta. Okay. So therefore, they are not able to ascend up, beta, in the normal position due to restriction. Okay, due to restriction by which vessels, as I told you, by the inferior mesenteric vessels. Okay. If they ask you, beta, what is the most common site of fusion? As I've told you, the lower poles of the kidney fuses. So previous question of your examination has been, what is the most common site of fusion in a horseshoe kidney? The most common site of fusion in the horseshoe kidney, beta, is usually L3, L4, beta. Yes, at the junction of L3, L4, beta, there is highest risk of fusion, biche. If you have to answer one, because in that question they asked the single best answer, then you can choose L4, beta, as a better answer. Okay, then you can choose L4 as a better answer. No issues with this. Next important, beta, if they ask you what are the clinical features, biche, so do remember that the clinical features in majority of the patients, beta, the patients may not have any symptoms also. Yes, the condition may remain asymptomatic itself, beta. No issues with this. In majority of the patients may remain asymptomatic. If there are any kind of symptoms, beta, what those can be? First, here these kidneys which are there, beta, which are fusing basically in the midline, they are going to form an abdominal lump, beta. Yes, they will be felt as an abdominal lump. That has to be remembered. Next important, the patient may experience pain also over here. Third important, the patient may have hydronephrosis. Now, what is hydronephrosis? Let's talk about that first. Okay, try to understand what I'm telling you because बहुत बार आएगा ये. See, we are here, beta. We know that definitely we have these major calyces. All these 3 to 4 major calyces fuse together to form the renal pelvis, and then this renal pelvis continues to form the ureter, beta. If I say if there is any kind of blockage, beta, in the flow of urine, right, whether it is a partial blockage or a complete blockage in the flow of urine does not matter, but there is blockage in the flow of urine. Due to that, beta, will the urine be able to properly empty itself? No. And as the urine is not able to properly empty, beta, definitely all the urine is going to collect inside this renal pelvis and these renal calyces. And that's the reason, beta, all this renal pelvis and the renal calyces which are there, it is actually going to dilate, beta. So that extreme dilatation of the renal pelvis and the renal calyces which is there, beta, due to the blockage to the flow of urine is what is called as hydronephrosis. Clear about? So when there is dilatation of ureter, that will be called as hydroureter. But when there will be dilatation of the renal pelvis and the cholecyst, that is known as the hydronephrosis. So any condition which will block the flow of urine beta will cause hydronephrosis. ठीक है, बहुत सारे आएंगे अभी. Next important, as there is stasis of urine over here beta, due to stasis of urine, the patient may have a higher risk of stone formation or even infections for that matter, that is UTI, urinary tract infection. If they ask you what is going to be the first line investigation, as the patient comes to me with the complaints with the abdominal lump, okay, as the patient comes to us beta with the complaints of an abdominal lump, obviously you have to go for an ultrasound abdomen beta. Okay, you have to go for an ultrasound abdomen, and on that ultrasound abdomen bache, you are able to see definitely that the kidneys are having a problem. So therefore beta, after an ultrasound abdomen, we can definitely send an investigation that is called as a KFT. What is KFT? Kidney function test beta, right, to see whether the kidney function of the patient is normal or abnormal. Now if they ask you what is the investigation of choice, so do remember beta, the investigation of choice is nothing else but a CECT scan beta. Okay, so CECT scan which is there beta, it is going to be the investigation of choice in this patient. And when we do a CECT scan, it is given below. You are able to see that classical horseshoe shaped kidney beta. Can you see here? We are having this one kidney, the second kidney, and both the lower poles are fused in the midline beta. This is the classical picture. This is the classical picture of a horseshoe kidney beta. Now important is, if they ask you that horseshoe kidney will be located at which level, what this vertebra would be, most probably this vertebra is going to be L4, right? So that is important. This is the picture on the CECT abdomen beta that you will be able to see. If they ask you on IVP or intravenous pyrography, what will be the picture? So on IVP or intravenous pyrography beta, we are able to see a very classical sign. It looks like a flower vase beta, right? So on IVP, definitely you have to remember all the appearances. ठीक है यहाँ पे. So we have to remember that we will be able to get a classical flower vase appearance, or it is also known as which sign beta? It is also known as a hand joining sign or a hand shaking sign beta. It is also known as the hand joining or the hand shaking sign. Okay, remember all of them beta. These signs are basically important in the urology part, congenital anomalies at least. Okay, you will be able to see a flower vase appearance, or we can call it as the hand joining or the hand shaking sign. Okay. Now if they ask you beta what is going to be the treatment, so do remember beta, that treatment which is there is going to be conservative. Yes, it is non-surgical treatment beta. You will be like, sir, why? Reason beta, if you are going to cut the kidney, actually the kidneys will get damaged beta, and the kidneys may stop functioning itself. That's the reason beta, it has been observed that whenever we cut the kidney, basically there is a risk of injury beta. That's the reason better, do not go for any surgical management. Do not cut the pores of the kidney beta. Definitely if the ureter is getting obstructed, you can lateralize the ureter, but do not go for cutting the kidney at all. Okay, so conservative management is the mainstay. And what do we do in conservative management? See, in the patient, if he's having stones, we have to do a removal of stone. If the patient is having UTI, we should give antibiotics. So that kind of a conservative or a symptomatic management has to be done. Clear? That is important. Next condition now after horseshoe kidney beta is this one over here. And in this condition, what are we able to see? We are able to see beta that there are multiple fluid filled lesions beta on the kidneys, right? Due to that, the kidney is also enlarged and ultimately it will get damaged, right? This kidney which is there beta, this bilateral kidneys which are enlarged and damaged basically due to formation of all these fluid filled cells known as all these fluid filled cells beta. This condition is known as PCKD. What is PCKD? Polycystic kidney disease beta. Okay, this condition which is there is classically called as the PCKD, that is polycystic kidney disease. Now when I talk about PCKD or a polycystic kidney disease beta, yaad rakhna, it is basically of two types. Either it is called as the infantile variety, or it is the congenital, that is the adult variety beta. Either it is the infantile variety or it is the congenital, that is going to be called as the adult variety. Clear about that? Has to be remembered. If I talk about beta, the infantile variety which is there, yaad rakhna, it is autosomal recessive in nature. The infantile variety which is there beta, it is going to be autosomal recessive in nature, and it is incompatible with life. What do I mean by incompatible with life beta? That the patient who is there will not be able to survive. Here the baby usually either dies in the uterus itself or usually dies in the first year of life during infancy. That is the reason it is known as the infantile variety. So this you don't have to worry much about. More important for you is going to be the congenital or the adult variety, because all your patients who will present to you will definitely be the congenital or the adult type. Now, when the congenital or adult type of PCKD presents to you, you have to remember the pattern of inheritance is going to be autosomal dominant beta. Yes, so it will have an autosomal dominant pattern of inheritance. First thing to be remembered. And why it is called as the congenital or adult variety, understand, as it is due to a gene mutation which will be present since birth, therefore it is called as congenital. But the symptoms of the patient which is there beta, it will only start appearing after 30 years of age. And as the symptoms which are there beta, they only appear after 30 years of age definitely, therefore we can call it as the adult variety beta. Now why the symptoms will appear after 30 years of age? The reason being beta, please remember that even though the gene mutation was present since birth, but this cyst which is there beta, those have started growing, okay, slowly over a period of time. So beta, when the patient turns an adult, till that time definitely that cyst would have grown and now the kidney damage would have started. Okay, so unless and until the patient is not an adult more than 30, the patient may not have any kind of symptoms, autosomal dominant polycystic kidney disease beta. If they ask you what are the gene mutations, do remember beta, the gene mutations for PCKD are going to be called as, either I can call that gene basically as PKD, okay, or the polycystin gene beta. You can call it as the PKD or the polycystin gene. So we have the PKD1 gene beta, which is located, we have the PKD1 gene which is located on chromosome number 16, and we have the PKD2 gene beta. We have the PKD2 or the polycystin 2 gene which is located on chromosome number 4. Okay, so PKD1 gene on chromosome number 16 and PKD2 gene on chromosome number 4 beta. Clear? If they ask you that if the PKD or the polycystin gene is undergoing a mutation, will we have only cyst inside the kidneys? No beta. There are other organs also like the liver, the pancreas, the spleen, the ovaries, the lungs, which may have cyst also beta. If they ask you then which is the most common extrarenal site apart from the kidneys beta, which is the most common site where cyst could be there? If they ask you the most common extrarenal site beta for the cyst to develop is going to be the liver. The most common extrarenal site beta for the cyst to develop is going to be the liver. That has to be remembered. No issues with this? So do remember that. If they ask you what will be the clinical features in the patient, yaad rakhna, the clinical features in the patient would be, the first and the foremost will be hypertension beta, right? The patient is actually going to have hypertension beta. Reason we know, whenever the kidneys are damaged beta, the patient will not be able to excrete out the excess volume. That will cause hypervolemia, which leads to hypertension, right? And even the RAS system which is there beta, it gets affected. That is the reason definitely the patient has hypertension in all the kidney diseases, right? Next important beta, if they ask you, the patient will also have a mass. Basically reason, this kidneys which are there due to formation of multiple cysts on their surface beta, they are going to enlarge in size, and that's the reason you'll be able to feel a mass in the lumbar region or in the flank of the patient. The patient may have pain also beta. The patient may have hematuria. Yes, the patient may have bleeding beta, and that can cause hematuria at times. And the patient may have uremia. Obviously, if the kidneys of the patient are damaged beta, the urea or ammonia like substances are not able to get excreted out from the body, and that causes collection of these nitrogenous substances in your body known as uremia bache. If they ask you what is the first line investigation, so yaad rakhna hai beta, the first line investigation has to be again ultrasound abdomen itself, right? Whenever a patient of PCKD might have come to you, you might have gone for ultrasound abdomen only, right? So ultrasound abdomen, and ultrasound abdomen pe wapas, when I'm able to see, okay, the kidneys are enlarged and there is cyst inside the kidneys, obviously we have to send the patient for a KFT. For what? To see definitely if the kidneys are normally functioning or they have undergone a damage beta. Okay? Now important is if they ask you what is the investigation of choice. So do remember, investigation of choice is going to be a CECT abdomen. Henceforth remember, एक चीज याद रखें हमेशा. Henceforth remember one thing, that for all the retroperitoneal problems beta, the investigation of choice will always be a CECT abdomen. For all the retroperitoneal problems, the investigation of choice is CECT abdomen, except one condition, and that is Wilms tumor beta. Yes, it is basically a Wilms tumor from the kidneys, where we prefer doing a MRI, that too in the early stages. Okay? But otherwise, everywhere CCT abdomen is the investigation of choice. Easy to remember? That is important. Pancreas, ho, kidneys, ho, aorta, whatever it is, CCT has to be the investigation of choice. So CECT scan beta has to be the investigation of choice. And when we do a CCT scan, you are able to see beta the classical picture out here. This is the classical picture that is seen. Can you see these are the multiple cysts beta in both the kidneys definitely developing, which have damaged the kidneys. This is what is the classical picture of the polycystic kidney disease beta. Okay, that has to be remembered. No issues with this, anybody? Next important now, if I talk about is IVP. If I do a IVP or intravenous pyelography, what should be the appearance on that? So please remember beta, on the IVP or intravenous pyelography, you are able to see a very classical appearance like this, and that is classically known as the spider leg appearance, which that is classically known as the spider leg appearance. That has to be remembered. No issues with this. The spider leg appearance is going to be seen beta in the patient. That has to be remembered. Clear? Hai? If they ask you what is the treatment in the patient, so please remember in a patient of polycystic kidney disease beta, initially when the patient comes to us, right? Initially when the patient comes to us beta, we have to only do a medical management of the patient, and that is usually done by antihypertensive drugs beta. Okay, we have to only give antihypertensive drugs of the patient, drugs to the patient. Reason, initially when the patient comes to us beta, patient is only having the most common symptom. And what is the most common symptom? I have told you, the most common symptom is going to be the problem of hypertension. Even the most common cause of death beta is hypertension related complications itself. Okay, so the first line management beta, or the main management, has to be antihypertensive drugs. Can anybody tell me in the chat box, pharma ho chuka hai tumhara, that which will be the antihypertensive drugs to be preferred in a patient of PCKD? Please let me know in the chat box. Okay, if beta antihypertensive drugs do not help, then definitely, and the kidneys are also damaged further. Okay, serum creatinine value of the patient is rising. You have to send the patient for a long term dialysis beta. Okay, we have to send the patient for a long term dialysis. Apart from that, we can go for a Rovsing surgery in the patient. Now, what is this Rovsing surgery beta? Rovsing surgery is nothing else but removing the roof of the cyst Q, so that the cyst is able to drain. Yes, de-roofing the cyst beta, or removing the roof of the cyst, so that definitely the cyst is able to drain beta. It is called as the Rovsing surgery. So yaad rakhna, Rovsing surgery is nothing else but de-roofing of cyst. So this surgery is not commonly done beta, because recurrence is even very high beta after the surgery also. So क्या मतलब है to do this surgery even if the recurrence is going to be high after the surgery? ठीक है? So that's the reason definitely beta, we do not go for the surgery commonly, but could be done. Okay, and the last option, when the kidneys are almost completely damaged beta, that has to be what? That has to be a renal transplant beta. The last option that you have to remember beta is going to be a renal transplant itself. Okay, now if I talk about renal transplant bachche, so please remember, what is the best site for a renal transplant? So yaad rakhna, the best site for a renal transplant is going to be the iliac fossa. Okay, and that too the right iliac fossa beta. I've told you, I've asked you about this question. So right iliac fossa beta is going to be the best site. You will be like, so why? Why we don't place in the original position beta? It is difficult to place the kidney in the original position. 1 point. Second, if we have to remove the kidney beta, why we need to remove the kidney? Because beta, I hope all of you are quite aware that the maximum chances of rejection or failure, if they are seen in any transplantation, it is the lung and the kidney transplantation. Okay, so kidney and the lung transplantation are the commonest ones beta, where there will be highest risk of failure. That was a previous year question of your exam. The highest risk of failure beta, it is usually seen in the kidney and the lung transplantation. That's the reason we may have to remove beta, definitely the sorry, we may have to remove the transplanted kidney. So therefore it should be easier to remove na. So because of that ease of removal beta, it is better placed in the right iliac fossa. Okay, so that is important to remember. No issues with this? Yes, very good. So please remember beta, the antihypertensive drugs of choice which will be there. Rakna, it is going to be ACE inhibitors. That is all your prils beta, captopril, lisinopril, enalapril. ठीक है, अगर वो ऑप्शन में नहीं है, then the second best choice will be the ARBs beta, that is angiotensin receptor blockers, known as sartans, that is valsartan, losartan, all of that. You remember diabetic nephropathy में drug of choice क्या यही तो है. So kidney problems causing definitely hypertension will always be this. Clear? Now second condition, next condition which is there beta, it is going to be duplication of the renal pelvis and ureter. Now what do I mean by this condition? Understand, duplication or duplex renal pelvis and ureter means we normally know beta from one kidney there is only one pelvis and one ureters which arise. बराबर एक किडनी से कितने pelvis होता है? Only one. And how many ureters? Only one. But here beta duplication means what? From one kidney basically beta there are two renal pelvis and there are two ureters which are arising. Okay, from one kidney definitely there are two renal pelvis basically and there are two ureters which are going to arise. Okay. Now important is here you are able to see definitely this is one of the renal pelvis beta. Okay, and definitely this is another renal pelvis which is. So here you are able to see beta that there are two renal pelvis and there are two ureters. Now most of the times what happens बच्चे याद रखना, most of the times beta that both these ureters which are there they combine to form a single ureter. Okay, most of the times both these ureters combine to form the single ureter and they open as one ureter beta. Okay, and they open as a one ureter in the urinary bladder. Okay, they open as one ureter inside the urinary bladder. That has to be remembered. But beta sometimes there can be a problem. If both of them fuse together, that is not a problem at all. But if both of them do not fuse with each other beta, if both of them are not going to fuse with each other, then that creates a problem. Kaise? Because this lower ureter may go and join the urinary bladder. Okay, the lower ureter which is there beta, it may go and join the urinary bladder properly. अब इसमें तो कोई दिक्कत नहीं है. This is normal. But the other ureter which is there beta, that other ureter basically is going to become ectopic. Okay, that other ureter which is there beta, it is going to become ectopic. I am using another color. Can you see? That means it is not opening in the urinary bladder beta. Where is it opening? It is opening in the urethra of the patient. Okay, it is not opening in the urinary bladder beta, it opens in the urethra of the patient. And this is the problem. Can you see? If there are two renal pelvis and two ureters, majority of the times both the ureters fuse and they open a single ureter into the bladder, no issues. But if beta any one of the ureter which is there, it becomes ectopic, that is a problem. And when it becomes ectopic beta, it opens into the urethra. Ab in males where it opens up beta, in males definitely it opens inside the prostatic urethra. And we know beta in males if it opens at the level of the prostatic urethra, what will be the complaint? We know that the internal urethral sphincter is at the level of the bladder neck and the external urethral sphincter is at the level of the membranous urethra. So still beta the external urethral sphincter is there. So definitely the control over the urine is not going to be lost. So this patient is not going to have any problem of dribbling. But what will be the problem? As the urine will keep on collecting inside the prostatic urethra for a longer duration of time, it will get infected beta. That's the reason the patient will have recurrent UTIs. Okay? So in males definitely beta the problem will be of recurrent UTIs. Okay? But in females what will be the problem? In females we know even the external urethral sphincter is in the proximal two-third. Okay, in the females even the external urethral sphincter is in the proximal two-third beta. And now what is going to happen? The urethra which is there beta, the ureter which is there beta, it is opening distal to the external sphincter. यहाँ पे जो दिख रहा है ना, you are able to see this one, right? This is nothing else but the ureter. The ureter is usually opening beta distal to the external sphincter. External sphincter के और भी बाहर. That's the reason beta here. Will there be any control of urine now? No, all the urine that is coming from the ureter is directly leaking out. So in females beta who are affected with this condition, they will have a constant dribbling of urine beta. Okay, there will be a constant leakage or a constant dribbling of urine because the sphincter which is there, it is not there over here, right? So that is important. Hopefully that's clear to all of you now. Chalo. So duplication of renal pelvis which is there. In this condition, usually both the ureters which are there beta, they join together and they open as a single ureter beta. They open as a single ureter in the bladder. But sometimes definitely there is a problem, and that problem itself we have to remember. And what is that problem? Sometimes the patient has problem, that is that two ureters which are there, these two ureters do not join with each other beta, and one of the ureter which is there, okay, these two ureters do not join with each other and one of the ureter becomes ectopic in nature. That is the problem beta. Clear hai? Now if I talk about, please remember this condition which is there, it is usually unilateral beta. Okay, this duplication of renal pelvis and ureter which is there, it is usually a unilateral condition. Okay, and more commonly it is seen on which side beta? So you remember that more commonly it is usually seen on the left side beta. Okay, so usually it is a unilateral condition and it has been more commonly observed that this condition is seen on the left side. If they ask you that what is the most common site of the ectopic ureter beta, the most common site where the ectopic ureter opens up. If one of the ureter becomes ectopic, in males where it opens up, as I've told you, It opens before the external sphincter. That means in which part of the urethra? It opens in the prostatic urethra, beta, before the external urethral sphincter. But in females, it opens after the external urethral sphincter, distal to the external urethral sphincter. That means it is going to be distal to the external sphincter. In females, it opens, beta, definitely distal to the external sphincter. And this is going to cause all the problem now. Right? Clinical picture, as I told you, beta, the male who is there is going to have recurrent UTIs, beta. Okay, the male who is there, beta, is going to have only recurrent UTIs. But if there is a female with this problem, she will have a constant dribbling or a constant leakage of urine. Right? A female who is there, she will have a constant leakage or a constant dribbling of urine. That is important to be remembered. If they ask you about the diagnosis, beta, so yaad rakhna, the diagnosis in a case of duplication of renal pelvis and ureter could be done, beta, with the help of a IVP. Now, what is IVP? Intravenous pylography, beta, right? So intravenous pylography, or you can mark it as IVU also. That's one and the same thing. So IVP or IVU, beta, will be the investigation that we can do in diagnosis of a renal pelvis, duplication of renal pelvis. Please remember, apart from this, we can also go for other investigations, but this can be a common one that we do. And when we do an investigation known as IVP, what are we are able to see? Here the upper renal pelvis, which is there, beta, it is compressing the lower pelvis. And as the lower pelvis is getting compressed downwards, beta, that's the reason what is happening. That's the reason, definitely, beta, you are able to see it appears like a drooping lily flower. And this is classically called as the drooping lily sign. Okay, so another important thing that you have to remember, that drooping lily sign on the intravenous pylography is a classical feature in patients of duplication of renal pelvis and ureters, beta. Okay, so drooping lily sign will be seen. No issues with this, anybody? That is important. Next important, if I talk about, beta, is going to be the treatment in the patient. Yaad rakhna, if they ask you about the treatment, bache, so treatment is nothing else but, okay, treatment is nothing else but what we are going to do over here. So please remember, beta, we know that one of the ureter which is there, it has become ectopic. So what we have to do, we have to remove the ureter from the urethra and we have to place it back inside the urinary bladder. We have to create the opening, beta, for that ectopic ureter into the urinary bladder. So that is what is known as a ureteric reimplantation, bache. So here we have to do a ureteric reimplantation in the patient. Clear hai baat? That is important. Then with this, chalo, the next condition now, let's talk about that, and that is nothing else but hydronephrosis, beta. If I talk about hydronephrosis, I've told you already that condition. What is hydronephrosis? Whenever there is a partial or a complete blockage to the flow of urine, beta, there will be retention of urine inside the pelvis and the calyces, leading to their dilatation. And it is an aseptic dilatation because there is no infection as of now. That condition is known as hydronephrosis, beta. So hydronephrosis is nothing else but, as I've told you, aseptic dilatation of the pelvic calyceal system, that is pelvis and calyces together, due to either a partial or a complete blockade to the flow of urine. Right? That is important. If they ask you, beta, what are going to be the causes? So do remember that if they ask you, what is the most common acquired cause? What do you think? What could be the most common acquired cause for a hydronephrosis case? What is going to cause blockage in the patient's ureter? Bolo. What could be the most common acquired cause? Yaad rakhna, beta, the most common acquired cause which is there is going to be stones, bache. Yes. The urinary stones or urolithiasis which is there, beta, it is going to be the most common cause, okay, for a hydronephrosis case to happen. Other causes which are there, beta, yes, they can be UTIs. What is UTI? Urinary tract infections. You will be like, so how? Because, beta, UTIs, which are the urinary tract infections, they may cause inflammation due to which there can be adhesions, or they may cause fibrosis later, which can lead to stenosis or strictures, beta, right? That can be a case. But yeah, most common acquired cause has to be stones. Next important, if they ask you, what is the most common congenital cause? So yaad rakhna, beta, the most common congenital cause, if they ask you, the answer is nothing else but, anybody, the most common congenital cause, it is called as something known as the PUJ obstruction. What is PUJ obstruction? Pelviureteric junction obstruction, beta, right? Whenever there is a pelviureteric junction obstruction, that is going to be a problem, beta, leading to hydronephrosis in a baby. Okay? So most common congenital cause agar puchenge, the answer has to be pelviureteric junction obstruction. Other causes of obstruction can be, beta, there are multiple causes. Here we have just seen some causes, beta, and that can be cancers, for example, okay, or it can be uretrocele. What is uretrocele? Understand? All of these are next conditions beta. So I'm just explaining it to you over here itself. Uretero seal matlab, for example, this is your bladder beta. Okay, and now in the bladder, what definitely we know that your ureter is going to open up. Okay, normally the ureter should open up like this. Problem kya hai beta? That here the ureteric opening which is there beta, it is very very narrow, and as the ureteric opening is very narrow over here beta, as the ureteric opening is very narrow, can you see over here? As the ureteric opening is very narrow over here, that's the reason definitely bache you are able to see that at the level of the intramural ureter, that means when the ureter is opening inside the bladder beta, at that level basically there is dilatation in the ureter. Okay, so as the ureteric opening is very very narrow beta, that's the reason there is more pressure over here, and therefore at this level beta, in the intramural part of ureter, there is dilatation. This condition is classically called as the ureterocele. This condition is known as ureterocele. So obviously beta, here there is a narrowing at the ureteric opening, therefore the ureter may not be able to empty properly. That's the reason there is retention of urine inside the ureter, which will cause dilatation. That will be called as hydroureter initially. But later on, there will be so much of retention that there will be retention of urine even in the renal pelvis and the calyces, leading to the dilatation, known as hydronephrosis. So over a longer period of time, beta, ureterocele may also lead to hydronephrosis. Next condition we have to talk about is retrocaval ureter. नाम में ही सब कुछ है. Retro means behind, cava means inferior vena cava. So what happens in this condition? Understand. For example, this is your inferior vena cava. Now normally beta, the renal pelvis is there. This is the renal ureter. It should come straight downwards beta and should open inside the urinary bladder. Right? This is the normal one. But in this patient beta, what happens basically is the ureter which is there, it takes a turn and it goes behind the inferior vena cava. Okay, mainly the right sided ureter beta. The right sided ureter takes a turn and it goes behind the inferior vena cava. And as it has gone behind the inferior vena cava beta, you can see there is obstruction basically which will be formed in the ureter. And due to this beta, there is retention of urine inside the ureter and the pelvis, causing hydronephrosis. Okay? So this is classically called as the this is what is classically called as the retrocaval ureter beta. Okay? Next condition is which is there, nothing else but BPH beta. Obviously we know BPH is kya? Benign prostatic hyperplasia. And in that benign prostatic hyperplasia, what is the problem? The prostatic urethra of the patient is getting compressed. Why the prostatic urethra of the patient gets compressed beta? Because the prostate gland which is there in this patient has enlarged. And as the prostate gland of the patient enlarges, it is going to compress the prostatic urethra. Obviously, if the prostatic urethra is compressed beta, the patient is not able to drain the urine properly. So there is extreme retention of urine inside the bladder, and therefore beta, there will be retention of urine in the ureters, causing the dilatation known as hydroureter, and ultimately there will be retention of urine inside the renal pelvis and the calyces, causing the dilatation known as hydronephrosis. So can I say over a longer period of time, even a patient of BPH may develop hydronephrosis as a complication? Yes. And last condition which is there beta, it is PUV. What is PUV? Posterior urethral valve beta. I've told you this condition already. Posterior urethral valve matlab, in the patient's prostatic urethra beta, we have a valve over here. And this valve which is there, which is present since birth beta, may not allow the urine to drain properly, and that is going to cause retention of the urine in the bladder and later on in the ureters and the pelvis, causing hydronephrosis as a complication. Clear about sub? So all of these conditions we have discussed, so it will be easier for us to grab in the upcoming questions, upcoming topics. Clinical features, if they ask you beta, obviously the patient is going to have, if there is retention of urine for a longer duration of time beta, it tends to get infected. Now water, even if it remains collected for a longer duration of time, it also gets contaminated. Obviously the urine will get infected, leading to UTI, that is urinary tract infections. Or retention of urine or stasis of urine will increase the risk of urinary stones in the patient as well beta. Clear about? That is important. If they ask you what is done for the purpose of diagnosis beta, if they ask you what is done for the purpose of diagnosis bache, so do remember beta, for the diagnosis definitely we have to go for, anybody, for the diagnosis beta, we can go for an IVP, that is an intravenous pylography beta. And when we go for an IVP or intravenous pylography bache, we are able to see this kind of appearance. Can you see over here? See, this is the appearance beta. Normally कैसा दिखता है? This is the renal pelvis beta and these are the renal calyces. ठीक है? Normally they are seen like this beta, right? A cup shaped appearance will be seen at the level of the renal calyces, right? A cup shaped appearance will be seen at the level of renal calyces. But here beta, you are not able to see a cup shaped appearance, rather you are able to see this kind of appearance beta. Rather than concavity, you are able to see convexity. Reason? Obviously there is too much of pressure, too much of urine inside the calyces beta, and therefore they have got dilated, and that's the reason beta, rather than concavity you are able to see convexity over there. And this dilated pelvis, okay, this definitely dilated calyces are seen, but this dilated pelvis and dilated calyces have this classical appearance beta, this convexity over here, and that convexity is classically called as beta, that convexity is classically called as the clubbing of calyces. इसको क्या बोला जाएगा? Clubbing of calyces. Like you have clubbing of nails ना, just like that beta, here I am able to see clubbing of calyces. So if clubbing of calyces is seen on IVP, that is what is suggestive of hydronephrosis. ठीक है? The first condition which is there, it is nothing else but duplication of renal pelvis and ureter. The second picture which is there, it is of hydronephrosis. Do not get confused during revisions. ठीक है? So clubbing of calyces will be seen. Done with this? That is important. If they ask you beta, apart from this, what are the other investigations to be done? तो याद रखना है, this you might have discussed in radiology and it is important also for your exam. याद रखना बच्चे अब से. We can also go for renal isotope scans. Yes beta, these are nuclear scans basically, which can either tell me about the anatomy, that is morphology of the kidney, the size, the shape, everything. And second, it is the functional scans beta, which can actually tell me about the function of the kidney beta, that is the glomerular filtration and all of that. Okay? If I want to see the anatomy or the morphology of the kidney beta, then we basically go for a scan called as the DMSS scan beta. We go for a scan known as the DMSS scan beta. It will tell me about the morphology of the kidney. So DMSS scan beta is nothing else but the mercaptosuccinic acid scan basically. But you just have to remember two things beta over here. कैसे? याद रखना scan के नाम में. M for morphology, right? So definitely that means this scan is used whenever I have to check any anatomical problem or morphology of the kidney. S for scarring, if I have to see any kind of scarring inside the kidney. So whenever you have to check morphology of the scarring in the kidney beta, you have to go for a DMSS scan. Clear hai? Next important beta, if I talk about the functional scans beta of the kidney, which will tell me about the GFR and everything, it is going to be the DTPA or the MAC3 scan beta. Okay, it is going to be the DTPA or the MAC3 scan beta. These are going to be the important ones. Okay, so DTPA or the MAC3 scans can be the functional scans of the kidneys beta. They can definitely tell me about the function of the GFR and everything of the kidney. If they ask you which is a better functional scan, answer is MAC3 scan. MAC3 is going to be the investigation of choice for hydronephrosis. MAC3 could be the investigation of choice in a patient of hydronephrosis. Clear about? That is important. Now if they ask you what should be the treatment in the patient beta, so yaad rakhna, in this patient of hydronephrosis beta, the treatment initially, obviously, if the dilatation is not too much beta, if the hydronephrosis is not very severe, so we can definitely go for conservative management beta. Okay, and we try to treat the underlying condition which is okay. Here in patients of hydronephrosis, whatever is the underlying condition, we see now in so many conditions the patient is having hydronephrosis. The first thing you always try to do beta is treat the underlying condition. Even after treating the underlying condition beta, if the patient's condition is going to persist, if the patient's symptoms continue even after treating the underlying condition, like for example, if it is a stone, do a stone removal, right? If it is an infection, treat that infection properly. Sorry. Or if it is definitely a PUJ obstruction beta, definitely go for a pyeloplasty surgery, right? So likewise, you have to treat the underlying condition. The hydronephrosis will get resolved with time beta. Okay. Apart from that, even if after doing all of this beta, the condition doesn't get resolved, then we can definitely go for a nephrostomy beta. Now what is stomy? Ostomy means creating opening. So nephrostomy means bache, here we actually insert a catheter inside the kidneys directly, so that all the rather the catheter inside the pelvis directly, so that all the urine which is retained over there beta, it is able to drain properly. So the nephrostomy which is done, it is done for the purpose of drainage beta. Okay, it is done for the purpose of drainage basically. That is important to be remembered. Next important beta, we can also go for a nephrectomy. Now if the kidney has been damaged, if there is scarring inside the kidney beta, then we have to go for removal of that part which has been scarred, that is nephrectomy has to be done. Clear about? So this is what is known as hydronephrosis. This is what is called as hydronephrosis. Done with this? Hopefully clear to all of you now. Now let's begin beta. Next condition which is there. Next condition which is there, it is known as a ureterocele. If I talk about an ureterocele beta, as I've already told you, ureterocele is this condition out here which is where the ureteric opening of the patient is very narrow. That's the reason the intramural or the intravesical part of the ureter undergoes a dilatation due to that pressure. ठीक है. So it is nothing else but intramural dilatation. Okay, it is the intramural dilatation of the ureter due to partial atresia. Atresia means underdevelopment or no development. So here beta, definitely the ureteric orifice or the ureteric opening is not developed properly. It is very very narrow. So due to partial atresia beta of the ureteric orifice. Okay, that is important. We know this condition which is there beta, it is going to be usually unilateral. Okay, it is usually unilateral beta, but 10% cases which are there, only 10% cases are going to be bilateral. But in your examination, whenever they have given an IVP na, they have usually given a bilateral condition. जब भी तुम्हारे एग्जाम में क्वेश्चन आया यूरेट्रोसील से, always a bilateral picture has been there. If they ask you it is more commonly seen in, so please remember uretrocele which is there beta, it could be more commonly seen in males beta. Okay, uretrocele which is there, it could be more commonly seen in males as compared to females बच्चे. ठीक है. If they ask you what are going to be the clinical features in the patient, तो याद रखना है clinical features में the first one, as there is atresia, as there is narrowing of the ureteric opening beta, the ureters are not able to drain the urine properly. That causes retention of urine in the ureter, causing hydroureter and later on dilatation of the pelvis beta known as hydronephrosis. Next important beta, as there is retention of urine over here, definitely the patient will have a higher risk of infections called as UTI, that is urinary tract infection, or the patient definitely has a higher risk of stone formations beta, right? These are the things that you need to remember. Clear about? Now important is beta, if they ask you what is going to be the investigation of choice beta, what is going to be the investigation of choice, so yaad rakhna beta, the investigation of choice in a patient of uretrocele has to be IVP itself beta, yes, or I will call it as IVU now. Why IVU? Because ureter देखना है अभी अपने को. Same investigation, just the names are different. IVU beta, if I talk about intravenous urography, and on that very very classical appearance is seen. Anybody, if you are able to name the appearance, this appearance which is there here, you are able to see now. This is the commonest question beta which has come from these topics that we are discussing. Okay, here you are able to see beta that the intramural ureter of the patient has been dilated, and due to that a classical appearance on IVP is seen beta. What is this appearance of the IVP called as? It looks like a cobra head or a adder head appearance beta. This classical appearance which is there beta, it looks like a cobra head or a adder head appearance. Okay, so cobra or an adder head appearance is classically seen in a patient of uretrocele. Yes, a very common question beta, yaad rakhna hai baat. No issues with this. Next important beta, if I talk about what is the treatment in the patient, so do remember that beta, treatment in this patient is going to be what? See, here the ureteric opening is very very narrow. One of the options is what beta? We go inside the bladder and we cut it beta. Okay, so and that's the sorry, we actually make an incision over here beta, and as we make an incision over here, definitely this ureteric opening is going to widen up. But that surgery has a problem associated with it. What? If you are going to make an incision at the ureteric opening beta, okay, it can widen up, but in case if the ureteric opening gets too wide beta, but in case if the ureteric opening gets too wide, okay, अगर गलती से ज़्यादा बड़ी हो गई, then what will be the problem? That even when the bladder will contract beta, even when the bladder will contract, the ureteric opening will not close. And as the bladder will contract and the ureteric opening will not close beta, therefore there will be a backflow of urine. That is going to cause a vesico-ureteric reflux as a complication. Okay? So if you make an incision at the ureteric opening beta, a complication of vesico-ureteric reflux could be there. Therefore, what is a better surgery then? As the ureteric opening is very narrow over here, you have to remove this ureter from here and create a new opening for the ureter in the bladder beta. Okay, that will be called as a ureteric reimplantation, right? That will be a better surgery. So that is important beta. A ureteric reimplantation could be done over here. Okay, and ureteric reimplantation can be done beta over here. That has to be remembered. Clear? So ureteric reimplantation could be done beta. No issues with this, anybody? Next important, if they ask you, if you have given an incision at the ureteric orifice, that can be a surgery which could be done. Incision at the ureteric orifice could be done. But the problem is what? In this surgery beta, there can be a chance of VUR. And what is VUR? Vesico-ureteric reflux. It may lead to vesico-ureteric reflux. Clear about? That is important. Very good. Next important beta, let's talk about a condition now that is known as a PUJ obstruction beta. Here we are all talking about the congenital conditions itself. Okay. The next condition we have to talk about is nothing else but the PUJ obstruction beta. What is PUJ obstruction? It is pelvic-ureteric junction obstruction beta. It is a pelvic-ureteric junction obstruction beta. Okay. What is a pelvic-ureteric junction? For example, this is the renal pelvis and this is the ureter. So this areas which is there beta, this is what is called as the pelvic-ureteric junction obstruction. Is patient में क्या होता है? Understand? At the pelvic-ureteric junction beta, the patient is actually having, okay, two problems. Either there can be such kind of abnormal curvature beta, right, at the level of the pelvic-ureteric junction. Either the patient is having some kind of abnormal curvature, or the patient may have an adynamic obstruction. Adynamic obstruction means here there is no contraction and relaxation beta at the level of renal pelvis. And as there is no contraction and relaxation at the level of renal pelvis beta, that is the reason the urine is not able to empty properly. Okay, that is causing retention of urine. So याद रखना बेटा, if I talk about the PUJ obstruction, that is the pelvic-ureteric junction obstruction, we have discussed definitely it is the most common congenital cause. Okay, PUJ obstruction is the most common congenital cause of which problem? PUJ obstruction is the most common congenital cause of hydronephrosis beta. It is the most common congenital cause of hydronephrosis over here. That needs to be remembered. Second important beta, you have to remember that lack of contraction and relaxation over here beta. If there is lack of contraction and relaxation, okay, if there is lack of contraction and relaxation at the pelvic-ureteric junction, definitely, then the patient is going to have an adynamic obstruction. Then the patient is going to have a adynamic obstruction beta. No issues with this. If they ask you what is going to be the investigation of choice beta, if they are going to ask you what is going to be the investigation of choice in this patient, तो याद रखना है, investigation of choice in a patient of pelvic-ureteric junction obstruction will be a IVP itself initially. Okay, it will be a IVP itself beta. The IVP can definitely give you a diagnosis. If the IVP is fails to make a diagnosis, then you can go for other investigations also beta. Okay, but IVP is going to be done. Apart from that, we can also go for a MAC3 scan just to rule out that whether the kidneys are functioning normally or not. Reason is, see, when the patient's or when the child's urine output is less now, what can be one of the possibility? Okay, one possibility can be PUJ obstruction. Another possibility, the kidneys are not functioning, right? So we have to look for that also, na, whether the kidneys are functioning or not. And for the kidney functional scans, the best one is MAC3 scan. Okay. Now when I do IVB beta, you are able to see this classical picture over here. You can see there is hydronephrosis. Why I'm saying hydronephrosis? Clubbing of the calyces is seen. Apart from that, you can see beta, the calyces normally look like lily flower. Here they are almost beta, they are so much dilated over here, right? The calyces, you can see they are so much dilated over here. So they are definitely beta. Here you are able to see dilatation of the renal calyces, dilatation of the renal pelvis beta. This is classically seen over here beta. And second thing, here after a certain point of time beta, you are not able to see the contrast itself. थोड़े time के बाद beta, you are not even able to see the contrast. That means what has happened? That means there is an obstruction in the ureter. Otherwise, there should be a complete ureter which should be visible now. Here after a certain point beta, the ureters are not visible further. Matlab, the contrast is not able to drain, the urine is not able to drain, because here there is some obstruction. And this is what? This is the pelvic-ureteric junction itself. Okay? So that is important. If they ask you about the treatment beta, what should be done? As I told you the name of surgery beta, here we have to repair the pelvis. If there is this abnormal curvature now, we have to correct that abnormal curvature beta, and that surgery. Okay, what we do in this surgery, we actually cut this part beta which is having this abnormal curvature, and then we join the remaining parts beta. Okay, so this surgery which is there beta, it is called as the Anderson-Heinz pyeloplasty. Remember the name itself, it is known as the Anderson-Heinz pyeloplasty beta. Hopefully that's clear. It is known as an Anderson-Heinz pyeloplasty. Do you remember the name of surgery? The next condition also I have discussed with you beta, and that is nothing else but a retrocaval ureter. Retrocaval ureter मैंने बोला था beta. That means, for example, the patient is having this inferior vena cava, and behind the inferior vena cava, what happens? The ureter which is there beta, it usually, the right sided ureter goes behind the inferior vena cava, and as the ureter goes behind the inferior vena cava beta, that's the reason there is blockage in the ureter, and that causes retention of urine, leading to hydronephrosis in the patient, right? So please remember retrocaval ureter जो होता है बच्चे, here the right ureter which is there, Okay, the right ureter which is there beta, it goes behind the inferior vena cava, and that leads to obstruction to the flow of urine. And as there is obstruction to the flow of urine, obviously the patient is going to develop hydronephrosis beta, and obviously all the problems associated with hydronephrosis. Then as there is hydronephrosis or retention of urine, the patient will have increased risk of UTIs as well as stones as well. If they ask you about diagnosis, what should be done for diagnosis, you can see beta, we have done an IVP. So we can do a IVP beta for diagnosis, and on that we are able to see a very classical picture. What is seen? What is this over here? You can देख पा रहे हो बेटा? Here you are able to see definitely the ureter is going behind the inferior vena cava. But when it is going behind the inferior vena cava, it is actually giving us a very classical shape beta. And this is called as which kind of ureter beta? This kind of ureter which is there beta. It looks like the fish hook, right? So this is classically known as the fish hook ureter beta. And it is classically known as the fish hook ureter, which is also called as a reverse J-shaped ureter. It is known as the fish hook or the reverse J-shaped ureter. Okay, either you call it as the fish hook or the reverse J-shaped ureter beta. Clear है बात? No issues with this, anybody? So do remember this. If they ask you beta what is the treatment in this patient, so do remember beta that the treatment in this patient is going to be what in a case of retrocaval ureter. So one thing is beta, you can just do lateralization of the ureter, and once we have done the lateralization of ureter, and we have to keep the ureters in same place beta, otherwise they will go again. So if you have to keep the ureters in same place beta, you might have seen we actually insert this kind of a stent beta. And what is this stent called as? This kind of a stent is known as a DJ stent beta. Okay, ये जो stent डालते अपन, that is known as a DJ stent. That is called as a double J stent beta. Okay, that is known as a DJ stent or a double J stent. That can also be inserted. So treatment which is there beta, it could be only a lateralization of ureter beta. And after you do a lateralization of ureter, you can definitely insert a DJ stent to keep them in the same position. Or if that doesn't help beta, the other condition is what? Cut the part which has gone behind the inferior vena cava beta and then join the remaining parts. That means go for a ureteric anastomosis. Okay, so definitely cut basically, okay, the part behind IVC. Cut the part behind IVC beta, and then bacha jo part hai beta, that we have to go for an anastomosis and anastomosis of the remaining parts of the ureter. That is a ureteric anastomosis. Clear to all of you? That is important. Now let's talk about the next condition beta. That is another problem associated with it, and that is known as VUR beta. Now what do I mean by VUR? That is nothing else but vesico-ureteric reflux. Okay, if I talk about VUR beta, that is nothing else but vesico-ureteric reflux beta. So if I talk about VUR or a vesico-ureteric reflux, bache, so do remember that this condition which is there, it is nothing else but when the urine has a backflow into the ureters beta. Okay, from the bladder, the urine go backwards into the ureters. I've told you what is the reason, because the ureteric opening is very broad beta. So vesico-ureteric reflux which is there, it is nothing else but backflow of the urine, bache. It is backflow of the urine from the urinary bladder beta into the ureters, basically leading to dilatation and leading to dilatation and development of hydroureter beta as well as hydronephrosis. Clear about that? Is important. If they ask you beta, it is more commonly seen in with sex. So please remember, up to 3 months of age beta, it could be more common in males basically, but after 3 months, the females will show the females which are there beta, they will actually start manifesting or showing the symptoms. That is the reason beta. Overall, if they ask you, it is more commonly seen in females. Okay, overall it is more common in females, and females usually start showing the symptoms more commonly after 3 months. Okay, that is important. What could be the problems or the features in the patient? The problems or the features in the patient could be hypertension, right? The patient may definitely have hypertension beta. Reason, obviously due to vesico-ureteric reflux beta, there is a severe retention of urine. That's the reason definitely beta, there is damage to the kidneys over a period of time, and as the kidneys are damaged beta, the patient is going to develop hypertension. Then as there is a constant backflow of urine beta, and there is a severe collection of urine. Okay, there's a constant collection of urine inside the pelvis and the kidneys, beta. Therefore, there will be a high chance of infection in the kidneys, and infection of kidneys is called as pyelonephritis. And due to pyelonephritis, beta, okay, if the patient will develop if the patient will keep on developing the infection of pyelonephritis again and again, obviously over a period of time, beta, the kidneys will undergo a severe fibrosis, and that will lead to scarring, beta, right? So it may progress into the level of scarring also. If they ask you what is going to be the investigation of choice, beta, so yaad rakhna, the investigation of choice in a patient of vesico-ureteric reflux is nothing else but MCU, beta. And what is MCU? I have told you, it is nothing else but a micturating cystourethrogram. The investigation of choice which is there, bache, it is nothing else but a micturating cystourethrogram. So MCU is nothing else but the investigation of choice for this condition. Clear hai baat? That is important. Done with this? That is important, beta. If I talk about the grades now, okay, if I talk about definitely, see, this is the picture of the MCU, beta. This is the micturating cystourethrogram. You will fill up the urinary bladder with a lot of contrast, and then the patient will start urinating. Now, when the patient is urinating, you are able to see the urine is coming outside, beta, but it is also going, enough amount of urine is also going backwards, and this backflow of urine, beta, is definitely showing you, the backflow of contrast is showing you that the ureters are grossly dilated, beta, and the pelvis is also grossly dilated. Okay, so please remember, beta, and due to that extreme dilatation, obviously, now due to high pressure between the ureters do not remain straight, they will become twisted, that is tortuous, right? So dilatation and tortuosity of the ureters is seen over here. Now there are 5 grades, beta, of vesico-ureteric reflux. Easy hai, yaad rakhna. The dark color which is there, beta, it is suggestive of a reflux. Okay? So grade 1 which is there, beta. In grade 1 you are able to see, beta, there is reflux which is there, but there is no dilatation as such, right? In grade 1 definitely there is reflux which is seen, beta, but there is no dilatation of the ureter. So grade 1 is reflux in a non-dilated ureter. Grade 2, beta. In grade 2 definitely you are able to see, beta, the reflux is going up to the level of the renal pelvis and the renal calyces, beta. Okay? But here there is no dilatation again. So grade 2 which is there definitely, beta, here the reflux is up to the level of the renal pelvis and the calyces, beta, but without any kind of dilatation. Next is grade 3, beta. Grade 3 may you are able to see that the reflux is up to the pelvis, but here now there is a mild to moderate dilatation which is seen. So grade 3 may, beta, you are able to see there is a mild to moderate dilatation of the ureter, pelvis and the calyces together. Okay? Next, if I talk about, beta, is grade 4. In grade 4 definitely you are able to see again the reflux is up to the level of pelvis itself, but here along with the dilatation, beta, now you are able to see tortuosity also, right? So in grade 4, beta, there is a moderate ureteral tortuosity which is also visible, beta, along with dilatation. Dilatation and tortuosity both are visible. And last one which is there, beta, grade 5. Grade 5 may you can see, beta, there is a severe or a gross dilatation of the ureter, okay, and the pelvis as well. So grade 5 mein, beta, there is a gross dilatation of the ureter, pelvis and the calyces, beta, along with a severe ureteral tortuosity. No issues with this, anybody? That is important to be remembered. If they ask you, beta, that, okay, if they ask you definitely what is the treatment in the patient, so can anybody tell me in the picture, in the MCU that is given to you, it is usually which grade of VUR, beta? Can you tell me that? It seems to be which grade of VUR? Bolo. Treatment, beta, yaad rakhna, if it is grade 1 to 3, beta, here we can just go for a conservative management, right? If it is grade 1 to 3, we can just go for a conservative management, beta. And conservative management may usually what is given? The patient will have usually risk of infections due to retention of urine, pyelonephritis ho sakta hai, therefore you have to give antibiotics, beta. Whereas if they ask you in grade 4 and 5, beta, grade 4 and 5 may we have to go for a surgical management. And what is that surgical management, beta? We know that the ureteric opening is very, very big. We have to create a new opening for the ureter into the bladder, beta, and that is called as a ureteric reimplantation, right? It is known as ureteric reimplantation. Clear hai? That is important. Very good. It seems to be grade 5, beta, right? Severe dilatation, severe tortuosity is seen definitely. It is a grade 5 UUR in the picture. Next important, if I talk about the last condition from the congenital anomalies, beta, and that is going to be medullary sponge kidney. Now, if I talk about the medullary sponge kidney, beta, yaad rakhna ye baat. that medullary sponge kidney is basically because the texture of the kidney which is there beta, it becomes like a sponge. Reason kya hai iska? Understand, because beta there is actually dilatation of the collecting ducts, okay, and as there is dilatation of the collecting ducts beta, there is retention of the urine at the level of the collecting ducts and the ducts of Bellini. So as there is retention of urine at the level of collecting ducts and ducts of Bellini beta, the kidneys which are there, that texture becomes like a sponge, as if the sponge is soaked in water. जैसे sponge को पानी में भिगो के रखोगे ना, वैसा texture हो जाता है. That is the reason it is called as medullary sponge kidney. It is dilatation of the collecting ducts beta, which leads to retention of urine inside the kidneys now. And as there is retention of urine in the kidney, obviously the patient will have a high risk of infection, that is known as pyelonephritis. The patient will have a high risk of pyelonephritis beta, or due to retention there can also be a risk of urinary stones in the patient. If they ask you what is the investigation of choice, so do remember beta, in this patients also the investigation of choice can be a IVP, that is intravenous pyelography we can do, and to check the renal function beta, we can definitely go for a MAC3 scan. Check for the renal function, again we can go for a MAC3 scan beta. Scarring waring देखने तो DMSS scan will be done, right? That we know. Okay? So that is important. And when we do a IVP beta, very classical appearance is seen. This IVP is showing me dilatation of the ducts of Bellini and the calyces beta, and it looks like the paintbrush appearance beta. This classically is known as which appearance? It is classically known as the paintbrush appearance. It is classically called as the paintbrush appearance. Done with this. If they ask you treatment beta, यहाँ पे you cannot correct the problem at the level of the collecting ducts na. So that's the reason that the treatment is usually conservative management. Whatever are the symptoms of the patient na, like UTIs वगैरह, pyelonephritis वगैरह, you have to treat that. So if there is pyelonephritis, give antibiotics. If there is stones, go for removal of the stone. So conservative treatment or conservative management will be done in patients of medullary sponge kidney. Next condition let's talk about now, and that condition which is there beta, it is actually infections of the kidney. Now if I talk about the infections in the kidney, the first infection of the kidney we have to talk about beta is known as the emphysematous pyelonephritis which is. Now emphysema is what? Emphysema is nothing else but collection of air or collection of gas. So here beta there is actually infection of the kidney and the renal pelvis, but in that condition beta, due to this infection there is production of gas. And as you are able to see beta inside the kidney, this blackish appearance which is seen na, it is basically due to the presence of gas in the kidney. Now normally you can see this is a normal kidney. So if you compare, obviously you are able to see on the affected side the kidney has been enlarged because of excessive gas inside the kidney beta. So gas production has happened due to this infection. Previous year question है exam का, याद रखना. So emphysematous pyelonephritis, it is nothing else but infection of the kidneys and the renal pelvis beta, which leads to gas formation. Okay, and obviously such a severe infection beta will not happen in an immunocompetent patient. Obviously it will happen in a patient whose immunity is weak, that is an immunocompromised patient beta. That will be important. If they ask you what is the most common cause, so yaad rakhna, whenever there is a gas forming infection na, the usual cause definitely is Clostridium perfringens beta or Clostridium vaccae. Even in gas gangrene we have studied. We will study also in patients of emphysematous cholecystitis beta. There also it is Clostridium perfringens when there is an infection of gallbladder forming gas. But in emphysematous pyelonephritis it is an exception, and this was the reason why they asked this question in your exam beta previously. ठीक है, यहाँ पे the most common cause even for emphysematous pyelonephritis is the same as UTI. What is the most common cause of UTI? Anybody? What would be the most common cause of UTI? Ask the patient, let me know that. Okay, as the patient is having definitely beta pyelonephritis or infection, the patient will have a high grade fever beta. Along with that, the patient will have lumbar pain or flank pain, and the patient will have dysuria. Dysuria is painful urination. Whenever the patient will try to urinate, the patient will have a lot of pain beta. These can be the symptoms which will be there. Anybody, what is the most common cause of UTI? That is the same one for emphysematous pyelonephritis also. So याद रखना है बच्चे, the most common cause of UTI is going to be E. coli, Escherichia coli. E. coli is going to be the leading cause beta for UTI as well as for emphysematous pyelonephritis. Shabash, yes. So that is important. If they ask you beta what is the treatment in the patient beta, so yaad rakhna, obviously if it is an infection, treatment has to be antibiotics beta, and that to IV. Okay, oral se kaam nahi chalega. We have to admit the patient and give IV antibiotics beta. That has to be remembered. No issues with this. That is important. Next important, if I talk about beta, is another condition, another infection of kidney, very very important, and that is genitourinary TB. Now, when we talk about genitourinary TB, beta, let's talk about this condition. Okay, genitourinary tuberculosis, definitely. Okay, याद रखना, TB which is there, the primary site of tuberculosis in the body is usually two of them, beta. First, the main primary site is the lungs always. The second primary site could be the lymph nodes, beta. Only these are the primary sites, beta, for tuberculosis. If the TB is anywhere else in the body, beta, it will always be a secondary infection. It cannot be a primary one. That means patient either had a pulmonary tuberculosis, and from there definitely, beta, the infection has spread to this particular organ. Same goes with the genitourinary tuberculosis, beta. Yaad rakhna that here the patient is also going to have a secondary infection itself, beta, where the infection spreads to the genitourinary tract, and the infection from the lungs usually spreads to the genitourinary tract via which route? Via the blood, that is hematogenous route, beta. Okay. So genitourinary TB, beta, is a secondary infection where it spreads via the hematogenous route. We are going to talk about both the types of TB, that is definitely renal as well as the bladder TB, beta. So yaad rakhna bache, if I talk about the renal TB, definitely, please remember what is the earliest lesion in a case of renal TB, beta. So please remember, beta, renal TB mein, if they ask you what is going to be the earliest region, so answer has to be ulcers at the renal papilla, or you can say papillary ulcers. Okay. So ulcer at the renal papilla, beta, or papillary ulcer will be the first region. Yes, as the infection starts in the kidney, beta, there is ulceration at the level of the renal papilla. That is going to be the earliest region in the case of kidneys. Now later on, what happens, beta? The infection spreads throughout the kidney, and when the infection spreads throughout the kidney, beta, there is pus formation in the kidney, and when the kidney will be having pus collection inside it, that is called as pyonephrosis, beta. Right? The patient will have pyonephrosis over here. That has to be remembered. Now, apart from the pus collection, beta, the patient will also have caseous necrosis, beta. The patient is also going to have caseous necrosis in the kidney, and as definitely, beta, there will be pyonephrosis, caseous necrosis, along with perinephric abscess also, beta. Perinephric abscess is what? Collection of pus in the capsule or around the kidneys, beta. Right? So there is collection of pus in the kidney called as pyonephrosis, around the kidney known as perinephric abscess, and definitely, beta, the patient is having caseous necrosis. We know na TB causes caseous necrosis. So the pus and caseous necrosis together, beta, will give a classical consistency to the kidneys, beta. Even somewhat fibrosis will start over here, and that classical consistency, or that classical form of kidney which is there, beta, is called as the putty kidney. I hope all of you are quite aware what is putty. Basically, that whenever you have to paint the house, beta, to fill in the cracks, basically we fill that putty, na. So that is what is called as putty. So putty kidney definitely will be there, beta. So just like that, beta, the texture will be something like that. Doughy texture will be there of the kidney. Clear it? Now later on, beta, what will happen? This infection or the inflammation is going to heal, and as the infection and the inflammation heals further, it undergoes calcification. This kidney which has been damaged, beta, it undergoes a calcification, and once it undergoes a calcification, it becomes extremely hard, beta, and this extremely hard kidney will be called as the cement kidney now. Okay, this extremely hard kidney is known as the cement kidney. Right? So initially there is ulceration, later on pyonephrosis, next is putty kidney, and last is cement kidney. And after cement kidney, beta, obviously the kidney has been completely damaged, and when the kidney completely gets damaged, beta, that is called as a nephrectomy. But here your body itself has damaged the kidney, beta, so you will call it as autonephrectomy. Okay, so here there is a self-destruction of the kidney, beta, known as autonephrectomy. Can anybody tell me autosplenectomy is a feature of which condition? Autosplenectomy will be a feature of which another condition, beta? Okay. Apart from that, beta, please remember that this patient can also have, beta, stricture and shortening of the ureter as well. Right? This patient who is there definitely can also have stricture and shortening of the ureter as well, beta. And if there is going to be stricture and shortening of ureter, beta, that can actually lead to hydronephrosis in the patient. Okay, that can lead to hydronephrosis in the patient as well, beta. Due to strictures, the urine will not be able to drain. Second, beta, you will be able to see a very small ureteric opening into the bladder, and that extremely small ureteric opening into the bladder, beta, is classically called as the golf hole ureteric orifice. That small opening into the bladder, beta, is what is called as a golf hole ureteric orifice. Hopefully that's clear to all of you. The gall for ureteric orifice in the bladder beta is very, very classical of renal tuberculosis beta or ureteric tuberculosis. Very good. Yes, sickle cell anemia mein there is autosplenectomy which is seen. Shabash. Next important beta, if I talk about it is bladder TB beta. If I talk about the bladder TB now, okay. If I talk about the bladder TB now, done with this. So if they ask you beta, what is the earliest region in a patient of bladder TB? याद रखना, earliest region in a patient of bladder TB has to be paleness of the bladder mucosa beta. ठीक है? If there is a pallor or paleness of the bladder mucosa, that is what is going to be the earliest region of urinary bladder. Here the pallor or paleness of the bladder mucosa is going to be the earliest region in a patient of bladder TB. Now, if they ask you, but if there is infection inside the bladder, definitely what is going to happen? If there is infection inside the bladder beta, there will be ulceration in the bladder, and now definitely beta, this inflamed bladder or this ulcerated bladder is going to heal. When this bladder heals beta, it will cause extreme level of fibrosis. And if there is too much of fibrosis in the bladder beta, obviously what is going to happen? The bladder is going to get contracted, the bladder is going to get narrow, right? So there will be a contracted, small, fibrosed bladder beta. That is classically called as what? That is classically known as beta the anybody? Thimble bladder beta. याद रखना, the ulcers in the bladder are going to heal with fibrosis beta, and if there is fibrosis of the bladder, the capacity of the bladder decreases, okay, and the bladder gets damaged beta, and that classical appearance of bladder is known as thimble bladder. So very, very classical appearances are seen in case of TBs beta, okay, genitourinary TB में सब भी याद रखना है. Putty kidney, cement kidney, thimble bladder, ठीक है, so that is important. Next important beta, the patient can also have a boggy granulomatous prostatitis beta, right? That means the prostate is going to enlarge due to pus formation inside it beta, and there will be a granulomatous infection. We know TB is any which way is granulomatous. So this will cause a TB in the prostate beta will cause a boggy granulomatous prostatitis beta. And this infection which is there beta in the prostate definitely will cause a very classical appearance in the prostate known as the watermelon prostate beta. Watermelon stomach we know beta was seen in which condition? Cave, gastric antral vascular ectasia. But watermelon prostate, if they ask you, answer is going to be prostatic TB beta. Clear hai? Next important, if they ask you beta, what will be the clinical features in the patient? So yaad rakhna beta, the clinical features in a patient of genitourinary tuberculosis beta. Okay, the clinical features in a patient of genitourinary tuberculosis. The earliest symptom, if they ask you, the earliest symptom has to be what, anybody? याद रखना है आपसे, the earliest symptom will always be increased urinary frequency. What do I mean by that? The patient has to go for urination again and again beta. More number of times the patient has to go for urination. That is what is called as increased urinary frequency. बार बार जाना पड़ता है. Reason beta, and this is not only the most common and the earliest feature of TB beta. This increased urinary frequency beta will be the most common symptom in all the urinary tract infections. This will be the most common symptom and earliest symptom in a patient of urinary stones, and even in case of genitourinary TB. Reason beta, whenever there is any kind of infection, okay, inside the genitourinary tract or any kind of stone in the GU tract beta, there is going to be what? Irritation of the genitourinary tract, and due to irritation of the genitourinary tract beta, the patient is going to have increased the frequency of urination. The patient is going to have increased frequency of urination. Clear about? So that is important. Clear? So do remember this beta. If they ask you what are the symptoms apart from this, so if they ask you beta what are the clinical features apart from this, so you have to remember beta. First of all, the patient is going to have pain beta, right? The patient who is there beta is going to have pain usually. Second beta, the patient is going to have bleeding, right? And if there is bleeding from the genitourinary tract, the patient will have hematuria. If there is bleeding from the genitourinary tract, the patient is going to have hematuria. There will be fever, there will be weight loss beta. The patient is going to have fever, the patient is going to have weight loss bache, and the patient may also have night sweats. Okay, there will be hematuria, there will be fever, there will be weight loss, there will be night sweats. Okay, the classical symptoms of TB usually. If they ask you urine examination, which is there, okay, we know that whenever a patient comes to us with any problems like dysuria, burning micturition, increased frequency of urination, all of these problems beta, obviously the first line investigation has to be a urine analysis. Okay, KFT मत mark करना, urine analysis has to be marked first. ठीक है, urine analysis में two things are done. One is a urine microscopic examination, and second is a urine culture and sensitivity beta, right? Now when I do a urine microscopic examination beta, when I do a urine microscopic examination, To our surprise, beta, very classical things are seen. Obviously, microscopy पे क्या क्या दिखता है? Apart from color, turbidity, and all of that, you are able to see the bacteria, you are able to see the pus cells, you are able to see the epithelial cells and the casts, beta, right? Here, definitely, but as it is an infection, I should be able to see the pus cells and the bacteria normally, right? But here, beta, I am able to see the pus cells for sure, but there is no bacteria, right? Yes, this is a specialty of genitourinary TB and a very, very classical finding, beta. As pus cells are present, but bacteria is absent on microscopic examination, beta. This is classically called as sterile pyuria, beta. Sterile, why? Because bacteria is absent. Pyuria matlab pus cells are present. Okay, so this is classically known as sterile pyuria, bache. So sterile pyuria is very, very classical term, beta, that they are going to use for TB basically. याद रखना ये बात. So sterile pyuria matlab, as I've told you, pus cells will be present, but the bacteria will be absent. Now, once definitely you have got an idea, okay, it can be a case of a TB, beta, then what should be the most sensitive investigation to be done? So do remember, beta, the most sensitive investigation that we have to do, okay, the most sensitive investigation that we have to do, beta, is a CT urography. If they ask you about the radiological investigations, which the most sensitive investigation that we can do definitely has to be a CT urography, beta. You can go for a CT urography. Okay, if they ask you what is going to be the biopsy and culture, basically, yaad rakhna, culture which is there, beta, it is going to be the gold standard investigation. Obviously, as I've told you, gold standard matlab it is not commonly done. Okay, it is not practical though. So gold standard investigation which is there, beta, it is a culture basically, and culture kiska to biopsy karke culture karoge. But please remember, beta, that is not practical, that is not commonly done. But the best one is obviously culture. Nothing better than a culture will be there, na? But yeah, it is not commonly done. It is CT urography which is more commonly done. Clear about that is important. Now, if they ask you, beta, what will be seen on this pictures? As you are able to see, the first picture is showing you a case of this is the first picture which is there, beta. It is IVP which is showing you a renal TB. Now, in this IVP, when I'm able to see the renal TB, beta, what we are able to see that these ulcers which are there, beta, they're actually causing damage to the calyces. And if, beta, due to the ulceration, the damaged calyces are seen, okay, due to ulceration, beta, you can see the calyces have been damaged. This is classically called as, beta, these damaged calyces which are there, beta, they are classically giving which kind of appearance? Anybody? They are giving a classical moth-eaten calyces. It is seen as if the calyces are eaten by some insect. किसी कीड़े ने खाया है calyces को, ऐसा लग रहा है ना? So these kind of moth-eaten calyces, beta, if they say, is a very classical feature on the IVP in a patient of renal tuberculosis. Moth-eaten calyces, beta, on the IVP is a classical feature in patients of renal tuberculosis. No issues with this. Next, which is there, beta, is a picture basically. That is the IVP or X-ray that you are going to tell me, beta. Okay, whether the next picture which is there, ye wala jo picture hai, please tell me that is the IVP or X-ray. This picture over here. What do you think? Is it intravenous pyelography or X-ray KUB, kidney ureter bladder? What do you think? Is it IVP or a X-ray? Anybody? Very good. Yes, shabash. It is definitely a X-ray KUB. So whenever, beta, you are having a confusion, always see whether first of all it is a X-ray KUB or it is a IVP. Reason I am saying it is X-ray, reason, beta, because here there is no ureter or no urinary bladder visible. If there would have been a contrast, na, then the ureter and urinary bladder would have the contrast and they will also be visible. यहाँ पे वो visible नहीं है, beta. That's the reason it is an X-ray. Reason, beta, over here definitely you are able to see. Okay, this is what is again X-ray, beta. Now again, why I'm saying X-ray, because no contrast in the ureter or the bladder, beta, is seen definitely. Therefore, this is also X-ray. But here jo X-ray, beta, in both the conditions there is something white which is appearing, beta. Okay, here definitely on the X-ray, the whitish appearance which is there, it is obviously a calcification or a stone, beta, and that is giving the shape of the renal pelvis. Now, when the calcification, okay, is giving the shape of is taking the shape of the renal pelvis, beta, it has to be a stone, beta, classically called as the staghorn calculi. Yaad rakhna, whenever on X-ray QB you are able to see a calcification in the shape of the renal pelvis, that is classically called as the staghorn calculi. But here we are able to see a X-ray, beta, which is actually showing the calcification, but that calcification is taking the shape of the kidney, beta. So whenever on X-ray QB you are able to see a calcification, bache, which is basically taking the shape of the kidney. This is classically called as the putti kidney beta, right? This is classically known as putti kidney. So please remember, putti kidney or cement kidney will appear like this. Clear? Hai? This has been a very common question in your examination. In the options, they have given putti kidney most of the times. Okay. So this is a classical appearance in a patient of putti kidney beta, where the calcification has started already in the kidney. So there is fibrosis, there is calcification, okay, everything. Clear about? So this is important to be remembered. And the last picture which is there, beta, this one. Here you are able to see, beta, the bladder which is there. Can you see the bladder has become so much narrow? It has become so much contracted, beta. It almost becomes like this, beta. This is what is called as a thimble, basically. The covering of a mic which is there, it is known as the thimble. Okay. So it is going to become like this, beta. It is going to have definitely a lot of fibrosis over the surface, and the surface is going to become very rough or irregular, just like this thimble, beta. Therefore, this kind of a bladder which is contracted, which is narrow, and which is irregular on the surface is classically called as a thimble bladder. It is known as the thimble bladder. Clear to all of you? Next important, if they ask you what is the treatment behind the patient, so yaad rakhna, the treatment in the patient is nothing else but anybody. The treatment which is there beta in the patient has to be what? We have to go for ATT. Any kind of TB beta, we know the treatment is always a ATT, that is anti-tubercular therapy. So here you have to go for an anti-tubercular therapy beta, or ATT has to be given. Okay. For a minimum span of 6 months it is given. If you feel there is a need, you can definitely extend the treatment beta. Okay. So 2 months of intensive phase, 4 months of continuation phase. Apart from that beta, what are the other interventions which may be required in a patient of genitourinary tuberculosis? So first, if there is pyonephrosis beta, or if there is pus collection inside the urinary tract, then we have to obviously drain the abscess beta, right? Then in that condition we have to drain the abscess, first thing. Next important beta, here we can also remove some part of the kidney due to beta the infection. Definitely if the kidney has got under, if the kidney has undergone damage beta, if there is definitely a putti kidney, cement kidney, okay, or a fibrous kidney, so you can definitely remove that part of the kidney beta, called as nephrectomy. Next important, you can actually go for a double J stenting also beta, right? If definitely the ureters which are there beta, those ureters are fibrosed over here, those ureters have become narrow beta. So please remember, urethral strictures अगर होंगे तो याद रखना क्यों करा जाता है double J stenting over here. If there is any kind of ureteric, if there is any kind of a ureteric stricture beta, for those ureteric stricture basically you can put a double J stent over there beta, okay, so that the urine is able to drain properly. Next important, you can also go for a ureteric reimplantation. Kiss condition mein? I told you gallful ureteric orifice. In the gallful ureteric orifice, when the ureteric opening in the bladder becomes very narrow, the urine is not able to drain properly. In that condition, you can go for a ureteric reimplantation. Or if the bladder has been contracted, bladder has become damaged or narrow beta, then we can go for an augmentation cystoplasty beta. Then we can definitely go for an augmentation cystoplasty. Clear to all of you? Want to continue with urinary stones or want to break? Jaldi batao. Break? Okay, fine. No issues with that. Take a 15 minutes break, and after the break, beta, let's talk about the other parts of. Hello, bachcho, let's start now. The next topic, which is that it is important beta for your examination point of view as well, and it is common also, and that is nothing else but urolithiasis. Now we know beta lith is nothing else but stones basically, right? So here urolithiasis means actually the stones which are formed in the urinary tract. Okay, so let's talk about urolithiasis. The urolithiasis are stones in the urinary tract. Why I'm using this common term? Because we are also going to talk about beta nephrolithiasis. That is nothing else but beta the stones in the kidneys, as well as we are going to talk about the cystolithiasis. That means stones inside the urinary bladder. Therefore, together we can call them as urolithiasis, right? If I talk about beta, the urolithiasis which is there, or the uroliths which are there beta, they can be classified into two types. These urinary stones can either be primary stones beta, or they could be secondary as well. Now please remember the primary stones which are there beta, they usually formed in a sterile urine. And where do we have sterile urine beta? Usually in the kidneys, right? So please remember, if there is retention of urine inside the kidneys beta, okay, that leads to formation of primary urinary stones. So renal stones which are there beta, those are considered as the primary urinary stones. They are formed out of sterile urine. Whereas secondary urinary stones which are there, secondary urinary stones are formed in an infected urine. Where the urine stays collected beta, usually the urine stays collected in the bladder. That's the reason beta there is chance of infection of the urine in the bladder beta. So if the stones are formed in an infected urine, those are going to be called as a secondary stones, and these secondary urinary stones are usually the bladder stones itself. That is important to be remembered, the first thing. Now let's talk about the next one. What are going to be the important risk factors for these urinary stones? The important risk factors. First one is altered urinary solutes. What do I mean by this? If beta the urine is extremely concentrated. Obviously, beta, if the urine is extremely concentrated, that means there is more amount of calcium, phosphates, oxalates inside the urine beta. Obviously, the chance of urine stone formation is actually going to increase, right? So altered urinary solutes are excessively concentrated urine beta, that you have to remember. Next is urine retention. If the patient is having a urinary retention, there will be stasis or of urine beta, which increases the risk. Next is UTI beta. There are certain urinary tract infections beta which actually increases the risk of stone formation, or prolonged immobilization for that matter. Yes, prolonged immobilization of the patient beta actually favors the retention and stasis of urine. That could be the reason. Or if the patient is having hyperparathyroidism. Why? Because we know if there is excessively increased parathyroid hormone in the body, the patient will have increase in the serum calcium levels. That means the patient will have hypercalcemia. And if there is hypercalcemia beta, obviously there will be calciuria. That means a lot of calcium will also get excreted out in the urine. Now, when the calcium comes into the kidneys beta for the purpose of excretion, that calcium may combine with the other crystals beta, and it may deposit inside the kidneys itself, leading to formation of stones, right? If the calcium combines with oxalic acid beta, okay, it can lead to formation of calcium oxalate stones, right? So similar manner mein. So if they ask you what is the most common cause of urinary stones, the most common cause of urinary stones, if they ask you, answer has to be a idiopathic hypercalciuria beta. We don't know the cause basically, but yeah, if there is hypercalciuria, that is definitely beta excessive excretion of calcium in the urine. That is actually going to increase the risk of urinary stones beta. So idiopathic hypercalciuria is going to be the most common cause of urinary stones. Next important, if I talk about, if they ask you beta which are going to be the most common type of bladder stones, तो याद रखना है बेटा, if they ask you the most common type of bladder stones as well. Previously थोड़ा अलग था, but now the most common type of bladder stones are also the same beta, that is your calcium oxalate stones, right? Calcium oxalate stones beta are the most common type of renal stones as well as the most common type of bladder stones beta. The first thing to be remembered. Second thing to be remembered is which are the most common type of bladder stones in children. So if they ask you most common type of bladder stones in children बच्चे, तो याद रखना the most common type of bladder stones in children are called as the mixed urate stones beta. Okay, so most common type of bladder stones are usually mixed urate stones in children beta. Urate is uric acid. Clear about that is important. Now if I talk about beta, the next one, that is the renal stones. Okay, this was about the bladder stones beta. Yes, there is chance of bladder stones. I'm not saying there is not a chance, but the chances of bladder stone are slightly less as compared to the renal stones. Renal stones are going to be much more common. Now let's talk about beta, the next topic, and that is renal stones. So renal stones are also a type of urinary stones beta. Let's talk about the various types of the renal stones now. Let's talk about the various types of renal stones, बच्चे. The first type of renal stone that we need to remember beta, it is the calcium oxalate stones. याद रखना the calcium oxalate stones which are there. Okay, the calcium oxalate stones which are there beta, those are considered as the most common type of renal stones. And now we know that calcium oxalate are not only the most common type of renal stones, but rather they are also the most common type of bladder stones. So we can say calcium oxalate are the most common type of urinary stones itself, right? Now these calcium oxalate stones, which is there, as I've told you, it forms when the calcium and the oxalic acid combines together. It is usually formed of two types of crystals, beta. Yes, every stone is going to be formed out of crystals, right? So, beta, please remember there are two types of crystals which may make up a calcium oxalate stones. Either it can be formed out of a monohydrate crystals, beta, or it can be formed out of a dihydrate crystal. Please remember, if the calcium oxalate stone is made up of monohydrate crystals, beta, if it is made up of monohydrate crystals, याद रखना ये बात, it will be with shape. Reason is beta, when you do a urine analysis or a urine microscopic examination, on that beta, if the patient is having renal stones, you will be able to see these crystals of the stone inside the urine. And depending on the shape of the crystals beta, you should be able to tell that definitely the patient is having which kind of urinary stones beta. Clear about? So you have to remember the shape beta. Monohydrate crystals which are there beta, those are going to be dumbbell shape. The monohydrate crystals which are there bache, those are definitely going to be dumbbell shaped beta. Okay, if they say dumbbell shaped crystals, we are right now the dumbbell shaped crystals which are there, those are usually seen in the monohydrate stones beta. Whereas if they ask you that dihydrate crystals which are there, those are going to have which kind of crystals? Those are going to have envelope shaped crystals beta. ये जो dihydrate crystals होते हैं calcium oxalate, they basically have a envelope shaped crystals बच्चे. Clear है? If they ask you which one are more common out of the monohydrate stones and the dihydrate stones, which one are more common? Do you remember that the dihydrate calcium oxalate stones are going to be more common? The dihydrate calcium oxalate stones beta are going to be more common beta. Clear about? If they ask you beta that these stones are formed in which pH of urine, whether it is the acidic pH or alkaline pH, do you remember that calcium oxalate stones are usually pH insensitive? What do I mean by this term? That means beta, these stones can be formed in any form of these stones can be formed in any pH of urine beta, whether it is acidic or alkaline does not matter. Next important beta, this stone which is there, the calcium oxalate stone, is going to have these kind of margins beta. What are these kind of margins called as? Spike like margins beta or speculated margins. As the calcium oxalate stones has these speculated margins beta, that's the reason when these calcium oxalate stones are going to pass by the urinary tract, due to the spikes, definitely beta, the urinary tract of the patient will get damaged. And if the urinary tract of the patient is damaged, the patient is going to have a lot of bleeding from the urinary tract, right? And that will also cause a pain. So please remember, if a patient is having calcium oxalate stones beta, because of that speculated margins, patient has a lot of pain, as well as the patient can have bleeding beta from the urinary tract, leading to hematuria. Clear about? Next important, if I talk about beta, is please remember that calcium oxalate stones are seen in which patients? You might have studied this in biochemistry beta. याद रखना, the calcium oxalate stones are usually seen in patients who are suffering from a condition called as anybody? Hyperoxaluria, right? It is a glycine amino acid metabolism defect beta, and in that patient of hyperoxaluria, definitely you are able to see excessive oxalic acid excreted from the urine, and that is the condition beta which can actually increase the risk of calcium oxalate stones in the patient. Let's talk about the next type of stones beta, and the other type of stones which are there. Okay, and that is nothing else but triple phosphate stones beta. Okay, then other types of stones are definitely the triple phosphate stones, also known as the struvite stones beta. Okay, the other ones are known as the triple phosphate stones, also known as struvite stones. Now why we call them as triple phosphate? Reason beta, they are usually made up of, or they are usually composed of three types of phosphate, that is calcium phosphate, magnesium phosphate, and ammonium phosphate beta. As they are composed of calcium, magnesium, and ammonium phosphate crystals beta, that's the reason definitely they are called as triple phosphate stones. Now all these crystals which are there beta, the triple phosphate crystals which are there, they will be wish shaped. So do remember beta, these are going to be coffin lid shaped beta. Okay, these crystals which are there definitely beta, they are usually coffin lid shaped. Okay, so the triple phosphate stones which are there beta, they are going to be definitely coffin lid shaped crystals. That has to be remembered. Okay, next important, if I talk about beta, that the triple phosphate of the steroid stones are usually formed in which kind of urine? So याद रखना बेटा that the triple phosphate of the steroid stones beta they are usually formed in an alkaline urine beta. They are usually formed in the alkaline urine. And please remember there is an infection beta. There is a urinary tract infection which makes the alkaline urine. And as it makes the urine alkaline beta, therefore it increases the risk of triple phosphate stone. That has been a very, very common question of your examination. Which is that urinary tract infection, or which is that bacteria that actually makes the urine alkaline beta and increases the risk of triple phosphate stones in a patient? Very common question of your exam. Do remember henceforth beta, that infection which is there beta, it is nothing else but Proteus infection or the Proteus mirabilis infection. Okay, so याद रखना triple phosphate stones which are there beta, the risk of triple phosphate stones will be high if the patient is having an infection of an organism known as Proteus mirabilis. Okay, if they say beta the triple phosphate stones, do remember the triple phosphate stones usually have a silent presentation. Now what do I mean by a silent presentation beta? That means they do not cause symptoms usually beta in the early stages. Yes, they may not cause any symptoms in the early stages beta. So therefore these stones which are there, they are going to have a silent presentation in the early stages. So what happens? Definitely they definitely grow beta, and as they grow they take the shape beta. As they grow they takes the shape of a pelvic calyceal system. As they grow they take the shape of the pelvic calyceal system. That has to be remembered. No issues with this, anybody? That is important beta. And when the stones are going to grow beta and they are going to take the shape of the pelvic calyceal system, do remember that beta, then it will be called as what? Anybody? As I told you, this triple phosphate stones you can see beta, definitely as they have silent presentation, they will keep on growing in size and they will grow so much big that they are actually taking the shape of the renal pelvis and the renal calyces beta. And now these are called as the classical staghorn calculi beta, right? These will be known as the classical staghorn calculi which. So याद रखना the triple phosphate stones may grow big in size and that will lead to formation of staghorn calculi. Hopefully that's clear to all of you now. That is important. Next important beta if I talk about are the cystine stones next. Cystine stones which are there beta, you have to remember that these cystine stones are usually are the hardest renal stones beta. These cystine stones which are there beta, they are considered as the hardest renal stones. They are not easy to break beta. Whereas please remember these cystine stones is made up of which kind of crystals beta? Usually the cystine stones beta have this shape of crystals. Okay, the hexagonal shaped crystals, or we can say it looks like which ring beta? The benzene ring, right? So please remember beta, if they say either a hexagonal shaped crystals, if they say beta either a hexagonal shaped crystals or the benzene ring shaped crystals beta, okay, will be seen in which condition? So answer has to be the cystine stones beta. In cystine stones beta, we have to remember there will be either hexagonal shaped or the benzene ring like crystals. Clear about that? Has to be remembered. If they ask you beta that the cystine stones are formed in which kind of urine, so do remember bache that the cystine stones are usually formed in an acidic urine. Okay, the cystine stones which are there beta, they are usually formed in an acidic urine, and it is seen in which condition? It is usually seen in a condition beta that is called as a cystinuria. Yes, cystine, not cystine. I hope you are quite aware from biochem. Cystine means two cysteines coming together. That forms a dibasic amino acid known as cystine. So when the patient is going to have a cystinuria beta, excretion of cystine from the body, that condition known as cystinuria is the condition where the patient can develop cystine stones. And I hope all of you are quite aware that in patients of cystinuria beta, there is a cola urine, not a cola colored urine beta. Cola urine matlab cystine, ornithine, lysine and arginine. These are the dibasic amino acids which are excreted in the urine. Therefore, it is called as cola urine. Alag ya dono. Okay? So that has to be remembered. In these patients, definitely beta, the patient will have a high risk of formation of cystine stones. Next important beta, if they ask you that uric acid basically, now the last stones which are there beta, those are usually formed of uric acid or the urate, you can say. It's one and the same thing. So if they say beta uric acid stones or the urate stones, that has to be remembered. These stones which are there beta, sorry, these stones which are there beta, they are usually soft stones beta. Yes, they are actually going to have soft surface beta. They are going to be softer stones, and they are, please remember, these stones which are there beta, they are usually seen in patients who are having high levels of uric acid beta. Okay, and these stones which are there, they are radiolucent. What do I mean by radiolucent? I've told you earlier, radiolucent means they will appear black on X-ray or a CT. And if they will appear black on X-ray or CT beta, obviously they are not going to be visible. That's the reason beta we may not be able to see the uric acid stones properly on X-ray beta. Yaad rakhna, there are only few renal stones which are radiolucent. Majority renal stones which are there beta, those are going to be radio opaque. That means they will appear white on X-ray or CT. Therefore, the investigation that is done for a renal stones beta or the urinary stones is going to be a X-ray and a NCCT itself. But beta, for some stones it may not be visible. Gallstones में उल्टा है बेटा. Gallstones में 90% stones are radiolucent, which will appear black. That's the reason gallstones में investigation of choice is not X-ray or CT. Over there in gallstones, the investigation of choice is an ultrasound abdomen. Clear है बात? So we know beta that these uric acid stones are usually formed in which kind of urine? The uric acid stones are formed in an acidic urine. By the name it is evident, and it is usually seen in patients beta who are definitely having what? Hyperuricemia beta. It is usually seen in patients who are having hyperuricemia. Now, hyperuricemia is usually seen in which patients? Increased uric acid levels in blood. It is usually seen in patients who are having gout beta, right? It can be seen in patients who are already suffering from gout, or it can be seen in patients beta who are usually suffering from tumor lysis syndrome, right? You have given a chemotherapy and after that the patient has developed a tumor lysis syndrome. In those patients it could be seen. It can be even seen in patients in biochemistry. You might have studied HGPRTS deficiency. It can be even seen in those patients of Lesch-Nyhan syndrome, right? In all these conditions, wherever there is hyperuricemia in the body beta, in those conditions definitely you can see the uric acid stones beta. Okay. Now, if they ask you what is the shape of crystals in the uric acid stones, yaad rakhna, the shape of crystals of uric acid stones is irregular beta. Yes, the shape of the uric acid stones which is there beta, it is irregular, it is not fixed. Okay, we can also call it as universal shape. The shape of uric acid crystals which is there beta, it is irregular or it is universal. Okay, it can be various shapes beta. ठीक है, अब देख लो एक बार यहाँ पे. Here you are able to see all the crystals beta. Okay, what is seen in this crystals now? The first one, we are able to see which type of crystals beta. The envelope shaped crystals are seen, and we know envelope shaped crystals are usually the calcium oxalate crystals beta. Which one, monohydrate or dihydrate? It is the dihydrate calcium oxalate crystals beta, which are going to be much more common. Monohydrate calcium oxalate crystals will be dumbbell shaped bache. Next important, here you are able to see coffin lid shaped crystals beta, and we know that coffin lid shaped crystals which are there, they are seen in triple phosphate or the struvite stones beta, and these struvite or triple phosphate crystals which are there, they are coffin lid shaped beta that you are able to see over here. Okay, so that is important. Next important, these are the hexagonal or the benzene ring shaped crystals beta. The hexagonal or the benzene ring shaped crystals are seen in cystine stones beta or the cystine crystals. Then these are the irregular shaped crystals. You can see some are flower shaped beta, some are definitely rhomboid shape, some definitely can be rectangular in shape. Okay, some can be needle shape. Any kind of crystals beta, those are the irregular or the universal shaped crystals. Those are uric acid crystals. Uric acid crystals in the joints, they are needle shaped beta. ठीक है, joint में जो होता है, those are needle shaped. In the kidneys which are there beta in the patient of stones, those will be irregular or universal. ठीक है, do not get confused between both of them. These are the various types of renal stones that you have to have an idea about. Now let's talk about the next one. What will be the clinical feature in my patient beta? If they ask you what is the clinical feature, तो याद रखना, I've told you beta that whether it is a case of an infection beta or a stone in the urinary tract, the earliest manifestation or the earliest feature is going to be only one, and that is increased urinary frequency beta. The patient will always have an increased urinary frequency because the stone or the infection will cause irritation of the urinary tract, and that's the reason the patient will get a recurrent urge to urinate. So increased urinary frequency will be the earliest symptom in the patient. Now, if the stone is very, very small in size beta, the patient may not develop any kind of symptoms. That means the patient may be completely asymptomatic, and then it could be an incidental diagnosis, right? You might have seen a lot of times what happens. You have done an ultrasound beta for some other reason, and on that ultrasound you get to know, okay, that you are having stone. Next important, we know beta that if the renal stone is bigger in size, definitely if these urinary stones are bigger in size beta, obviously they are going to cause a lot of pain. Depending on the location of pain beta, I'll be able to see, okay, depending on the pattern of pain, we will be able to tell that what is the site of the stone beta, where is the stone usually present in the whole urinary tract. Okay, we'll talk about that in a while. Apart from that, if the stone is going to cause blockage in the flow of urine beta, there will be retention of the urine causing dilatation of the pelvis and chelicus, known as hydronephrosis. We have rather discussed that the most common acquired cause for hydronephrosis has to be stones. And beta, stones may, which is there beta, it will cause retention of urine and thereby increase the risk of urinary tract infections as well. Okay. Now, if they ask you beta, these are the various sites, these are the various patterns of pain beta, and depending on that, we will be able to suspect that what is the likely location of the urinary stone. Let's talk about that. The first one, if they say beta, the patient is having a fixed lumbar pain. Okay, fixed lumbar pain means the patient is only having pain in this lumbar region beta, or only in this loin or the flank region. That's it. So if the patient is only having a fixed lumbar pain beta, that is suggestive of a kidney stone beta. If the patient is having a fixed lumbar pain, that is what is suggestive of a kidney stone in the patient. Done with this. Next important beta, if I talk about, if the patient is having beta a lumbar pain, okay, if the patient is having a lumbar pain beta which is radiating, okay, the patient is having a lumbar pain which is radiating to the perineum in males, perineum in females beta, and scrotum in males. If the lumbar pain radiates to perineum in females and scrotum in males, yaad rakhna, as soon as the lumbar pain starts radiating, you have to have an idea that now the stone has come inside the ureters beta. Yes, kidney में जब तक stone है, the pain will not radiate, but as soon as the pain radiates beta, you have to remember that the stone is in the ureter now. ठीक है? So here beta, if the patient is having a lumbar pain radiating to the perineum in females or scrotum in males beta, here you have to remember it is usually in the upper 1/3 of the ureter beta. Okay, the stone usually is in the upper 1/3 of the ureter then. Okay, then it is a ureteric calculi. No issues with this, anybody? Next important beta if I talk about, and that is if the patient is having a lumbar pain beta radiating to the inner thigh. If the patient has a lumbar pain beta radiating to the inner thigh, then what is the diagnosis? What is the location? So please remember, if the patient has a lumbar pain radiating to the inner thigh beta, then you have to remember the suspected location which is there. It is going to be, anybody, the suspected location which is there beta, it is going to be at the level of pelvic brim. Then it is going to be at the level of pelvic brim beta. No issues with this. Next important, if they ask you beta, that if the patient is having a lumbar pain beta, what is pelvic brim? I hope all of you are quite aware that when the ureter usually crosses the crest beta, okay, at that level. Lumbar pain radiating to the same sided iliac fossa beta. So if the patient is having a lumbar pain radiating to the same sided iliac fossa beta, so the patient is having a pain, lumbar pain radiating to the iliac fossa, then definitely remember that the patient is actually having the stone beta in the middle 1/3 of the ureter. Then the patient is having the stone beta in the middle 1/3 of the ureter. Hopefully that's clear. Next important, if the patient is going to have beta a painful desire to pass the urine. Okay, if the patient has a painful desire to pass the urine beta, that is called as strangury. Okay, the patient wants to pass the urine beta, but the patient has a lot of pain. Okay, that is classically known as strangury beta. So yaad rakhna, strangury is seen definitely when the stone is actually obstructed beta at the level of the intramural part of the ureter. What do I mean by this? When the ureter is going to open into the bladder. Okay, so when the ureter opens into the bladder beta, at this level definitely if the stone is obstructing, that is what is called as the intramural part. Okay, so when the stone is in the intramural ureter, okay, or the intravesical ureter, in that side definitely the patient will have a strangury beta. Next important, if they ask you that when the patient has a suprapubic pain, do remember beta, suprapubic pain which is there, it is usually seen, okay, suprapubic pain which is there beta, it is usually seen in the case of a bladder stone. So if the patient is going to have a bladder stone beta, then the patient is going to have a suprapubic pain. Whenever the patient will have a bladder stone bache, the patient is going to have a suprapubic pain. Next important, if they ask you beta, that in which condition definitely, okay, in which condition definitely beta, the patient will have a suprapubic pain referred to the tip of the penis. So please remember, if the patient is having a suprapubic pain beta, suprapubic is this one, when the patient has pain over here. When the patient is having a suprapubic pain beta referred to the tip of the penis or radiating to the tip of the penis, that is suggestive. Either the stone is in the neck of the bladder beta, either the stone is at the level of the bladder neck, or the stone is inside the urethra beta. Either the stone is inside the bladder neck or the stone is inside the urethra. Hopefully that's clear to all of you now. That has to be remembered. Okay? So can you see with the pattern of the pain beta, you can definitely tell that what is the location of the stone. Clear about that is important. Next important beta, if they ask you that 90% of the renal stones which are there, do remember beta, we know that 90% of the renal stones which are there beta, those are radio opaque बच्चे. Radio opaque मतलब those will appear white on the CT or X-ray beta. Okay? Whereas please remember beta that only 10% of the renal stones which are there beta, those are going to be radiolucent. Only 10% of the renal stones which are there beta, those are going to be radiolucent. No issues with this. If they ask you about the first line investigation, so do remember the first line investigation in my patient. Okay, do remember the first line investigation in my patient has to be X-ray, right? Because 90% stones, if they are radio opaque beta, I can easily pick them up on X-ray. The first line investigation will be X-ray beta, and this is what is called as a X-ray KUB, that is X-ray kidney, ureter and bladder. Okay, the X-ray KUB will be my first line investigation. But if they ask you beta what is the investigation of choice, obviously X-ray cannot be the best investigation, right? So if they ask you investigation of choice beta, we know the investigation of choice has to be a CT scan. But to look for a stone beta, I do not need any contrast, so it should be a NCCT beta, that is a non-contrast CT scan. So it should be a NCCT KUB. Non-contrast CT scan beta of the kidney, ureter and bladder is the investigation of choice in the patient. Now in the first one beta, the first image which is there, it is actually showing you the X-ray, and on this X-ray you are able to see beta that the stone has grown so big that it is actually taking the shape of the renal pelvis. We know this is usually seen beta when the patient has silent presentation in the early stages of the stone, and these stones which have taken the shape of the renal pelvis beta are classically called as staghorn calculi beta. These stones which have taken the shape of the renal pelvis beta, they are classically known as the staghorn calculi. And हमें ये भी पता है that which stone usually develop a staghorn calculi. The stones which develop into a staghorn calculi beta are going to be the triple phosphate stones or the struvite stones, right? That has to be remembered. Next important beta, you are able to see a NCCT in the next picture, and on this NCCT beta, you are able to see in the inferior calyx of the kidney beta, we are able to see the stone beta. Clear about? Chalo. Now this is also X-ray beta, and on this X-ray actually there are two X-rays. This is the first one, this is the second one beta. Okay, in both the X-rays I am able to see a whitish appearance. That means in both the X-rays there is a calcification which is seen. But which calcification is basically a giant bladder stone and which calcification is basically a calcified fibroid beta in a female? That has to be differentiated. So this was a previous year question, and the most common ones where the people got confused was either it is a bladder stone or it is basically a calcified fibroid beta. तो अब याद रखना है, here definitely the calcification that you are able to see on this X-ray is in the center of the pelvis or in the periphery, right? It is in the center of the pelvis, first point beta. Second, you are able to see beta that this calcification which is seen beta, the calcification is uniform or non-uniform. It is uniform, पूरा सफेद दिख रहा है ना अच्छे से, ठीक है? So definitely this is a uniform calcification, that is called as a homogeneous calcification or homogeneous opacity. So please remember beta, here in this picture I am able to see that the calcification which is there, okay, or the opacity which is there, definitely beta, it is a homogeneous one. And when there is a homogeneous calcification or a homogeneous opacity beta, that has to be a stone itself. Okay, that has to be a stone. So this is a classical picture of a giant bladder stone beta. Right, this X-ray which has come in your examination earlier was actually a picture of a giant bladder stone. ठीक है, तो कैसे पहचानना है? First, it will be in the center. Second, it will have a homogeneous opacity or homogeneous calcification. Next, if I talk about beta, the other picture that is there, the other picture which is there beta, this one here, it can be in the periphery, it can be in the center. So the location is not fixed as such. Second important, you are able to see beta, the calcification which is there beta, is it homogeneous or heterogeneous? Right, here you are not able to see a uniform calcification. There are usually whitish dots all over. So this is definitely a heterogeneous calcification, right? So here we are able to see a heterogeneous calcification or a heterogeneous opacity in the patient, right? There's a heterogeneous calcification or there is a heterogeneous opacity in the patient beta. Heterogeneous, sorry. Okay. There's a heterogeneous calcification or heterogeneous opacity, and this condition which is there beta, it is a case of a calcified fibroid beta. ये जो picture है definitely this is actually a case of a calcified fibroid. So when there is calcific degeneration in the fibroid, you might have studied in gynae na. So this is actually a picture of calcified fibroid. And what is this sign classically called as beta? This calcified fibroid which is there, it gives a very classical appearance. And what is this appearance called as? This appearance is called as the womb stone appearance beta. It doesn't appear what in को के patient की कोख में बहुत सारे पत्थर पड़े हुए हैं. Womb stone appearance it is classically called as. Clear to all of you? That is important. Now, let's start with the next one. Done with this, hopefully clear to all of you now. Now let's start with the management of the patient beta. Now if I talk about the management in this patient, okay, if I talk about the management of my patient beta, then okay, what should be the first line management beta? So yaad rakhna, in all the patients of urinary stones, the first line management which is there, bache, you have to definitely advise some things to the patient beta. Okay, you have to definitely advise few things to the patient. And what is that? So first line is always a conservative management. We do not immediately jump off for a surgery. The first line when we go for a conservative management in a renal stone beta, what is that management? What are we going to recommend altogether? The conservative treatment mein beta, we have to recommend the patient to definitely take beta what analgesics, because the patient is going to have a lot of pain, so you should give painkillers to the patient beta or analgesics to the patient. Second thing that you are going to recommend beta could be a syrup alcohol. There can be multiple syrups. I'm just saying one of them. You can give a syrup alcohol to the patient beta, and that alcohol syrup can actually help in definitely beta neutralizing the stone. Okay, it can actually help in neutralizing the stone beta. Just have to remember that. You have to mix it in water and you have to take it every day beta at the night time. So it actually can help in neutralizing the stone beta or dissolving the stone, but it can only dissolve smaller stones beta. Larger stones cannot be dissolved. ठीक है, याद रखना है बात. And the most important advice you will give the patient is plenty of fluids. Yes, the patient has to take plenty of fluids beta. Reason, if the patient will take plenty of fluids, definitely the urine output of the patient is going to increase. And if the urine output of the patient is more beta, okay, the urine of the patient is diluted, it is not concentrated, first thing. Second important beta, as the urine output is more, definitely those crystals which will be there in the urine beta, they will not deposit, they will get washed off from the kidneys. Okay, and if the crystals do not deposit, the stones are not going to form. Clear about? Next important beta, if they ask you what should be the treatment in the patient now, okay, so definitive treatment if they ask you beta. So first of all, let's talk about renal stones or kidney stones beta. Now when my patient is having a renal or a kidney stone, if the stone is less than 5 to 6 millimeters in size, if the stone is going to be less than 5 to 6 millimeters in size beta, majority of the patients will be asymptomatic. And even if the patient is symptomatic beta, mild symptoms would be there, you can just go for an observation beta and the conservative management, right? So you can just go for observation and the conservative management that we have discussed over here. Okay, that is nothing else, but you can definitely give syrup alcohol, analgesics, and plenty of fluids will be advised. I hope all of you might have heard as well that beer drinking is definitely going to be helpful in patients of renal stones. So the logic behind that is basically, we do not advise that, but still, what is the logic behind that? That is, beer basically is going to be a diuretic beta. It increases the urine output, and that's the reason definitely it can actually help in washing away those crystals. But again, it is not recommended. The observation and conservative management is recommended beta for a small renal stone less than 5 to 6 mm in size. Next important beta, if they say the stone is going to be more than 5 to 6 millimeters in size, bache, so if the stone is more than 5 to 6 mm in size, then we have to go for a surgical option beta. And there are two surgical options for a renal stone or a kidney stone beta. One is ESWL. What is ESWL? It is an endoscope, it is an extracorporeal shock wave lithotripsy beta. What is that? So here beta, from outside the body, you can see you are actually going to fire shock waves beta onto the stone. And as you are going to fire the shock waves onto the stone beta in the kidney, that stone will get fragmented. Yes, that stone will get broken down into multiple small pieces beta. And once that stone has got broken down into multiple small pieces beta, that stone is going to come out with the help of urine itself, right? So you will go for ESWL in the patient, and after that you will give a lot of fluids to the patient so that the patient's urine output increases. And with the urine beta, all these small fragments or the pieces of the stones are washed out. Clear about that is what is done. So this surgical option which is there beta is known as ESWL. So do remember ESWL is nothing else but extracorporeal, that is outside the body shock wave. We are actually using a sound waves beta which are very very intensive. Okay, shock wave lithotripsy, that is breaking down a stone. Okay, so do remember ESWL is the option that is used now. As I've told you, ESWL mein, I've told you the definition what it is. It is nothing else but ultrasonic shock waves beta. It is nothing else but the ultrasonic shock waves definitely, which are going to be fired beta, which are fired directly onto the stone, and as they are fired onto the stone beta, the stone which is there, it gets fragmented into pieces. So there is fragmented stone beta, and these fragmented stone pieces which are there beta, they align themselves in a ureter. Okay, they usually align themselves in a ureter beta. Why? Because they have to pass in the urine. Okay, they align themselves in the ureter to pass in the urine beta. So when definitely you will be doing a ESWL, and after the ESWL, when these fragments of the stone will try coming outside beta, when these fragments of the stone will try coming outside, you are able to see beta in the ureter of the patient. Okay, you are able to see this classical fragments of the stone beta, okay, coming outside, and this fragments of the stone when they are aligned themselves in the ureter, this phenomena is classically called as, previous year image based question, yahi x-ray aaya tha tumhare exam mein, and they asked what is this called as. So after ESWL, when the fragments of stone they align themselves in the ureter beta to pass out, this is classically known as the Sten-Strasse phenomena beta. This is classically known as the Sten-Strasse phenomena. So Sten-Strasse is nothing else but the line of stones basically, or a street of stones. Okay, literally this means a street of stones basically. That is what is Sten-Strasse phenomena. Okay, now in all the conditions we will be able to do a ESWL or what? No beta. There are certain contraindications also of ESWL that you have to remember beta. Okay. Now important is, if they ask you ESWL was done in a patient, what could be the important complication? So if they ask you beta, if ESWL is done, what can be the complication? One complication can be, as we have just broken down the stone beta and now the fragments of the stone are coming outside. See, it is not in our hands beta that how many pieces of that stone are going to happen. Okay, and if there is a piece of stone beta which gets obstructed in the urinary tract, that can be a complication as well, right? So please remember the most common complication which is there beta, it could be obstruction basically, right? The most common complication which is there beta, it could be obstruction basically beta. Pain can also happen, yes, pain can also happen, but a common complication could be obstruction as well. Okay, apart from that beta, the patient will have hematuria and the patient will have UTI also beta, right? The fragments of the stone which are there, they may be sharp and therefore they can cause bleeding from the urinary tract beta. Okay, and the patient may have a risk of UTI also. Now, if they ask you what are the contraindications of ESWL, what are those conditions where ESWL cannot be performed? Let's talk about them one by one. So, the contraindications of ESWL beta, you have to remember, first and foremost has to be pregnancy. Obviously, beta, such strong shock waves, can we use them in pregnancy? No. So, pregnancy is a contraindication. Next, if a patient is already suffering from bleeding disorders beta, what are bleeding disorders? For example, patient is having hemophilia, thrombocytopenia, any of these bleeding disorders beta. Obviously, in that condition, if we do a ESWL, those fragment of the stones may cause bleeding, and if there is a bleeding disorder already beta, the patient may have massive bleeding or massive blood loss. That's the reason beta. Next, if there is a distal obstruction, why? Because here we are just breaking down the stones inside this surgery beta, okay, and the stones are going to come out on their own along with the urine. But if there is a distal obstruction, samjho you have broken down the stone in the kidney, but there is an obstruction in the ureter itself or the urethra, will the stone fragments be able to come out? No. Next important beta, if there is a cystine stone. Reason, cystine stones are the hardest renal stones we have discussed, and they cannot be broken down by just shock waves beta. Okay, they have to be removed surgically. If there is a stone in the inferior calyx beta, reason, if there is a stone in the inferior calyx bachche yaad rakhna, it is very difficult for the stone basically, or these fragments of the stone to come outside. Okay, and lastly, if the stone size is going to be more than 1.5 to 2 centimeters beta. If the stone is larger in size, more than 1.5 to 2 centimeters, then it is difficult. Okay, so important contraindications yaad rakhna: pregnancy, the stone size more than 1.5 to 2 centimeter, cystine stones. These are the important contraindications that you have to remember for your exams. Others are also important. These are the important ones. Next important beta, if I talk about if ESW is contraindicated, then what are the options with us? So in a patient of renal stone beta, if ESWL cannot be done, the other treatment options if they ask you beta, one is definitely going to be PCNL. Now what is a PCNL bache? PCNL is nothing else but a percutaneous nephrolithotomy. Yes, we have to go via the skin beta. Obviously from the lumbar region we will directly enter, and we will actually enter with a nephroscope beta. Under the ultrasound and CT guidance beta, that nephroscope will directly go into the patient's kidneys or into the patient's renal pelvis, and from there we are going to extract or remove the stone beta. Clear about? So that is important. So it is known as a percutaneous nephrolithotomy beta. Okay. So if there is a larger stone or if ESWL is contraindicated due to any reason, then we can go for a percutaneous nephrolithotomy. Hopefully that's clear to all of you now. Now in this it is a surgery beta which is preferred. We directly insert a scope, a nephroscope in the kidney, and we remove the stone beta. So in which conditions it will be preferred? Usually it is preferred beta in a patient who is having a distal obstruction. Why? Because in distal obstruction beta, I cannot insert with a catheter from the urethra, okay, and I cannot remove the stone. So therefore directly remove the stone. Or if there is a very large stone beta, because if there is a very large stone, I cannot remove it from the urethra. Okay? So if there is distal obstruction or a large stone beta, then PCNL is going to be the preferred surgery in the patient. But if it is a smaller stone beta, okay, but ESW is contraindicated, like for example pregnancy cystine stone in these conditions the stone is not very big, okay, and there is not any distal obstruction also, but ESW is contraindicated. So in these conditions beta, I can also go for any other surgical option, and that is called as a retrograde intrarenal surgery beta. Okay, and this retrograde intrarenal surgery is what beta? Do remember that we will actually insert a catheter via the patient's urethra. From urethra the catheter will go into the bladder, from bladder into the ureter, from ureter up to the renal pelvis beta, and from there it is actually we are going to remove the stone. So here we are not directly going via the skin beta, we are actually going via the natural route beta, and this is what is called as a retrograde, because we are going in a backward manner. Retrograde intrarenal surgery beta, also known as a rhinoscopic lithotripsy. Okay, we can also call it as a rhinoscopic lithotripsy beta. Clear about that? Is important beta. It is also known as a rhinoscopic lithotripsy, and it is usually done with the help of what beta? It is usually done with the help of a Dormia basket. Basket हो गया वो. Okay, Dormia basket you have to remember, or with the help of a holmium laser. Okay, either with the help of a Dormia basket or with the help of a holmium laser. With the help of holmium laser you can break down the stone, or with the help of Dormia basket beta we can actually remove the stone. How? Understand. For example, this is the patient's renal pelvis and the ureter. Okay, the patient's renal pelvis and the ureter beta. Here basically the patient is having a stone. What we usually do beta? We usually pass. Okay, we usually pass beta a catheter in the patient, and this catheter which is there beta usually has the scope which is there. This catheter or the scope beta usually has a basket attached to it. Now what is going to happen? This basket which is there beta, we are going to open up this basket, and as you are going to open up this basket beta, now you are going to pull it out. Why? Now as you open up the basket and pull it out beta, once you have slided the basket behind the stone, and now you are going to open up the basket, and now you are going to pull it out beta, so that the stone gets trapped inside the basket beta and it gets removed easily. So this is what is called as a Dormia basket. Clear about? So please remember, this is what is known as the Dormia basket beta. Yaad rakhna. So I can go for a rhinoscopic lithotripsy or a removal of the stone beta directly by this procedure, okay, with the help of a Dormia basket beta. Clear hai? Sure. Next important, if I talk about this, the ureteric stones beta. If they say there is a ureteric stone beta, okay, if they say there is a ureteric stone, that means stones inside the ureters now. So if the stone is usually smaller in size, that is less than 5 to 6 mm in size, and it is not causing any impaction beta, matlab it is not obstructing something. So if it is less than 5 to 6 mm in size beta and it is not impacted basically, so in that condition I can again go for an observation. I can again go for an observation beta and conservative treatment. Okay? If there is a ureteric stone very small in size, not causing many symptoms as such, so you can go for an observation and a conservative treatment in the patient. But beta, if there is a large stone which is impacted, okay, if there is a large stone which is impacted beta, in those conditions which we have, what we have to do? So either if there is a large stone or we have a impacted stone beta, both the conditions, large stone ho ya fir impacted stone beta, in that conditions we have to go for a URS beta. And now what is the URS beta? So URS is nothing else but a ureteroscopic removal beta. Okay, URS which is there, it is nothing else but a ureteroscopic removal. So here we have to insert a scope beta. Okay, here definitely we have to insert a scope bache, and we can go for a ureteroscopic removal of the stone. With the help of which basket again? Dormia basket. Okay, we can go for a ureteroscopic removal beta. Again, same thing. You have to slide the ureteroscope and the Dormia basket behind the stone, open it up, and then pull it out. So that is what is called as URS beta, or a ureteroscopic removal. Clear baat? So URS is basically ureteroscopic retrieval or ureteroscopic removal of the stone. Okay, that is what is URS. If they ask you beta non-impacted agar stone hai, so if the stone is in the ureter beta and it is non-impacted, so I can even go for a ESWL beta. Then you can definitely go for a ESWL, that is extracorporeal shockwave lithotripsy. Clear about? So hopefully all the surgeries are clear to all of you now. Okay. So now that is the ureteric stone. Now let's talk about the bladder stone beta. If the stone is inside the urinary bladder, what is the treatment that we do? Done. If the stone is inside the urinary bladder beta, then definitely in patients of bladder stones, what we are going to do? We are going to go for a perurethral cystolithotomy beta. Okay, that means again you are going to go via the urethra beta, and then once you enter inside the bladder beta, you are actually going to trap the stone and you are going to remove the stone beta. So perurethral cystolithotomy, which is there in a retrograde fashion, would be done. Perurethral cystolithotomy is done definitely for all the bladder stones. But beta, if there is a large stone, definitely, or if the patient is having a urethral stricture, okay, if there is a large stone, or if the urethral stricture is there, urethral stricture hai, so obviously I cannot insert beta a catheter via the urethra, or I cannot remove the large stone also via the urethra. Then what we do, we actually make an incision over here beta, we insert the scope from here, and then we directly remove the scope beta from here. So this is also a cystolithotomy. You are opening the bladder and you are removing the stone over here, but this is basically from the suprapubic region. So that's the reason beta you can call it as a suprapubic cystolithotomy, right? This will be called as the suprapubic cystolithotomy beta. So the management is usually a cystolithotomy only, either a perurethral one or a suprapubic one, that depends. Hopefully that's clear. Chalo. The next one which is there beta, it is nothing else but the urethral stone. Now I am saying the stone is inside the urethra beta, the distal most part of the urinary tract. So if the stone is in the urethra, bache, okay, if the stone is in the urethra, what is the aim actually for a urethral stone for treatment? Yaad rakhna, urethral stone mein beta, we actually push back the urethral stone. Yes, push back that urethral stone into the bladder. Okay, push back into bladder beta and treat like a bladder stone. Okay, push back the stone into the bladder and treat like a bladder stone. Reason beta, you will not be able to remove urethral stone beta by inserting a scope basically behind it, because the urethra is very small beta. So definitely sliding a scope behind the stone is not possible. So you have to push the stone back itself in the bladder and then treat like a bladder stone itself. Hopefully that's clear to all of you now. So that is what is done. But beta, this is usually done when the stone is in the posterior part of the urethra beta. Barabar? When the stone is almost at the tip of the urethra beta, almost at the level of the external urethral meatus. Are you going to push the stone all the way back to the bladder and treat it like a bladder stone now? Obviously not. So when the stone is almost at the opening beta, can you see the stone over here beta is almost at the external urethral meatus. Okay? So if I say beta, if the stone which is there here, the stone is in the urethral meatus beta. So if there's a stone in the external urethral meatus, what is the treatment beta? Whenever the stone is in the external urethral meatus, bache, do remember that we have to go for a forceps removal, right? We can definitely use some lignocaine jelly beta, or we can give a local block beta over there, local anesthetic, and then we can easily do a forceps removal of the stone beta. ठीक है? उसको फालतू में वापस नहीं भेजना है. Hopefully that's clear to all of you. Easy. Next important. Now that was all about your urinary stones beta, that is renal, ureteric, and the bladder stones. Now let's talk about the renal tumors. Important question again. Recently they have started asking a lot of questions on kidney tumors जो पहले नहीं आते थे. Now definitely In pathology also there are a lot of questions from kidney tumors as well. They are asking. If I talk about beta, the renal tumors, the first one which is there beta we have to talk about is the benign kidney tumor. So yaad rakhna beta, if they ask you the most common benign kidney tumor beta, the most common benign renal tumor which is there is known as a renal oncocytoma. Okay, what are oncocytes? Oncocytes are those cells beta which are usually rich in mitochondria. Okay, so here this tumor usually arises from those oncocytes. So please remember the most common benign renal tumor is known as a renal oncocytoma. Okay, that has to be remembered. Important is that if they ask you what is going to be the investigation of choice in the patient beta, so renal oncocytoma ke patients, majority of them will be asymptomatic. If some of them have symptoms, it can be definitely a lump in the lumbar region, pain, hematuria like symptoms. If they ask you investigation of choice beta, do remember it is a CECT abdomen. I have told you for all the retroperitoneal organs beta we have to do a CECT scan basically. Rather than abdomen, it's better to call it a CECT KUB. ठीक है? So CECT scan or CECT KUB will be the investigation of choice. Treatment if they ask you बेटा, तो याद रखना है treatment में we have to go for a partial nephrectomy. Right? What do I mean by this? We have to remove that part of the kidney which is having the tumor beta. Right? So we have to remove the tumors and therefore some part of the kidney gets removed. That will be called as a partial nephrectomy. No issues with this. Next condition that we need to know beta is going to be an angiomyolipoma. The next condition we have to talk about is nothing else but an angiomyolipoma. Now if I talk about an OMA beta, OMA means what? A benign tumor. Angio means what? Blood vessel. Myo means what? Muscles. And lipo means what? Fatty tissue. So basically beta, this is actually a benign tumor of the kidney beta, which has all the three components in it. Okay? So it is basically a benign tumor of the kidney. Okay, it is basically a benign tumor of the kidney beta, which contains the blood vessels, which contains the muscle layer, and it also contains fatty tissue inside it. This is classically called as a renal angiomyolipoma. I hope you might have studied in medicine and pathology about this condition beta. This renal angiomyolipoma is commonly associated with a neurocutaneous syndrome that is called as tuberous sclerosis. You might have seen in tuberous sclerosis, the patient has multiple tumors in the body beta, like a subependymal giant cell astrocytoma in the brain, a cardiac rhabdomyoma in the heart, and renal angiomyolipoma in the kidneys beta. Clear about? So that is important. It is associated with the condition known as tuberous sclerosis. Previous question है याद रखना है. If they ask you what should be the treatment in the patient beta, so do remember the treatment of angiomyolipoma. Usually if the patient is asymptomatic, we know benign tumors ke liye nothing is done. That means we can go for an observation beta. Okay, if the patient is asymptomatic, benign tumor and nothing is done, observation. But if the patient is having bleeding beta, if bleeding is present, then we have to block the blood vessel that is supplying the tumor beta, the main blood vessel, so that the size of tumor is also going to shrink. And if I am going to block the blood vessel beta, that is what is classically known as angioembolization. Usually if the tumor is going to be small in size beta, we have to go for an observation in renal angiomyolipoma. But if it is going to be symptomatic, that means if the patient is going to have bleeding beta, we have to go for an angioembolization. No issues with this. Now let's talk about beta the next topic, and that is RCC. What is RCC? Renal cell carcinoma, also known as hypernephroma beta or the Gravet's tumor. Yes, the kidney cancer. Now let's talk about the malignant tumor or the cancer of the kidney beta. So if I talk about the cancer of the kidney, definitely, okay, the malignancy of the kidney is known as RCC, that is renal cell carcinoma. Please remember this condition is also known as hypernephroma, and we can also call this condition as a Gravet's tumor. Okay. Important is what are going to be the risk factors beta for a renal cell carcinoma. याद रखना, the important risk factors for a renal cell carcinoma would be the patient having diabetes mellitus and hypertension. Diabetes mellitus, hypertension are important risk factors beta for renal cancer, liver cancer, for all of them almost. Okay. Apart from that beta, tobacco intake. If the patient is going to do a tobacco intake beta, then definitely that is also important risk factor. So smoking, tobacco, all of that. Stones, definitely. Stones are actually going to increase the risk of bladder cancer beta, or even thorotrust exposure. Now what is thorotrust beta? Thorotrust is an important dye. You have to remember that. Thorotrust which is there beta, it is basically an important dye. Just a minute. Excuse me. Chalo. So sorry for the disturbance. So please remember thorough exposure, which is there definitely beta. That is going to be important. So yaad rakhna that thorough exposure definitely is associated with definitely beta renal cancer also, and even with bladder cancer as well. ठीक है, तो ये thorough dye have to be remembered. Even with liver cancer it is associated. Next important, the other dyes which are associated with renal cancer or kidney cancer beta. So those are going to be the nitrogen aniline dyes beta. ठीक है, तो याद रखना the nitrogen aniline dye which are there, it is usually associated with kidney cancer as well. Next, if they ask you what is a gene mutation associated with kidney cancer, very very important. The gene mutation associated with kidney cancer beta has to be remembered as the VHL gene beta located on chromosome number 3. Okay, so the VHL gene located on chromosome number 3, 3 is very classically associated with the kidney cancer. This VHL is nothing else but the von Hippel-Lindau gene. Yes, so due to VHL gene mutation, the patient has a von Hippel-Lindau syndrome, and that increases the risk of renal cell carcinoma. In your examination, they went a step further also beta to ask that which subtype of renal cell carcinoma is associated with the VHL gene mutation. So yaad rakhna, the subtype of renal cell carcinoma that is associated with VHL gene mutation is clear cell carcinoma. Yes, the most common type which is there, known as clear cell carcinoma, that itself is associated with the VHL gene mutation. Next important beta, if they ask you that which is the most common histological type beta, so yaad rakhna, the most common histological type which is there is going to be adenocarcinoma. Reason is, we know beta that the renal cancers which are there, they are usually going to start from the renal tubules beta. Majority of them beta, they arise from the PCT, that is your proximal convoluted tubules, where we have a columnar epithelium. That's the reason definitely beta. Please remember adenocarcinoma which is there is going to be the most common type of renal cancer. Okay, most common type of renal cancer is an adenocarcinoma. If they ask you which is the most common subtype, so yaad rakhna, as I told you recently, the most common subtype beta is going to be a clear cell carcinoma. The most common subtype of the renal cell cancer beta is going to be a clear cell carcinoma. Yaad rakhlo, the clear cell carcinoma is going to be the most common subtype of a renal cancer beta. And as I told you that the clear cell carcinoma which is there beta, it is the most common subtype, and it is the most common itself beta, which is associated with the VHL gene mutation or with the von Hippel-Lindau syndrome beta, right? The one that is associated with VHL gene mutation or the von Hippel-Lindau syndrome is nothing else but clear cell carcinoma itself. If they ask you it arises from which part of the kidney, as I've told you already, that usually it arises beta from the PCT, the proximal convoluted tubule. Majority of your cancers arises from the PCT itself, including the clear cell carcinoma which arises from the PCT. Next important beta, if you are talking about the histopathological examination, here you are able to see beta, we do not do a biopsy in the kidney cancer beta because of the risk of spread while taking the biopsy. Therefore, the investigation of choice is a CECT itself. Then how do we get the histopath? After removal of the mass beta, when I send the mass for histopathological examination, this kind of a picture can be seen. What you are able to see, clear cells are seen definitely beta, right? Here what I'm able to see here, there is a cell beta, and these cells are definitely having prominent nucleus beta, and with prominent nucleus you are able to see normally the cytoplasm appears pink in color. Here definitely beta, the cytoplasm appears very clear. So either you can call it as a clear cytoplasm, or we can call it as the ground glass cytoplasm beta. Okay, so either I am able to see a clear or a ground glass cytoplasm on the histopath. So when we are able to see cells with prominent nuclei and a ground glass cytoplasm, that is definitely a histopath of clear cell carcinoma beta. Okay, so these histopaths come in your examinable and patho se questions are this one and the second one that I am going to tell you. Now the second subtype of renal cell carcinoma beta is going to be the papillary one. The second subtype is going to be the papillary renal cell carcinoma. When I talk about a papillary renal cell carcinoma beta, yaad rakhna, the histopathological examination of the papillary subtype reveals what? I hope all of you are quite aware beta, that papillary is what basically, that means when the cancer on the histopathological examination shows the papillae beta, that is finger like projections on the biopsy, okay, and the histopathological examination in the papillary RCC beta, okay, the histopathological examination in the papillary RCC is going to show what? Anybody? It is going to show all the papillary cancers of your body, shows the classical laminated calcified bodies beta, and those laminated calcified bodies are called as the Samoma bodies, which are an example of dystrophic calcification, right? So Samoma bodies will be seen beta on the histopath of papillary renal cell carcinoma beta. Next important is the chromophobe subtype beta. The third subtype of the renal cell cancer is known as the chromophobe subtype. If I talk about the chromophobe RCC beta or the chromophobe type of renal cell carcinoma, here definitely please remember two things. That out of all the subtypes of the renal cell cancer beta, out of all the subtypes of the renal cell cancer, chromophobe RCC has the best prognosis. Chromophobe RCC is going to have the best prognosis beta. First point to be remembered. Second point, that what is the histopathological examination going to look like? याद रखना, if there is a chromophobe RCC beta, you are able to see a very classical histopathological examination. On the histopath in a patient of chromophobe RCC, you are able to see some special features. First, the cell is going to have these kind of borders beta, and when the cell basically has this kind of hexagonal shaped borders beta with a prominent nuclei in between, it looks like which cell? Anybody? It is basically going to look like a plant cell. You might have drawn plant cells in your 12th standard na. So obviously beta 12th 11th jab bhi nikala hai, so please remember beta, the plant cells which are there, they are going to have such kind of borders. So there is a plant cell like appearance beta in this condition. Second, the nucleus which is there beta, it appears large, and this nucleus looks like a raisin beta, kishmish jaisa lagta hai. So this is what is called as a raisin like nucleus or a raisinoid nucleus beta. Okay, so these are the features that will be seen in the chromophobe type of RCC on the histopathological examination. So yaad rakhna, the histopathological examination shows plant cell like appearance beta. It shows a plant cell like appearance. With what? With a raisinoid nucleus beta. There's a plant cell like appearance with a raisinoid nucleus. No issues with this, anybody? That's important. Next important beta, if they ask you, is going to be collecting duct beta. Okay, if they are going to ask you about the collecting duct renal cell carcinoma or the Bellini duct renal cell carcinoma. Okay, if they ask you about the collecting duct or the Bellini duct renal cell carcinoma beta, okay, in this patient, you have to remember one thing, that I've told you most of the renal cell cancers arise from the PCT. Here the cancer is going to arise from the collecting duct or the Bellini duct beta, and this cancer which arises from the collecting or Bellini duct will have the worst prognosis. Yes, among all the subtypes of renal cell carcinoma, if they ask you which is going to have worst prognosis, answer is the collecting duct carcinoma or the Bellini duct carcinoma beta. Clear about? So these are the points that has to be remembered. Now if they ask you what is going to be the clinical features beta, so please do remember that the most common clinical feature in this patient, the most common clinical feature in this patient is going to be a painless hematuria beta. Yes, these patients who are going to have a painless hematuria beta. The patient will have a lot of bleeding, but the pain is not going to be there initially. So there will be a painless hematuria beta in the patient. That is going to be the most common clinical presentation in a case of a renal cell cancer. Apart from that beta, what can be the other complaints of the patient? The other complaints can be, in some patients beta, when the tumor or the cancer has grown in size or when it is involving the nerves beta, the patient definitely can have flank pain also. Apart from that, as the cancer is going to grow bigger, the patient will have mass in the lumbar region beta. The patient will have loss of appetite, that is called as an anorexia, or the patient will also have weight loss beta. Okay. Next, the patient is going to have bache hypertension. Reason, if the kidneys are going to get damaged, I have told you beta, there will be hypervolemia causing hypertension in the patient. Some patients may have a low grade fever at times. We have to remember that your kidney cancer which is there beta, it usually spreads along the renal vein. We are going to discuss about this condition beta. Yaad rakhna, the left renal vein which is there beta, it usually drains into the inferior vena cava, and inside this left renal vein beta, we have the left testicular vein which drains. The right testicular vein directly drains into the inferior vena cava beta, but the left testicular vein which is there beta, it usually drains into the left renal vein, and that too perpendicularly. Now important is beta, yaad rakh lo yahan pe, these are the testicular veins beta, the pampiniform plexus of testicular veins. Okay, now what is going to happen definitely beta, yaad rakh lo, for example, if the patient who is there bache, for example beta, the patient is having a renal cancer and that renal cancer is actually blocking the renal vein beta. Now if the renal vein is getting blocked, obviously please tell me beta, will the testicular vein be able to drain? No, as the testicular vein is not able to drain properly beta, there will be pooling of blood inside the testicular vein itself, and as there is pooling of blood inside this left testicular vein itself beta, there will be pooling of blood inside this pampiniform plexus of veins also, and when there is a lot of pooling of blood or a lot of collection of blood inside this pampiniform plexus of testicular veins, all these testicular veins are going to dilate beta, and they will become tortuous. These dilated, tortuous, pampiniform plexus of veins, which is there, beta, is what is called as a varicocele. Now we know that dilated and tortuous vessels are called as what? Varices or varicosities, right? And here the varicosities are seen inside the cavity, and that cavity is nothing else but the scrotal sac. So therefore, this condition is known as a varicocele, beta. As this varicocele is secondary to a cancer, beta, we can call it as a secondary varicocele. Okay? So when the cancer spreads along the renal vein, beta, please remember that it can actually cause impaired drainage from the left testicular vein, leading to a secondary varicocele development. If they ask you, beta, distant metastasis, we know that from kidney cancers, beta, there can be a distant metastasis which could be seen, and the most common site for distant metastasis will the lungs. Okay, the most common site for distant metastasis from a renal cell carcinoma will be the lung. GIT cancers more commonly spread to the liver, and kidney cancer more commonly spreads to the lungs, beta. And whenever the cancer spreads in the lungs, I hope all of you are quite aware, beta, you might have seen on the chest x-ray there are whitish ball like appearance, beta, and that whitish ball which are there, beta, they are called as the cannonballs basically. So it gives us the classical cannonball appearance. No issues with this, anybody? That is important. We know that the renal cell cancer can also spread to the bones, beta, via the blood route or hematogenous route. When it spreads to the bones, beta, there will be a classical pulsatile bony metastasis, beta. Okay, so this is a keyword, beta, yaad rakhna. Pulsatile bony metastasis, if they ask you, answer has to be a renal cell cancer. Pulsatile proptosis, I have told you, cavernous sinus thrombosis. Pulsatile tinnitus, I have told you, that is glomus jugulare in ENT. And I've also told you, beta, pulsatile swelling, that is a arteriovenous or an AV fistula. Ye pulsatile chal yaad rakh lo, in examination it will be easier. Now the patient of renal cell cancer can have a paraneoplastic syndrome. What do I mean by paraneoplastic syndrome, beta? That means when the cancerous or the malignant cells which are there, beta, they produce a hormone like substance. Okay? For example, the cancerous cells, most of them, they produce a substance, beta, called as PTHRP. Ab ye PTHRP kya hai? Parathyroid hormone related peptide. Yes, this is a substance which looks like the parathyroid hormone and acts like a parathyroid hormone. Therefore, beta, as the cancerous cells are going to produce excess amount of this PTHRP, the patient will have excessive rise in the serum calcium levels, causing hypercalcemia. So hypercalcemia, beta, can be one of the paraneoplastic syndromes which could be seen. Okay, याद रखना, if they ask you paraneoplastic syndrome में what is the most common paraneoplastic syndrome, तो याद रखना है the kidney cancers which are there, beta, they produce a substance which looks like erythropoietin, beta, okay, which is responsible for RBC production. So that's the reason the patient has more RBC production, called as polycythemia. And due to that, beta, the ESR of the patient, that is erythrocyte sedimentation rate of the patient, beta, is elevated. So there is an increased or elevated erythrocyte sedimentation rate, okay, and that is due to what? Due to polycythemia. So whatever is there in the option, beta, whether it is elevated ESR or it is a polycythemia, is going to be considered as the most common paraneoplastic syndrome in kidney cancer. Next, the patients may also have amyloidosis, beta. The patient may also have hypercalcemia, as I've told you, and the patient may also have anemia as well. And in kidney cancers, beta, as a paraneoplastic syndrome, the patient may also develop a non-metastatic hepatic dysfunction. Matlab, here, beta, it is like the kidney cancer has not spread to the liver, beta, but the substances which are released from this kidney cancer, beta, okay, those inflammatory mediators, they are actually known to cause the liver dysfunction. Okay, so this non-metastatic liver dysfunction or hepatic dysfunction in a patient of kidney cancer, very classical, is known as Stauffer syndrome, beta. It is classically called as the Stauffer syndrome. Yaad rakhna ye naam. So Stauffer syndrome is seen in patients of renal cell carcinoma, beta, when the cancer does not spread to the liver, but still due to the chemical mediators, beta, there is damage to the liver. Okay. Now if they ask you about the diagnosis, beta, what should be done for the diagnosis? The first line investigation, beta, in a patient. Okay, the first line investigation, shall I? Hopefully you have written. The first line investigation, beta, in the patient has to be a urine microscopic examination. Reason, what is the most common presentation in a patient of a renal cell cancer? It is hematuria, right? That's the reason, but obviously whenever a patient comes to me with hematuria, I have to go for a urine microscopic examination as my first line investigation. And when we do a urine microscopic examination, beta, we are able to see a very classical picture. And what is that picture that is seen? So, beta, you will be able to definitely say RBC cast, beta. Why? Because hematuria is there, na? So I will be definitely able to see, beta, the RBC cast in the urine. But along with RBC cast, beta, we are also able to see malignant cells. So whenever you are suspecting a malignancy, always ask the pathologist to look for malignant cytology also alongside. So when he does a urine microscopic examination on that beta, along with the RBC cast, the malignant cells will be seen as well, and that can give you a first suspicion that your patient is having a renal cell cancer. Great, all of you. If they ask you what is the investigation of choice, याद रखना बेटा, the investigation of choice is nothing else but a CECT beta. Okay, so CECT scan, okay, or CECT KUB has to be the investigation of choice for a renal cancer. We do not take a biopsy. Reason, while taking a biopsy there is a risk of spread, and when you do a CECT beta, you are able to see this is the kidney, and from the left kidney you can see such a huge or a gross beta cancer that is developing. Okay, so this is what is a classical picture of a RCC or hypernephroma beta. If they ask you what is the treatment in the patient, so yaad rakhna hai beta, if the cancer is less than 4 centimeters in size, if the cancer is less than 4 centimeters in size, if it is bilateral beta, if both the kidneys are having a cancer, or if there is RCC in a patient with single kidney beta, in patient with single kidney, ये patient गायब हो गया, ठीक है. So if there is RCC in a patient who is only having single kidney beta, so if the cancer is less than 4 centimeters in size, if there is a bilateral RCC, or if there is a RCC in a patient who is only having single kidney beta, so in this condition beta, we have to only do a partial nephrectomy beta, right? In this patient, we only have to go for a partial nephrectomy beta. We cannot remove the whole kidney in this patient. Partial nephrectomy has to be done, but beta, with or without lymph node dissection, obviously. If they say if the cancer is more than 4 centimeters in size beta, or there is lymph node involvement also, okay, if there is more than 4 centimeter size of renal cancer beta, or there is lymph node involvement, then we have to definitely remove the kidneys beta completely along with the lymph nodes also. Okay, and when we are going to remove the lymph nodes also beta in the patient, that is what is called as a radical nephrectomy, right? That surgery will be known as the radical nephrectomy then. Hopefully that's clear to all of you. So that is the management of RCC or a renal cell cancer. Let's talk about the next type of renal malignancy beta or a kidney malignancy, and that is going to be called as the Wilms tumor beta, also known as a nephroblastoma. Yes, the next type of renal malignancy that we have to talk about beta is nothing else but a Wilms tumor, also called as a nephroblastoma beta. Now when I talk about a Wilms tumor or a nephroblastoma, do remember that this is actually the most common renal malignancy beta. In which age group? This is actually the most common renal malignancy in children beta. Okay, so usually it is more commonly seen in children who are 2 or 3 years of age. But yeah, so if they ask you which is going to be the most common renal malignancy in children, answer has to be a Wilms tumor, also known as a nephroblastoma. Important point. But if they say beta that which is the most common abdominal malignancy in children, okay, if they say beta most common abdominal malignancy in children beta, then please remember, do not get confused, then the answer has to be a neuroblastoma beta, not a nephroblastoma. Then the answer has to be a neuroblastoma, followed by the second most common will be a nephroblastoma, followed by the second most common will be a nephroblastoma, that is your Wilms tumor. Okay, so please remember beta, if they ask you most common renal malignancy in children, answer is the nephroblastoma. If they ask you most common most common abdominal malignancy in children, then your answer has to be a neuroblastoma. Can anybody tell me which is the most common malignancy in children? कौन सा कैंसर सबसे ज्यादा कॉमन है चिल्ड्रन में? Which is the most common malignancy in children beta? Please tell me that in the chat box. We know beta that all diseases can be either sporadic or familial, and I've told you beta majority of the diseases or cancers will always be sporadic. That means the ones which will occur anywhere, any point of time, in any person, anywhere in the world, right? Barabar, that is sporadic. Few cases are going to be familial beta, which are usually genetic or hereditary in nature. If there are familial cases of Wilms tumor beta, those familial cases can be associated with some syndrome beta. Okay, the familial cases of Wilms tumor beta, याद रखना, the familial cases of Wilms tumor, they are usually associated with conditions like Weger syndrome beta. Okay, they are usually associated with conditions like Weger syndrome. What is Weger syndrome? W goes for Wilms tumor, A goes for aniridia, that is absence of iris, G goes for genitourinary malformations or defects, R goes for retardation, that is mental retardation in the patient. Okay, or mental as well as growth retardation is also there. Next is a Dennis-Drass syndrome beta. Dennis-Drass syndrome is going to be seen beta in multiple patients Danish-Rush syndrome beta is going to be having multiple cancers. One of those is going to be Wilms tumor which. Next is a very very important beta, has been a previous year question of FMG exam. August 2020 उसके बाद भी एक बार, that is Beckwith-Widman syndrome बच्चे. So please remember Beckwith-Widman syndrome you might have discussed in pediatrics. याद रखना, here you have to remember Beckwith-Widman syndrome में the patient usually has what? The patient usually has beta. Okay, the patient is having hemihypertrophy, that is half of the body of the baby beta will be large in size. The baby will be having macroglossia, that is a large tongue. Baby will be having an omphalocele beta. Okay, so that is definitely the herniation of the organs at birth itself. And they have asked that which tumor will be associated in this patient. So answer was Wilms tumor. Clear about that? Is important. Most common malignancy in children, answer is ALL, acute lymphoblastic leukemia. Clinical features, if they ask you beta, that has to be remembered. The clinical features of the patient has to be abdominal lump beta. Obviously the patient is going to have a renal malignancy, so they will present you with abdominal or a lump in the flank region. Patient may have abdominal pain or flank pain, and there will be hematuria beta. Clear hai? So abdominal lump, pain and hematuria is the classical triad in a patient of Wilms tumor. If they ask you beta that what is going to be the most common site for distant metastasis, again the same beta, whether it is a renal cell carcinoma or it is a Wilms tumor beta, the most common site of distant metastasis is going to be the same, that is nothing else but the lungs beta, followed by the liver. Okay, the most common site is going to be the lungs over here. If they ask you beta what is going to be the first line investigation, so yaad rakhna, the first line investigation in the patient has to be what? Anybody? The patient over here definitely either comes to you with hematuria or comes to you with a mass beta. If my patient comes to me with hematuria, my first line investigation will always be a urine microscopic examination. But my patient comes to me with a mass, then my first line investigation has to be an ultrasound abdomen beta. Then my first line radiological investigation has to be an ultrasound abdomen. Okay, that is important. Investigation of choice, if they ask you beta, so yaad rakhna hai, investigation of choice in the patient has to be again a CCT itself. So CCT scan has to be the investigation of choice. No issues with this. If they ask you what will be seen on a histopath, again biopsy is not done for diagnosis. Biopsy or histopathological examination will be done after the mass has been resected. Okay, so histopath, if I see beta, histopathological examination pe Wilms tumor is very khas beta. Why? Because it is going to show you a mixed tumor beta. Now what do I mean by a mixed tumor beta? That all the elements are seen, all the three elements are seen beta. So Wilms tumor may definitely we are able to see there will be epithelial elements also, there will be mesenchymal, that is connective tissue elements also, and there will be blastomal elements also beta, that is the immature ones. Okay, the epithelial elements, blastomal elements and mesenchymal elements together is seen as seen in a mixed tumor known as Wilms tumor or nephroblastoma. If they ask you what is the treatment beta, so yaad rakhna, the mainstay of management, why we are studying it over here, because the mainstay of management has to be a surgical resection of the tumor beta. So surgical resection of the tumor has to be done with normal margins. But beta, after the surgical resection, we may have to go for a chemotherapy in the early stages only, and chemoradiation, that is both chemo as well as radiotherapy in the later stages. So agar early stages mein, so surgery followed by chemotherapy is enough, but later stages mein, so surgery followed by chemoradiation has to be done. Clear hai? Next, let's talk about beta the urinary bladder cancer. Now that was all about your Wilms tumor and nephroblastoma. Do remember it अच्छे से. If I talk about the next one, that is urinary bladder cancer. Sorry. Now urinary bladder which is there beta, it is lined by anybody. So yaad rakhna, urinary bladder which is there. See, the kidneys which are there, the tubules are lined by the columnar epithelium. Therefore, adenocarcinoma is more common in kidneys. There are chances that a transitional cell carcinoma may develop in the kidneys. Reason, the renal pelvis is lined by transitional epithelium, but that is less common in the kidneys beta. Okay, so yaad rakhna, the renal pelvis, the ureter and the urinary bladder, all of them are lined by the transitional epithelium. So therefore, this has been a previous year question of your exam, that which is the most common histological type of your bladder cancer. The most common histological type of your bladder cancer has to be a transitional cell carcinoma. Sarkari question, yaad rakho ye baat. The most common type histologically for a bladder cancer has to be a transitional cell carcinoma. If they ask you beta that which is going to be the most common site, so please remember beta, basically this transitional cell carcinoma which is there, it usually develops from the lateral wall of the bladder beta. Okay, if they ask you which is the most common site in the bladder for it to develop, so it is basically the lateral wall of bladder beta. followed by the trigone of bladder. Trigone is the central part of the bladder, na? So please remember, beta, the lateral wall of the bladder is going to be the more common part, followed by the trigone of the bladder. No issues with this? Now, if they ask you, beta, that what are going to be the risk factors in the patient? Important. The risk factors, if they ask you, beta. Okay, if they ask you what are going to be the risk factors, तो याद रखना risk factors के नाम पे. The first one is cyclophosphamide. I hope all of you are quite aware. This cyclophosphamide drug which is there, this drug actually causes a complication known as, common question, hemorrhagic cystitis, beta. And as it causes hemorrhagic cystitis, that is inflammation of the gallbladder, sorry, urinary bladder, beta, it can cause damage over there and may lead to development of a urinary bladder cancer in future. So cyclophosphamide is an important risk factor. Can anybody tell me, previous year question, that which is the drug that is given to prevent the hemorrhagic cystitis which can be caused by cyclophosphamide? So ये complication prevent करने के लिए which drug is given? Tell me in the chat box. Apart from that, beta, the smoking is important risk factor, as I told you. Dyes, usually the same dyes like kidney cancer, it is the dyes which are there, beta, like nitrogen aniline dye or naphthylamine dye for that matter, beta, or a very important one, and that is going to be benzidine dye, beta. Yaad rakhna, a lot of people always confuse it with benzene. No, beta, benzene exposure leads to a blood cancer, that is nothing else but the leukemias, beta. Benzidine exposure is the one, beta, which is associated with the bladder cancer. ठीक है, ये previous year question में पूछा गया था. Benzidine they have asked and people marked blood cancer. No, benzene means blood cancer, benzidine means bladder cancer. ठीक है. Next important, beta, squamous cell carcinoma which is there. So squamous cell carcinoma can definitely be there, beta. Squamous cell carcinoma can be seen in bladder cancer, beta, can be seen in the urinary bladder, beta, but that's rare usually. And that squamous cell carcinoma is usually associated with which infection? That has to be remembered. Previous year question of your exam again. Micro se question hai. Which infection of the urinary bladder increases the risk of squamous cell carcinoma? So do remember, that is schistosomiasis, beta. So schistosomiasis of the urinary bladder is actually going to increase the risk of bladder squamous cell carcinoma in the urinary bladder. Okay, so schistosomiasis which is there, beta, it is the infection that is going to increase the risk of squamous cell carcinoma of the urinary bladder. Clear hai baat? Next important, if I talk about Mesna, is the drug for prevention of the hemorrhagic cystitis. Mesna, MESNA. Next, if I talk about, beta, what is the most common clinical presentation? The most common clinical presentation is same, beta, that is the patient is going to have a painless hematuria. The patient over here is going to have a painless hematuria, that has to be remembered. Apart from this, you have to remember one more thing. Okay, whether it is kidney cancer or bladder cancer, beta, yaad rakhna, most common clinical presentation is same, that is a painless hematuria only. Okay. Now here, if the patient of a bladder cancer is having pain, beta, that is suggestive that the cancer has spread outside the bladder and it is involving the nerves now. Okay. So pain which is there, beta, it is usually suggestive of an extravesical spread. Okay. Agar pain agar hai, so that is what is suggestive of an extravesical spread in a patient of a bladder cancer. Obviously, the patient will definitely have, beta, LUTS also. What is LUTS basically? LUTS are nothing else but lower urinary tract symptoms. Whenever there is any problem in the bladder or the urethra, beta, and the difficulty that the patient has with urine, to describe all those symptoms together, we use the term known as LUTS, that is lower urinary tract symptoms. As there will be bladder cancer, beta, the capacity of the bladder may decrease and therefore the patient may have to go for the urine again and again. That is, increased urinary frequency will be there. Patient may have nocturia, that is increased frequency at night time basically. Right? So all of these features together can be seen. Investigation of choice, if they ask you, beta, to yaad rakhna, we can go inside the urinary bladder and we can take a biopsy. When we go inside the urinary bladder via the urethra by taking a camera or scope, and that is called as a cystoscopy. So here, beta, we can do a cystoscopy with biopsy or a cystoscopic biopsy, beta, in the patient. So investigation of choice in the patient, beta, has to be a cystoscopy with biopsy. No issues with this, anybody? If you definitely see, beta, okay, over here on the cystoscopy, what is going to be seen, beta? Okay, please remember what is going to be seen over here. You are able to see a very classical appearance, beta. This is classically called as, beta, the flower-like appearance, right? Here you are able to see, beta, flower-like appearance is seen inside the urinary bladder. And this has been a recent examination question. July 2023. This was the picture which was given and they asked what is the diagnosis. Yes, but just by the picture they asked. Okay, so yaad rakhna, if flower-like appearance is usually seen on cystoscopy, it is more likely to be a case of a urinary bladder cancer, because urinary bladder cancer is going to grow outwards, matlab it is going to be exophytic, It is going to be superficial beta. Okay, it is going to be exophytic and it is going to show a superficial growth. Exophytic superficial growth, if it is seen beta, it will give us a cauliflower like appearance or a flower like appearance beta, and that is what basically called that is what is basically seen in a patient of a bladder cancer. याद रखना ये image important है. Next important, if they ask you beta, what is the staging investigation of choice? Now we know beta that bladder is a perineal or a pelvic structure, and if I have to do a staging, I have to see the wall of the urinary bladder, I have to see the surrounding structures, and the best radiological investigation we have discussed beta for all the pelvic and the perineal structures has to be what? It has to be the MRI. So the staging investigation of choice has to be MRI in the patient. Clear about? Next important, if they ask you which are the sentinel lymph nodes beta, the sentinel lymph nodes for a bladder cancer, the bladder is mainly going to drain, or it first drains into the obturator lymph nodes. So yaad rakhna, obturator lymph nodes which are there beta, they are going to be the sentinel lymph nodes in a patient of bladder cancer and in the case of a prostate cancer also. ठीक है, याद रखना है बात. If I talk about beta, that okay, do remember staging investigation of choice is MRI over here, and the sentinel lymph nodes are obturator lymph nodes. If they ask you now what is the treatment, so do remember if the cancer is going to be superficial beta, if the cancer is going to be superficial over here, that means only involving the inner layers of the bladder wall. So if there is a superficial cancer beta, can we just go inside the bladder beta with the help of an endoscopy and we can just resect the bladder, right? That's as we did in a gastric cancer, we have just done a mucosal resection. Just like that beta, if the cancer is in the early stages, we can go inside the bladder and just resect the cancer beta with some normal margins. And that surgery which is there beta, that procedure which is there is classically called as TURP. Now what is basically a TURP beta? Yaad rakhna, it is a transurethral. Okay, it is nothing else but beta a transurethral resection of bladder tumor beta. It is usually a transurethral resection of the bladder tumor. Okay, that is what is known as TURP beta. Do remember that. Transurethral resection of bladder tumor is what is called as TURP, which is definitely the treatment of choice beta for a superficial bladder cancer or a cancer in the early stages beta. If they ask you after that what we have to do, after that beta followed by the TURP, definitely you have to either give chemotherapy to the patient or you can give immunotherapy to the patient. Anybody, immunotherapy in a patient of bladder cancer will be given by which vaccine? Which is that vaccine that is used for the treatment of bladder cancer? Anybody? Hopefully all of you are quite aware. The vaccine that is used beta for immunotherapy in a bladder cancer is the bacilli calmette-guerin, that is the BCG vaccine beta. So BCG vaccine could be used beta inside the bladder for the treatment of bladder cancer, usually to prevent recurrence mainly. That is important beta. BCG vaccine is there. Therefore, all the vaccines you might have studied in PSM are primary level of prevention except BCG vaccine in bladder cancer, which is secondary because used for treatment. Next important, if they say there is a muscle invasive cancer beta, if the cancer is actually invading the detrusor muscles of the urinary bladder beta, so in this case definitely we have to remove the urinary bladder completely. And if I have to remove the urinary bladder along with the obturator lymph nodes, so I will call it as a radical cystectomy beta. Then that surgery which is there beta will be called as a radical cystectomy. Okay, that is going to be called as a radical cystectomy. No issues with this anybody? That has to be remembered beta. If I talk about beta, after this radical cystectomy, what should be done? After this radical cystectomy beta, we have to give again chemotherapy to the patient and radiotherapy to the patient. Yes, both chemo and radiation has to be given together. Reason is to reduce the chances of recurrence beta after radical cystectomy, because there would be some of the other malignant cells beta which may be left behind in the pelvis. Okay? After that, as the bladder had got removed beta, so now if they ask you beta that which is the most common route for diverting the urine beta, it is known as an ileal conduit. So we are actually going to create a bladder beta with the help of an ileum. So that is known as an ileal conduit. So ileal conduit which is there definitely, ileal conduit which is there beta, it is considered as the most common route for urinary diversion after surgery. The most common route for urinary diversion of the surgery is going to be the ileal conduit itself. Clear about? Next important now. If they ask you about the next topic, and that is bladder rupture beta. Let's talk about the next topic, that is bladder rupture. Now if I talk about bladder rupture beta, please remember there are two types of bladder rupture. One is an extraperitoneal bladder rupture, second is an intraperitoneal bladder rupture beta. Yaad rakhna that bladder is usually a extraperitoneal organ. That means the organs that lie below the peritoneum are called as extraperitoneal, and bladder is an extraperitoneal organ. So obviously, beta, which one will be more common type of a bladder rupture? Obviously, by that logic, as bladder is an extraperitoneal organ, obviously, please remember that extraperitoneal bladder rupture is going to be more common. Extraperitoneal bladder rupture is going to be much more common, beta, as compared to the intraperitoneal one. Okay. Now, important is why a extraperitoneal bladder rupture happen. So please remember the bladder rupture usually happens, beta, due to a pelvic trauma. Reason I told you, because the urinary bladder is located inside the pelvis or inside the pelvic cavity. That's the reason if a patient had a road traffic accident due to which the patient had a pelvic fracture, and that pelvic fracture has damaged the urinary bladder, beta, that leads to a bladder rupture. Okay. So yes, if with pelvic fracture, beta, there is a very high incidence or a very high chance of urinary bladder rupture also. So please remember, extraperitoneal bladder rupture is due to a pelvic trauma, and we know that pelvic trauma does not occur due to minor trauma. It occurs due to a significant trauma like RTA. Okay. So please remember, it is due to pelvic trauma, beta, and if there is an extraperitoneal bladder rupture, beta, it will also be associated. Okay, it will also be associated, beta, with a posterior urethral injury, because we know that the posterior urethra which is there, that is your prostatic and the membranous urethra together. So posterior urethra which is there, beta, it is it is also located close to the bladder, beta. It is also located inside the pelvic cavity. So if there is a extraperitoneal bladder rupture, there is a very high chance that the patient may also have a posterior urethral injury. Now, if the patient is having a bladder rupture and a posterior urethral injury, beta, you will be able to see that the patient is having blood at the tip of the external urethral meatus. Okay, the patient may have, beta, blood at the tip of the external urethral meatus. Right, at the external urethral meatus, there will be blood which is seen, and that is suggestive of bleeding either from the bladder or the urethra. Clear about? Next important, beta, as the bladder is ruptured, what is going to happen? As the bladder has been ruptured, beta, all the urine will leak out into the pelvic cavity. So as the urine has leaked out into the pelvic cavity, beta, the patient may not be able to pass the urine, beta. There will be inability to pass the urine in the patient, beta. Okay, there will be inability to pass the urine. So right, that is important to be remembered. Now, next important, if the patient is having an intraperitoneal bladder rupture, what is that condition where my patient has an intraperitoneal bladder rupture? Understand. For example, beta, my patient has drank a lot of beer. Okay, and due to that, as I told you, beer is a diuretic, so my patient's urine output is going to increase. And due to that excessive beer that he has drank, beta, his bladder is completely full. Okay, his bladder is completely full, beta. And now this patient is going to walk. Obviously, after drinking so much of beer, beta, the patient cannot walk straight. So he is walking like this, beta. He goes to the washroom and he falls on the commode. Okay, now what is going to happen? The patient actually has an injury in the suprapubic region, right? So the bladder was extremely full, beta, and now the patient has an injury to the suprapubic region or in the lower abdomen. Due to that, this bladder ruptures. And as this bladder ruptures, beta, all the urine from this bladder is going to go into the peritoneal cavity of the patient, and this is going to cause a intraperitoneal bladder rupture. So intraperitoneal bladder rupture will only occur, beta, in a over distended urinary bladder. Okay, and when there is a trauma to the over distended urinary bladder. Clear about? So intraperitoneal bladder rupture, as I've told you, it occurs due to trauma to the lower abdomen, beta. It occurs due to trauma to the lower abdomen, and when there is a over distended urinary bladder, beta, like in patients of lower abdominal operation. For example, your obs-gynae resident asked you कि जाओ definitely make the patient ready for CS definitely. Okay? So now you had to definitely get the patient ready for cesarean section. You did all the things except you did not insert a Foley's in the patient to drain the bladder. Now what was the problem? That the female's bladder was full. The female was taken up for the LSDS. Obviously, the surgeons did not notice that whether the Foley's has been inserted or not. Now, as soon as they gave the incisions, beta, okay, they had the bladder in front. They thought that the bladder would be empty. Therefore, they retracted the bladder with force. And as they retracted the bladder ruptured. Okay? And immediately there was a call sent to the surgery department. Ki please, aa jao karke. Okay? So that is important. That is going to happen. So please remember, beta, if there is a lower abdominal surgery and if there is a over distended bladder, there is a very high chance, beta, of damage to the urinary bladder and causing an intraperitoneal bladder rupture, or beta, even in cases of beer drinking also, as I told you. Clinical features kya honge? If there is an intraperitoneal bladder rupture, the patient is going to develop features of peritonitis as well. So the patient will have a sudden pain abdomen, beta. Yes, there will be a sudden severe pain abdomen, usually in the suprapubic region, beta. Okay, and if there is peritonitis, then there will be pain all over the abdomen. Along with that, beta, the patient may have syncopal attack. Okay, suddenly if the patient has an intraperitoneal bladder rupture, the patient may fall down unconscious for some time. That is, the patient will go into syncope, and the patient will have all the other features of peritonitis. That is, a severe acute abdominal pain along with guarding, the cardboard-like rigidity on the abdomen. There will be diffuse tenderness, and the patient may or may not be in shock. These are the features of peritonitis which will be there. Okay, so that is important. If they ask you beta, what is the investigation of choice in the patient, तो याद रखना बेटा, यहाँ पे लिख सकते हो प्लस माइनस शॉक. एज यू नो डेफिनेटली पेरिटोनाइटिस में क्या क्या होता है. ठीक है, इन्वेस्टिगेशन ऑफ चॉइस बेटा, इफ दे आस्क यू, तो याद रखना इन्वेस्टिगेशन ऑफ चॉइस वेदर इट इज अ एक्स्ट्रा पेरिटोनियल ब्लैडर रप्चर और इंट्रा पेरिटोनियल ब्लैडर रप्चर बेटा. द इन्वेस्टिगेशन ऑफ चॉइस हैज टू बी अ CT cystography. What is a CT cystography? We will inject a contrast inside the urinary bladder, and then after that we'll do a CT scan beta. That is going to be called as a CT cystography, which will be the investigation of choice. On that CT cystography beta, you will be able to see the leakage of the contrast from the ruptured part of the bladder beta, and you will be able to assess that how much is the rupture definitely. Okay, what can be the treatment and everything. But beta, if my patient is hemodynamically unstable, that means my patient is in shock beta, obviously in the intraperitoneal bladder rupture na, extraperitoneal mein to patient may not be unstable. So in intraperitoneal bladder rupture beta, when my patient is hemodynamically unstable, in those patients most of the times beta, I cannot go for a CT scan, we know. Therefore we inject a contrast inside the urinary bladder, and rather than doing a CT scan beta, we rather go just for an X-ray, and that is called as a cystogram. Then we just go for X-ray beta known as a cystogram. That's it. Okay. And when I do a cystogram, these are the below given findings beta which are seen. These are the X-rays na. So both of these are cystograms which are given. The first picture which is there beta, you are able to see that here definitely the contrast which is there beta, it is leaking into the into the pelvic cavity. And if the contrast is leaking into the pelvic cavity from the bladder beta, that means here the patient is having an extraperitoneal bladder rupture. And if there is an extraperitoneal bladder rupture, the bladder is going to give us a very classical appearance beta, and that bladder is called as the classical teardrop bladder or teardrop deformity. Okay, so if they ask you beta, teardrop deformity is usually seen on cystogram. In which kind of bladder rupture? The answer has to be a extraperitoneal bladder rupture, shows us the classical teardrop deformity. Next important beta, here you are able to see that the contrast which is there beta, it is leaking out into the peritoneal cavity, and as the contrast is leaking out into the peritoneal cavity, it has to be an intraperitoneal bladder rupture. And in the intraperitoneal bladder rupture beta, if they ask you what is the appearance seen on the cystogram, the cystogram gives a very classical appearance beta, classically called as the sunburst appearance or the sunray appearance. Right here we are able to see the classical sunburst appearance or the sunray appearance beta. Hopefully that's clear to all of you. So sunburst appearance on a cystogram is a feature of intraperitoneal bladder rupture. Now if they ask you what is going to be the treatment in the patient beta, okay, if they ask you what is going to be the treatment in the patient, तो याद रखना treatment के लिए beta, okay, treatment के लिए if they say the patient is having an extraperitoneal bladder rupture beta, if they say the patient is having an extraperitoneal bladder rupture, तो याद रख लो, here we may try inserting a Foley's catheter beta. In clinical practice we may try inserting a Foley's catheter, but whenever you suspect a urethral injury, do not insert a Foley's, because in a suspected urethral injury, if you are trying to insert the Foley's beta, the urethral injury which is there or the urethral rupture which is there beta, it may increase further. ठीक है, तो याद रखना, in only a bladder rupture अगर है तो definitely Foley's can be tried beta. Okay, if there is only a bladder rupture or Foley's catheterization could be tried, but we know that in extraperitoneal bladder rupture beta, there is a very high chance of associated urethral injury. तो याद रखना, whenever there is a suspected urethral injury, beta, directly go for a SPC. The better choice is, exam में बेटा अगर mark करने के लिए आ जाए तो SPC would be a better choice directly to mark, because in most of the cases there is definitely beta a a urethral injury, and that's the reason beta in majority of your exam questions the answer would be suprapubic catheterization or a supracath beta. Okay, so here we insert a catheter to drain the bladder beta, but how we are going to insert the catheter bache? Please remember, we are actually going to insert the catheter beta from the suprapubic region. What we do, we make an incision over here beta, and then with the help of a trocar, and we are going to insert a catheter. Then we are going to remove the trocar, and once that catheter has gone into the urinary bladder, We are going to fix it with the help of sutures beta onto the skin. This is what is called as SPC, that is a suprapubic catheterization, or we call it as a supracath. Do remember that. So supracath is actually considered better beta in patients of trauma, basically in cases of bladder injury, or especially beta whenever the patient is actually going to have what? Whenever the patient is going to have an extraperitoneal bladder rupture. No issues with this. Next important, intraperitoneal bladder rupture. If I talk about beta, if I talk about intraperitoneal bladder rupture, which what has to be done in that cases? Intraperitoneal bladder rupture mein, we have to take up the patient for a surgery because the patient is having peritonitis beta. And as the patient is having peritonitis bache, that's the reason definitely we have to take up the patient for an exploratory laparotomy beta. Peritonitis hai, so we have to clean the peritoneum, that is peritoneal lavage. So exploratory laparotomy with peritoneal lavage. Okay, along with exploratory laparotomy and peritoneal lavage beta, what else we have to do? Apart from exploratory laparotomy and peritoneal lavage beta, I hope all of you are quite aware, we also have to do a bladder repair, right? So bladder repair will be done with the help of sutures beta. And if the bladder has just been repaired beta, obviously you cannot let that bladder get full with urine, otherwise the sutures are going to break. That's the reason beta you have to drain the bladder, and uske liye beta for at least the next 2 weeks beta, or 3 weeks definitely, whatever time the bladder needs to heal. For that definitely beta, we can actually insert a catheter inside the bladder. Catheterization can be done. Now that catheterization depends beta whether we insert a Foley's catheter or the suprapubic catheter. That depends on the extent of injury. Whether if definitely the urethra has also been injured, then better go for a suprapubic. If the urethra has not been injured, better you can go for a Foley's cath. Okay. Hopefully that's clear. This is what is the treatment beta in a patient of an intraperitoneal bladder rupture. Clear to all of you? Now next important beta, what is seen in the next picture? What is definitely seen in the next picture beta? Hopefully all of you have written this. So here beta we are able to see this is nothing else but the Foley's catheter beta in the picture. This is nothing else but the Foley's catheters. Yaad rakhna, as I've told you, that the sizes of the needles and the cannulas are measured in gauge, whereas the sizes of the catheters and the tubes are measured in French beta. Okay, so there are various sizes of Foley's catheter beta. The green one that you are able to see beta, it is a 14 French Foley's, and 14 French Foley's is generally used for a adult female beta. Next, the orange one that you are able to see beta is basically a 16 French Foley's beta, and that 16 French Foley's basically, do remember that, is generally used for an adult male beta. Okay, these black white ones which are there beta, the black, the white, okay, they are around 8 to 10 French Foley's beta, and they're generally used for the pediatric population. These 8-10 French Foley's which are there now, they're generally used for the pediatrics, smaller sizes. And this is the three-way Foley's beta, the last one that you are able to see. अब ये three-way Foley's क्या होता है? Normally the Foley's has two ports beta. How? For what reason? Understand. This is the main port beta where you have to connect the uro bag and from which the urine is going to come outside beta. Okay, and this is another port beta. Once you have inserted the Foley's completely, you have to inflate the balloon of the Foley's beta with the help of 10 cc of normal saline over here, at least 10 to 15 cc of normal saline, so that the balloon gets inflated, and then when you try to pull out the Foley's does not come out, the Foley's gets fixed inside the bladder. Yes, I've told you in ET tubes and tracheostomy tubes beta, the cuff which was present over there, the cuff ka function was just to prevent an aspiration, not to fix the tube. Here beta in Foley's, the cuff ka function is definitely to fix the Foley's catheter. Clear, but that is important. You have to take some lignocaine jelly, coat this end of the Foley's properly with lignocaine jelly, or you can inject 10 cc of lignocaine beta into the patient's urethra, and then you can definitely start inserting the Foley's easily. Once the Foley's goes completely inside the urethra beta, then definitely you are going to check if the urine is coming outside or not. Please connect a urobag first, otherwise you will get that prashad completely. Okay, and then once the urine starts coming outside, you can definitely fix the Foley's by injecting 10 cc of normal saline over here. Three-way Foley's mein, what is the third port for? This third port which is there beta, it is actually from here the normal saline can go inside the urinary bladder. Why? Because if the normal saline goes into the bladder and it is going to wash the bladder and is going to come out from the send, right? That is important beta. So actually the three-way Foley's which is there, it is used for the purpose of bladder wash beta. It is used for the purpose of bladder wash or bladder irrigation के लिए we have to use the three-way Foley's. Clear? That is important beta to be remembered. Next, if I talk about beta, this picture which is there over here, this is actually a picture of a supracath, that is a suprapubic catheterization. Okay, this is the picture of a suprapubic catheter beta, you are able to see. Okay, and this supracath which is there beta, it is done like this, it is inserted like this. You can definitely insert a needle beta first, and you can see definitely you are able to aspirate the urine or not. Okay, that means the bladder is full, and in only a full bladder beta you should insert a supracath, otherwise there will be injury to the other organs. Okay, then definitely once the bladder is full, you can insert this trocar beta by making an incision in the suprapubic region. You have to insert the trocar first at 60-degree angle, 60 to 90-degree angles by, and once you definitely insert this trocar beta, once the trocar has gone inside, you are going to remove the trocar and only the catheter will be left in place inside the urinary bladder. This is how you insert the supracath or the suprapubic catheter. Another condition beta, previous year question of your examination, this has come earlier. What is this condition called as? यहाँ पे याद रखना बेटा, the anterior abdominal wall which is there, it is absent, and as the anterior abdominal wall is absent beta, the bladder has been exposed to the external environment. Can you see the urinary bladder of the baby which is there beta, it is exposed to the external environment. This condition, when the bladder is exposed outside, is classically called as ectopia vesicae beta. This condition is known as ectopia vesicae, aka also known as extrophy of bladder beta. Just remember, spot diagnosis of this condition ka. This is actually called as ectopia vesicae beta, also known as the extrophy of the bladder. No issues with this, anybody? That is important. That is important beta. So ectopia vesicae, also known as extrophy of the bladder beta, very important spot diagnosis has been given in your examination. Now this condition here, as I've told you beta, the abdominal wall of the patient is absent over the bladder, and therefore the bladder is exposed. यहाँ पे beta, the patient is going to have a problem that the pubic bones which are there beta, they are not fused with each other. When the pubic bones are not fused with each other beta, that problem which is there is called as a pubic diastasis. That problem is known as a pubic diastasis, for which you do a ileostomy later. Okay, it is an iliac osteotomy basically. You cut the iliac bones and then you fuse them. That is what is done basically beta. This condition which is there, it is also associated with some other disorders also. And what it is associated with, it is either associated with beta undescended testes in males, okay, undescended testes in males, or absence of fallopian tubes in females. Okay, undescended testes in males or absence of fallopian tubes in females beta. That is the condition which may be associated with the ectopia vesicae or the extrophy of the bladder. Clear about? That is important to be remembered. The next condition that you are able to see on the cystogram beta, the next condition that you are able to see on the cystogram, this picture out here is classically called as, here the shape of the bladder on the cystogram beta you are able to see, it looks like which tree? It looks like a Christmas tree beta, or a fir tree basically. This Christmas tree or a fir tree like appearance in the bladder beta is classically called as a neurogenic bladder. Now when the bladder is not able to contract beta, okay, or the tone of the bladder has been completely lost, that condition is known as a neurogenic bladder or an atonic bladder, where the bladder muscles are not able to contract. If the bladder muscles will not be able to contract beta, there will be severe retention of urine, and that retention of urine which is there beta, it leads to this condition known as the neurogenic or an atonic bladder beta. Very good, where definitely you are able to see the classical appearance on the cystogram. And yaad rakhna hai beta, this classical appearance on the cystogram is known as the Christmas or the fir tree appearance. I hope all of you are quite aware what is the drug which is given beta for a neurogenic or an atonic bladder. For a neurogenic or an atonic bladder beta, we need to give a drug which is going to help the detrusor muscles of the bladder to contract properly, and that drug of choice is known as a bethanicol. That drug which you will give in pharma, you might have studied bethanicol in neurogenic bladder or atonic bladder. No issues with this, anybody? Chalo. So that is important beta. The picture which is there, it is a cystogram, because on that I am able to see a contrast in the bladder itself. Next condition beta, if I talk about, is nothing else but a bladder diverticula beta. If I talk about a bladder diverticula, what is a diverticula? We know beta, diverticula is nothing else but an outpouching beta. Okay, diverticula which is there, it is nothing else but an outpouching. So for example, there was a severe retention of urine in the urinary bladder beta, like in patients of BPH. Okay, in patients of BPH beta, they are not able to pass the urine. Therefore, there is too much of retention of urine inside the urinary bladder. The pressure in the urinary bladder increases too much, and that's the reason beta, the patient may develop a urinary bladder diverticula also. Okay, When the patient has a urinary bladder diverticular, na, there's a very classical feature beta. And what is that classical feature? Understand. So whenever the patient will go to pass the urine beta, what happens basically? Okay, whenever the patient goes to pass the urine beta, the patient usually passes the urine. Whatever urine was present inside the urinary bladder beta, it will be passed out. So definitely now the urinary bladder of the patient is empty, right? So all the urine from the urinary bladder which is there beta, it will be passed out. But the problem is what beta? There will be some still urine left inside the outpouching of the diverticular. There will be some still urine left inside the outpouching of the diverticular. Now what will happen? This patient will come back from the bathroom, and the patient will come back from the washroom, and the patient is going to lie down. As the patient lies down beta, all this urine again comes back into the bladder. All this urine comes back into the bladder, and now again the patient has a urge to urinate beta. Immediately the patient has to urge to urinate. Again वापस उसको लगता है कि वापस washroom जाओ. That is a classical feature beta that is seen in a patient of a bladder diverticular. Clear? That is important. So please remember, bladder diverticular which is there beta, it is nothing else but an outpouching from the urinary bladder. Okay, outpouching from the bladder wall is what is called as the bladder diverticulum. In this condition beta, it can be either congenital or it can be acquired also beta. The bladder diverticular which is there, it can be congenital also or it can be acquired also beta. It can be congenital, it can be acquired. So please remember, if I talk about the congenital bladder diverticular beta, so it is basically due to what? It is due to beta. Anybody? It is due to the persistent urachus. Now what is urachus? Understand beta. Yaad rakhna, I hope all of you are quite aware beta that in the fetal life bache, the urinary bladder and the umbilicus actually has a connection with each other. And the connection between the umbilicus and the urinary bladder beta during the fetal life is known as the urachus, also known as the allantois beta. This connection between the bladder and the umbilicus beta is known as the urachus or the allantois basically. Now please remember, this urachus should disappear after birth. But in some patients, if this urachus does not disappear, so what can happen? The urine start coming out from the umbilicus. Previous year FMG question. In the NICU, when the pediatrician was examining the baby, there is urine coming out from the baby's umbilicus. What is the likely diagnosis? Okay? Or what is the likely embryological structure patent? So, yaad rakhna beta, in this condition, you can see that the urachus or the allantois of the patient has not closed. That's the reason beta, the patient is actually having urine coming out from the umbilicus. This is called as a urachus fistula. Why fistula? Two-way connection is there. So urachus fistula means the urine comes out from the umbilicus. But just like that beta, if urachus undergoes a partial fibrosis, matlab some part of the urachus disappears or it closes. So beta, you will be able to see that some part which is related to the urinary bladder, it is still there beta. And that leads to formation of a diverticulum beta. Okay, that is known as a urachus, that is known as a congenital diverticulum. So congenital diverticular beta in a patient of bladder is due to a persistent urachus. If some part of the urachus does not disappear, it remains as an outpouching beta, and that leads to a bladder diverticular. Next, acquired bladder diverticular beta, it is due to pulsion. What is a pulsion diverticular? I have told you. Pulsion diverticular is that beta which happens due to increased pressure. So if there is an increased intravesical pressure beta, that is increased pressure inside the urinary bladder due to severe retention of urine, as seen in patients of BPH beta, I have told you, the patient may develop a acquired bladder diverticular beta, and therefore it will be called as a pulsion diverticular because it is due to excessive pressure. Important is what can be the symptoms in the patient. As I told you, the patient may have an increased frequency of urination beta. The patient may have an increased urinary frequency or increased micturition frequency. Reason, this bladder diverticular can actually keep on compressing against the bladder wall, and therefore the patient will have an increased frequency of micturition. The patient will have a risk of UTI because that urine which is collected inside that outpouching may get infected. Now here, very classical finding, as I told you, what is that? Patient passes the urine beta and the bladder is empty. But as soon as the patient comes and lies down, that means if there is a change of posture. On change of posture beta, it again leads to an urge to urinate. Again the patient has an urge to urinate immediately. That is what is classically called as beta a finding of bladder diverticulum. Okay? If they ask you what can be the complications, so do remember beta, the complications of bladder diverticular could be the patient may have a high risk of stones, urinary stones. Patient may have recurrent UTIs. There can be obstruction, or the patient may develop a urinary bladder cancer also. We can go for an ultrasound KUBP beta. I hope all of you are quite aware. KUBP matlab kidney, ureter, bladder, okay, and prostate basically. Ultrasound KUBP could be done. And when we do a ultrasound KUBP or KUB beta, on that you are able to see classically This is the picture beta. This is the main urinary bladder, and from that main urinary bladder you are able to see beta an outpouching, okay, which is formed. That is classically called as a bladder diverticulum. So either I can go for a ultrasound KUBP, or even beta to confirm further we can go for a cystogram beta or a CT cystography, because on that cystogram also that you will be able to see that the contrast is filled up inside an outpouching, and that is what is a classical case. Okay. Treatment, if they ask you, nothing else but beta removal of the diverticula has to be done. And removal of diverticula, I hope all of you are quite aware, should be called as a diverticulectomy. So we have to do a diverticulectomy with repair of the bladder, right? We have to do a diverticulectomy beta with repair of the bladder wall. That has to be done. Now let's talk about the next topic beta, and that is again trauma itself. That is nothing else but urethral rupture beta. So let's talk about urethral rupture now. If I talk about urethral rupture beta, hopefully all of you have written. Now, if I talk about urethral rupture in a patient, yaad rakhna, urethra which is there beta, I hope all of you are quite aware. In a male urethra, there are two parts mainly. The posterior urethra, which is in the pelvic cavity near to the bladder, which has two parts, prostatic and membranous. The anterior urethra, which is more exposed outside beta, one part is in the perineum called as a perineal or the bulbar urethra, the one in the penis called as the penile urethra, right? We know that as the anterior urethra is more exposed outside beta, that's the reason it is at a higher risk of injury beta. Okay, so anterior urethral rupture is going to be more commonly seen than the posterior urethral rupture. Yes, if they say pelvic trauma or pelvic fracture beta, so obviously beta we know which urethra lies in the pelvis, it is the posterior urethra. So pelvic fracture में या pelvic trauma में, if they ask you which urethral rupture is common, then it is going to be the posterior urethral rupture, but overall more common anterior one. Clear है बात? So याद रखना urethral rupture which is there, what will be the classical features in this patient? If the urethra of the patient has been ruptured beta, obviously the patient will have leakage of urine, and that's the reason the patient may not be able to pass the urine. There is inability to pass the urine beta, first feature. Okay, the patient may have inability to pass the urine. Second important beta, the patient may have blood at the tip of the external urethral meatus. The patient may have blood at the tip of the external urethral meatus. Reason beta, there is bleeding from the urethra. That is what is suggestive from the blood at the tip of the external urethral meatus beta. Next, the patient may have bleeding around the urethra also beta. If the posterior urethra is ruptured, the patient will have a pelvic hematoma which develops, and if the anterior urethra is ruptured, the patient may have a perineal hematoma which develops. Clear about? So either the patient will have a perineal, okay, the patient will have a perineal or a pelvic hematoma beta. The patient will have a perineal or a pelvic hematoma, okay, depending on the site of rupture beta. Now if they ask you which urethral rupture is common, as I've told you beta, more common is going to be the anterior urethral rupture. And in anterior urethral rupture beta, if they ask you that which is going to be the more common part to be ruptured, yaad rakhna, in anterior urethral rupture beta, the most common part that undergoes a rupture basically is going to be, anybody, whether it will be the penile or the perineal. So please remember, we know that the penile is more exposed, but still beta, that penile is at least surrounded by what? The penis. So therefore it is protected. But perineal jo hota hai beta, perineal is very superficial. It is just lying in the perineum. So if there is any kind of injury to the perineum beta, the patient's perineal urethra will get ruptured easily. So the most common site of injury in the anterior urethra has to be the perineal or the bulbar urethra beta, right? The perineal or the bulbar urethra which is there, it is going to be the most common one to get ruptured. That is important. Apart from that beta, if they ask you basically that it occurs due to, we know beta, if perineal urethral rupture is happening, it occurs due to a perineal trauma. Now what kind of perineal trauma? For example, you're walking by the road beta, and definitely you see a beautiful girl, you definitely look over there beta, and you keep on walking. Obviously what is going to happen, you will step on a loose manhole cover beta, and as you step on that loose manhole cover, that manhole cover exactly goes beta and hits your perineum in between the two legs. Okay, this manhole cover, it actually goes exactly beta and hits your perineum in between the two legs. This is what is called as a perineal trauma beta. Okay, this picture has been given in your exam earlier, and they asked in this kind of injury which urethral rupture will be more common. So answer is very easy, it is the perineal or the bulbar urethral rupture which is more common, because here we are able to see the perineal trauma beta. Or definitely they can also give you a history of this kind of a injury beta when the patient is traveling by the bicycle that has a rod. Again, the patient has no attention and therefore is suddenly applies brake. And now again the patient is going to have beta a perineal trauma. Why? Because the patient usually falls exactly on the rod beta. Okay, and the rod usually hits the perineum of the patient. Okay, so that is important. So anterior urethral rupture or the perineal urethral rupture beta, it occurs due to a perineal trauma, like in a case of a bicycle accident or due to loose manhole covers beta. Either due to bicycle accidents or due to loose manhole covers. Clear to all of you? Now important is beta, if they ask you what is going to be the sign बच्चे, तो याद रखना है the sign which is there beta is going to be a classical butterfly hematoma beta. The patient is actually going to develop a classical butterfly hematoma. That butterfly hematoma is nothing else but a perineal hematoma which develops. Right, in this patient beta, there is going to be the classical butterfly or the perineal hematoma which develops. Okay, here you are able to see beta. Can you see this butterfly hematoma in the perineum of the patient? So whenever the patient has a perineal injury without a perineal urethral rupture, the patient has the classical butterfly hematoma or the perineal hematoma. Now another question, that where there is collection of urine beta, if the anterior urethra undergoes rupture, which are the sites where there can be urine collection? This was a previous year question. Can anybody tell me that? The question is, in a patient of an anterior urethral rupture, there will be collection of urine or extravasation of urine in all the below given sites except option 1, superficial perineal pouch, option 2, deep perineal pouch, option 3, anterior abdominal wall, option 4, scrotal sac. Okay, so what is your answer? Definitely. Okay, in which there will be no fluid, no urine collection in anterior urethral rupture beta. याद रखना बेटा कहाँ कहाँ होता है urine extravasation. You can write over here. Urine extravasation, very common question of surgery and anatomy. Urine extravasation in anterior urethral rupture happens basically, and the answer is deep perineal pouch beta. याद रखना, except the deep perineal pouch there will be collection of urine everywhere. ठीक है, तो याद रखना है बात. So please remember definitely beta, it is the deep perineal pouch where there is no urine collection in the perineal urethral injury beta. In the posterior urethral injury there can be collection of urine in the deep perineal pouch. ठीक है, तो यहाँ पे there is urine collection beta in the superficial perineal pouch. Okay, there is urine collection beta in the superficial perineal pouch. To solve PYQs beta, that's an important thing now to remember. ठीक है, if you're not knowing the answers for the questions that I'm asking alongside, your all subjects are done. अभी तुम बहाना नहीं दे सकते कि we are not knowing the answers. ठीक है, तो please remember beta, this has been a question of anatomy previously multiple times. ठीक है, so make sure that you are revising other subjects also and you are doing a lot of PYQs at least and reading their explanation, not rattafying their answers. Please remember that PYTs are important than PYQs. Next important beta, apart from superficial perineal pouch, is the anterior abdominal wall, because it is also connected with the superficial pouch beta. ठीक है, anterior abdominal wall, it can be the scrotal sac बच्चे. ठीक है, so these are the definitely sites beta where there can be collection of urine beta. ठीक है, superficial perineal pouch, anterior abdominal wall, scrotal sac. Okay, these are going to be sites, and even the inner thigh for that matter. Even the inner thigh can be the site beta where there can be urine collection over here. Okay, but not in the deep perineal pouch beta. Next important, if there is a posterior urethral rupture beta, agar if there is a posterior urethral rupture in the patient, what I have to do? So posterior urethral rupture mein the more common site beta among the prostatic and membranous, the more common site definitely is the membranous urethra which undergoes rupture. Among the posterior urethra, it is the membranous urethra beta which undergoes rupture more commonly. No issues with this. Clear to all of you? Next important beta, if they ask you the posterior urethral rupture, okay, is more commonly going to be in the membranous urethra, and it occurs due to, it occurs due to the pelvic trauma in the patient. Okay, it usually occurs due to the pelvic trauma in the patient beta, that has to be remembered. And here, what is the reason? Definitely due to pelvic trauma beta, the patient has a pelvic fracture, and due to that pelvic fracture, I've told you, the patient will have a bladder rupture also, extraperitoneal bladder rupture, and along with that a posterior urethral injury as well. Okay, so pelvic trauma, and pelvic trauma we know beta, pelvic trauma or pelvic fractures cannot occur after just a normal fall. They will only occur after a severe trauma beta, like a road traffic accident, right? Because pelvic bone is a very strong bone of your body. Road traffic accidents के बाद it will be seen. Sign if they ask you, here there will be collection of blood beta in the pelvic region, not in the perineal. So here the patient is actually going to have a pelvic hematoma. The patient is actually going to have a pelvic hematoma over here. On examination beta, if they ask you on digital rectal examination, what you will be able to see. So yaad rakhna beta, see. Here we know that, for example, beta, we have the prostatic urethra and this is the membranous urethra beta. Okay. Now what is going to happen, definitely, as there is a lot of blood collection around the urethra beta, as there is a lot of blood collection in and around the urethra, what is going to happen, the urethra which is there, it is going to get lifted up. And if the urethra is going to get lifted up, even the prostate which is there beta, it will get lifted up also due to that hematoma which is formed over here. So when we do a digital rectal examination, when I do a DRE or a digital rectal examination, I will feel the anterior wall of the rectum, and on that anterior wall of the rectum beta, I will be able to feel or assess the prostate gland. But in this patient beta, as there is a lot of hematoma over there, I will be able to feel that the patient's prostate has been lifted up. That is called as either a high riding prostate or a floating prostate beta, right? Because there will be a lot of hematoma below the prostate gland, okay, or the prostatic urethra. Therefore, on digital rectal examination, I'm not able to feel the prostate properly. That is called as a high riding prostate or a floating prostate, and that is classically called as which sign? Vermeulen sign beta. This is classically known as the Vermeulen sign. Now, if they ask you what is going to be the investigation of choice, yaad rakhna, the investigation of choice in the patient has to be a RGU. What is RGU? Retrograde ureterogram. I've told you now that definitely beta, for a urethra, the best study which is there, contrast study, is going to be a retrograde ureterogram. So here you have to do a retrograde ureterogram beta, and when we inject a contrast inside the urethra beta, we will be able to see from where the urethra has been ruptured now, from that side definitely the urine has started leaking out. From that side definitely, sorry, the contrast has started leaking out. Okay, from wherever the urethra has been ruptured, definitely from that side beta, the contrast will be leaking out, and then you can definitely assess it properly. See, this is the retrograde ureterogram. They also ask you beta that definitely which site is ruptured just by a RGU. You might have studied that in radiology also, because this is a common question of radiology as well. ठीक है, अब ये देखो, ये क्या दिख रही है तुम्हें? ब्लैडर दिख रहा है, right? This is basically the urinary bladder that we are able to see. This is the part where there is the bladder neck. Now, so this part which is there beta is going to be what? This part is going to be the prostatic urethra. So what is this part going to be? Membranous urethra. So here there is rupture in which urethra beta? Membranous urethra. This part is going to be the perineal urethra, and the last one is going to be the perineal or bulbar urethra, and the last one is going to be the penile urethra, right? So definitely beta, these are the various parts of the urethra. So here you are able to see the rupture beta in the membranous urethra. Okay, solve these questions a lot of times, definitely similar kind of questions, you will definitely be able to assess that where there is exactly the rupture beta. Okay, you have to see definitely where is the bladder, okay, and then according to that you can easily assess. Okay, कौन से part में there is a rupture. Now if they ask you about the treatment beta, so do remember the treatment which is there in this patient. In emergency, what we have to do? In emergency beta, we can actually insert a Foley's catheter in this patient. Reason, definitely in this patient beta, if you insert a Foley's catheter, you are able to drain the urine. But the problem is, if you try to insert the Foley's, okay, that may extend the urethral rupture. That's the reason beta, we do not take that risk. So better than inserting Foley's, directly go for inserting a catheter inside the patient's urinary bladder, and that is called as a suprapubic catheter insertion or a suprapubic catheterization. So here beta, to drain the urine, because as the urethra has been ruptured beta, therefore the patient is not able to drain the urine. The patient is having a severe urine retention, so therefore we have to drain the urine, and for draining that urine beta, we definitely have to insert a catheter inside the patient's urinary bladder. But we cannot go for a Foley's. Reason is that Foley's may actually extend the injury beta. You can write down, okay, Foley's के साथ what is the risk beta? Foley's may, okay, Foley's may definitely extend the injury or extend the rupture basically beta. That's the reason it is usually avoided. That is the reason it will be usually avoided. Now, apart from that beta, this is the emergency management just to drain the urine. After that, what we have to do? Obviously, we have to do a urethrotomy beta. Okay, we have to either do a urethrotomy or a urethroplasty. Okay, we can repair the urethra, but beta, that is only required in some cases. If it is a only minor trauma, if it is only a minor rupture beta, it will heal on its own. You just definitely keep the catheter over there itself. The urethra is going to heal on its own. But if does not heal, then either I have to go for a urethrotomy beta, or that is suturing it properly beta, that is closing the urethra, or I have to go for a urethroplasty, that is repairing the urethra. Okay, so that could be done. No issues with this. Here I can do a urethral repair beta with the help of a graft also at times. Okay, strictures में urethral strictures में beta definitely the graft would be required as well. Here also graft will be required at times. Okay, so that is all about your urethral rupture. Okay, so hopefully you need a lunch break now, otherwise I can continue further, but let's take a lunch break, and after the lunch break let's continue further. Okay, after the lunch break we'll talk about the other topics. Okay, so mostly likely, if after the lunch break we are able to complete urology, let's take a large session and complete urology, and then take a longer break if you want, and then we'll start with hernia. ठीक है, ऐसा कर सकते हैं, because only 13 pages are left, so most likely let's see how it works. ठीक है, because some topics are very easy after this.